Ok, neka stoji sad tako. Da, da, da. Poštovane koleginice i kolege, dame i gospodo, pre nego što počnem, želela bih da se zahvalim princezi Katarini koja me ljubazno pozvala da učestvujem na ovoj značajnoj konferenciji. Princeza Katarina je inače pre nekoliko godina, kada sam ja bila direktor Instituta za mentalno zdravlje, pomogla institutu donacijom preko njene Lifeline fondacije i zahvaljujući toj pomoći mi smo izgradili jednu novu salu za predavanja, čuvenu plavu salu u institutu. Let me say it in English. Before beginning, I would like to warmly thank Princess Catherine, Her Royal Highness, who kindly invited me to participate in this important conference. I would also like to express my gratitude and the gratitude of my colleagues to Princess Catherine and her Lifeline Foundation because she helped us to build a new hall for lectures, famous Blue Hall at the Institute, and in front of the Blue Hall there is a table showing gratitude to Her Royal Highness Princess Catherine. Da bih ispunila svoj današnji zadatak, a zadatak mi je da govorim o zaštiti mentalnog zdravlja u Srbiji, o izazovima i rešenjima, ja sam zamislila da govorim o značaju mentalnog zdravlja i o mentalnim poremećajima, zatim o problemima i izazovima sa kojima smo se susretali i susrećemo se, o mentalnim poremećajima u Srbiji, pokazat ću i primere naše dobre prakse, govorit ću o novim izazovima sa kojima smo suočeni i na kraju pomenut ću perspektive, odnosno kako ja vidim buduće korake u zaštiti mentalnog zdravlja u Srbiji. U manifestu Kraljevskog koledža psihijatrije iz Velike Britanije rečeno je da 1 od 5 majki ima depresiju, anksioznost ili psihozu za vreme trudnoće ili u toku prve trudnoće, u toku prve godine posle porođaja, što je veliki broj. Rečeno je također da 1 od 10 dece od 5 do 16 godina ima probleme mentalnog zdravlja, a 1 od 6 odraslih neki mentalni poremećaj. 1 do 2% odraslih ima ozbiljnu psihijatrijsku bolest. U ovom manifestu Kraljevskog koledža psihijatara naglašava se da je mentalno zdravlje podcenjeno i zanemareno i da je podrška osobama sa problemima mentalnog zdravlja svuda nedovoljno finansirana i procenjena. I tako je na ministarskom sastanku održanom 2014. godine u Evropskoj uniji rečeno, zaključeno da je mentalno zdravlje pepeljuga zdravstvenog sistema. Samo 1 od 3 osobe dobijaju tretman. A šta je cilj? Cilj je jednaka i dostupna zaštita mentalnog zdravlja osoba sa mentalnim poremećajima. Pre neki dan u najvažnijem psihijatrijskom časopisu World Psychiatry, koji ima ogroman impact faktor blizu 80, pročitala sam rad holandskih autora koji je, znači, objavljen pre neki dan u junu, prikazujući Nemezis studiju, Netherland Medical istraživačku studiju, koja je urađena na velikom uzorku, reprezentativnom uzorku od više od 6000 ispitanika. I ova velika studija pokazala da u toku života poremećaj raspoloženja, takozvane afektivne poremećaje ili ono što je poznato kao depresija i bipolarni poremećaj, ima skoro polovina populacije. Znači u toku života polovina populacije razvije poremećaj raspoloženja, zatim razvijaju se u značajnoj meri anksiozni poremećaj i zloupotreba supstanci i ADHD, odnosno Attention Deficit Hyperkinetic Disorder, poremećaj pažnje i pokreta. Ono što je međutim zanimljivo, što su kolege zaključile, je da nije bilo značaja u prevalenciji mentalnih poremećaja pre i posle pandemije COVID-19. A koji su izazovi sa kojima se naša zemlja susretala, suočavala poslednjih godina, koji su uticali na mentalno zdravlje? Najpre bih rekla, pošto ću govoriti o stresu kao jednom od značajnih faktora rizika za mentalno zdravlje, da stres ima mnoga lica. Evo ovde sam prikazala Boga Janusa koji ima dva lica. Pa stres može biti dobar, takozvani eustres. Ja sam sad pod jednom vrstom eustresa kada se obraćam vama, ali može biti i loš stres i distres. I ja ću pokazati sa kojim distresom smo se mi suočavali poslednjih godina. Pre toga pokazat ću da smo objavili mnoga lica stresa, kao što vidite ovdje je naznačeno, u jednom dvotomnom udžbeniku američkom, koji se zove Personality and Individual Differences, ima 2 toma i objavila ga je čuvena izdavačka kuća Sage 2019. godine. I zaista stres može imati mnoga lica. A kako deluje stres i kakav je on faktor rizika? Stres može izazvati bolest. Bolest dovodi do sniženja kvaliteta života, sniženi kvalitet života dovodi do dodatnog stresa i tako se stvara začarani krug. Jedna velika kolaborativna studija Svetske zdravstvene organizacije na više od 5000 ispitanika pokazala je da psihološki distres je povezan sa somatskim simptomima, može izazvati i somatske poremećaje i za to postoje jasna naučna objašnjenja. Dalje, ova studija je pokazala da distres, loš stres, je uzrok smrti u 70 do 80% slučajeva u razvijenim zemljama, a u 40 do 50 slučajeva u zemljama u razvoju. A kakve su naše iskustva? Koje su bile sve godine stresa kroz koje smo mi prošli? Naš narod je doživao mnogobrojna traumatska iskustva zbog ratova u okruženju, mnogih ljudi koji su bili izloženi torturi. U jednom trenutku bilo je mnogo izbeglica i raseljenika, takozvanih interno raseljenih lica, oko 700.000 u Srbiji. Sankcije Ujedinjenih nacija trajale su 3,5 godine, zabranile su čak i naučnu saradnju i objavljivanje radova u naučnim časopisima. Kao što bombardovanje je trajalo 78 dana. Prolazili smo i prolazimo i dalje kroz socijalnu tranziciju, doživljavali smo godinama i doživljavamo politički kovitlac i ono sa čim se dalje suočavamo je takozvana brain drain, seoba mozgova, kako sam ja to prevela, ili depopulacija, i ovde sam prikazala izbeglice iz Krajine u toku Oluje i čuvenu Gerniku Pabla Pikasa, koji sam i videla u muzeju Reina Sofia u Madridu. Picasso je naslikao čuvenu Gerniku posle bombardovanja ovog grada, njegovog grada 1937. godine. A koje su posljedice godine stresa kroz koje smo prošli? U toku tih godina mi smo se bavili, osim što smo pomagali osobama koje su pod stresom, koje su doživjele teška iskustva, mi smo radili i veliki broj istraživanja. Ispitivali smo prevalenciju posttraumatskog stresa kod izbeglica u okviru jedne međunarodne evropske multicentrične studije koja je nazvana STOP, zatim kod žrtava torture, kod seksualno zlostavljanih žena i kod zdravih osoba. Ispitivali smo komorbiditet, odnosno udruženost psihičkih i somatskih poremećaja, mentalnih i somatskih, zlostavljanje dece i kvalitet života. Ispitivali smo posttraumatski stres i ličnost, posttraumatski stresni poremećaj u opštoj populaciji u okviru studije koje je nazvala simbolično Connect da bi povezala zemlje u regionu, koja je bila multicentrična evropska studija. I najzad ispitivali smo i posttraumatski stres i plastičnost hipofizno-pituitarne adrenalne osovine u okviru projekta Srpske akademije nauka i umetnosti kojoj ja pripadam. I kakvi su rezultati? Naši rezultati su pokazali da 29% izbjeglica, kada smo ih mi ispitivali, imalo je posttraumatski stres. 56% seksualno zlostavljanih žena, i to nije čudno, to je procenat koji se nalazi u literaturi u celom svetu. 75% žrtava torture su imali ovaj poremećaj, što također nije čudno, ali je bilo zanimljivo i čudno da je 11% zdravih studenata imalo znake posttraumatskog stresa. I nije čudno da je kvalitet života bio snižen u svim životnim domenima. A kakav je bio posttraumatski stres u opštoj populaciji? Kao što sam rekla, mi smo učestvovali u jednoj velikoj multicentričnoj evropskoj studiji koja je ispitivala posljedice stresa u svim zemljama u našem regionu, u 8 zemalja. I šta je studija pokazala za Srbiju? Skoro 19% ispitanika u opštoj populaciji, to je bio reprezentativni uzorak slučajnog izbora, imalo je znak posttraumatski stresni poremećaj. Međutim, 32% je imalo znake životnog, takozvanog lifetime posttraumatskog stresa. Depresija, koja je inače svuda u svetu jedan od vodećih uzroka tereta bolesti, bila izražena kod 26, znači više od 1/4 naših ispitanika. Dalje, po redu je bila anksioznost, nasilje u porodici i zloupotreba supstanci. A što je pokazalo istraživanje u primarnoj zdravstvenoj zaštiti u okviru međunarodne 10. klasifikacije mentalnih poremećaja? U primarnoj zdravstvenoj zaštiti najizraženiji su poremećaji raspoloženja i dalje neurotični i sa stresom povezani i somatoformni poremećaji mentalni koji se izražavaju preko telesnih tegoba. A koji su faktori rizika za posttraumatski stres? Uvek se postavlja pitanje ko razvija posttraumatski stresni poremećaj i zašto. Svi smo doživjeli bombardovanje, svi smo doživjeli ovu majsku kolektivnu traumu koju ću pomenuti pri kraju. Neki dožive posttraumatski stres, a ne. Da li je pretraumatska vulnerabilnost, osetljivost, slabost ličnosti najvažnija? I koji su psihološki mehanizmi koji su medijatori patoloških odgovora? To su bila pitanja koje su nama bila zanimljiva i koje smo istraživali. I zaključili smo da faktori ličnosti povećavaju rizik za razvoj mentalnih poremećaja, ali također mogu biti protektivni i štititi osobu i učiniti ono što se naziva rezilijentnost, tako da neke osobe i najveći broj ne razvije ove poremećaje. I mi smo to i objavili u časopisu Journal of Personality Disorders. A sva ova iskustva i istraživanja objavili smo na mnogo mesta. Evo ja ovdje pokazujem poglavlje koje se zove Srpsko iskustvo, koje smo objavili u knjizi Katastrofe i mentalno zdravlje Svetske psihijatrijske asocijacije, u kojoj sam ja aktivna veliki broj godina i koji je objavio američki izdavač Wiley. Dalje objavili smo poglavlje koje smo nazvali Spirala stresa i posljedice u knjizi Katastrofe, mentalno zdravlje, kontekst mentalnog zdravlja i odgovori. Kao što možete vidjeti, jedan od urednika ove knjige sam i ja. Kakve su posljedice i zaštita mentalnog zdravlja također smo objavili u 2 oksfordska udžbenika. Prvi udžbenik, odnosno to je moj već 3. udžbenik, ali 2020. godine objavili smo poglavlje izbjeglice, migranti i oni koji traže azil i njihova iskustva u oksfordskom udžbeniku migrantske psihijatrije. Ovo poglavlje je napisano po pozivu, kao i drugo poglavlje koje je objavljeno u oksfordskom udžbeniku socijalne psihijatrije prošle godine. U našem poglavlju pisali smo o zaštiti mentalnog zdravlja u istočnoj Evropi i Balkanu. Ja još uvijek imam ulogu predsjednika Psihijatrijskog udruženja Istočne Evrope i Balkana. Kakvi su problemi kada govorimo o zaštiti mentalnog zdravlja u Srbiji? Oni su veliki, postoje, kao što sam rekla na početku, u skladu sa manifestom Royal College-a, nedovoljno učešće primarne zdravstvene zaštite. Svi pacijenti moraju se prvo javiti primarnoj zdravstvenoj zaštiti, međutim, primarna zdravstvena zaštita nedovoljno učestvuje u lečenju pacijenata. Vidite, skoro 40%, samo 40% se javlja našim lekarima opšte medicine kada ima neke mentalne probleme. Dalje, imamo mali broj centara za zaštitu mentalnog zdravlja u zajednici i takozvane kuće na pola puta ili rezidencijalne domove za osobe koje imaju teške mentalne poremećaje. Pored toga, tercijarne službe, to su instituti, univerzitetske bolnice su dominantne. Ovo s jedne strane nije dobro, ali je dobro jer naše tercijarne ustanove, institut u kojem sam ja bila direktor do pre 4 godine, imaju otvoren pristup, tako da pacijenti mogu da dođu sa uputom, da se jave i da odmah budu uključeni u neki vid pružanja pomoći, što na zapadu, u zapadnoj Evropi nije slučaj. Međutim, zaštita mentalnog zdravlja u našoj zemlji ima i mnogobrojne prednosti. Naš kadar je veoma dobro edukovan. Zatim postoji ravnomerna teritorijalna pokrivenost u hospitalnim ustanovama, psihijatrijska odeljenja u opštim bolnicama, svim opštim bolnicama postoji i kada smo započeli reformu pre 10 godina u Srbiji, bio je mali procenat u velikim bolnicama na početku te reforme. Te godine, kada smo započeli reformu, bilo je 3.500 pacijenata u velikim bolnicama. Za razliku od, recimo, Švedske, u kojoj na početku reforme psihijatrijske zaštite bilo je 20.000 pacijenata u velikim bolnicama. I kako smo se suočili sa izazovima i koji put ka rešenjima je bio? Ovaj put je naravno nezavršen, on je dug i još traje, ali mi smo uradili razne stvari. Bili smo uključeni u partnerstvo za mentalno zdravlje, u pakt stabilnosti jugoistočne Evrope i Balkana i u ovaj pakt uključeno je 9 zemalja, sve zemlje bivše Jugoslavije, uključujući i Albaniju i Moldaviju. Cilj ovog partnerstva je bio da se napravi dugotrajna sveobuhvatna strategija prevencije konflikta. To je bio put ka pomirenju i kao razrešenju konflikta. I u okviru ovog pakta mi smo radili projekt o mentalnom zdravlju, čiji naziv je bio jačanje socijalne kohezije preko osnaživanja službi za mentalno zdravlje u zajednici. I sve je odvijano pod pokroviteljstvom Svetske zdravstvene organizacije. Cilj pakta stabilnosti jugoistočne Evrope i Balkana bio je da se osnuju nacionalne komisije i kod nas je osnovana Nacionalna komisija za mentalno zdravlje na čijem čelu sam ja bila. Šta je bio cilj da se uradi? Da se harmonizuje zaštita mentalnog zdravlja u svih 9 zemalja, da se harmonizuju zakoni o zaštiti prava mentalno obolelih osoba, da se otvore pilot centri za zaštitu mentalnog zdravlja u zajednici i da se edukuju kadrovi za rad u centrima za mentalno zdravlje. I šta smo mi uradili? U skladu sa Helsinškom deklaracijom Svetske zdravstvene organizacije koja je objavljena 2005. godine na ministarskoj konferenciji u Helsinkiju na kojoj sam ja bila učesnik, mi smo pripremili strategiju za razvoj zaštite mentalnog zdravlja. Kao što vidite, ona je prevedena i na engleski i Vlada Republike Srbije usvojila je 2007. godine. Mi smo također pripremili i zakon o zaštiti prava mentalno obolelih osoba koje je Vlada usvojila 2013. godine. Inače, naša strategija je od strane Svetske zdravstvene organizacije visoko ocenjena i data je kao primjer za neke druge zemlje u istočnoj Evropi. Otvorili smo pilot centar za zaštitu mentalnog zdravlja u zajednici u Medijana opštini u Nišu. Pripremili smo nacionalni program za prevenciju alkoholizma, program za decu i mlade i razvili smo, odnosno pokrenuli smo razne antistigma kampanje, jer kao što je poznato, psihijatrijski pacijenti, osobe sa mentalnim poremećajima su stigmatizovani od strane zajednice i ne samo što su oni stigmatizovani od drugih, nego internalizuju stigmu pa su i oni autostigmatizovani, sami sebe stigmatizuju i zato i ne dobijaju svu pomoć koju bi morali dobijati. Naša nacionalna strategija za mentalno zdravlje je deo zdravstvene reforme. Ona se oslanja već na postojeći sistem zaštite mentalnog zdravlja, u skladu je sa međunarodnim standardima i mi smo odabrali srednji put, nismo prepisali strategije iz sveta jer smo morali naravno i želeli da prilagodimo našim lokalnim uslovima. U strategiji smo predvideli reorganizaciju službi i rekonstrukciju bolnica. Recimo, moj institut je bio potpuno rekonstruisan, izgrađena su 2 nova sprata. Predvideli smo skraćivanje hospitalizacije i liste zakazivanja. Kod nas je hospitalizacija u proseku 30 dana u institutu, a zakazivanje vrlo brzo, od 0 do 7 dana. Smanjivanje broja postelja, takozvana deinstitucionalizacija za 10% godišnje i to je obavljeno. Otvaranje alternativnih službi za mentalno zdravlje u zajednici u saradnji sa lokalnom samoupravom i poboljšanje kvaliteta lečenja, takozvana individualizacija lečenja. Lečenje usmereno na osobu sada inače u trendu i u razvoju i ja sam deo tog pokreta, psihijatrija i medicina usmerena na ličnost, na osobu, a ne na dijagnostičku kategoriju i naravno humanizacija tretmana. I rezultate naše reforme, kao što možete vidjeti, objavili smo u raznim međunarodnim časopisima. Neki su sa visokim značajnim impaktom. Sad ću pokazati primjere dobre prakse. Šta smo mi uradili? Od 2009. godine mi smo bili kolaborativni centar Svetske zdravstvene organizacije, jedini u regionu, za zaštitu mentalnog zdravlja i edukaciju kadrova koji se bave mentalnim zdravljem. Ovaj centar je postojao sve dok ja nisam napustila institut. Preveli smo mnoge knjige, 7 knjiga Svetske zdravstvene organizacije. Ovdje su 6 priručnika za prevenciju samoubistva Svetske zdravstvene organizacije i obavili smo razne seminare za škole, lekare opšte medicine, primarnu zaštitu, službenike zatvora, grupe preživelih i za profesionalce u medijima. Dalje, preveli smo uputstva za dijagnostiku i vođenje mentalnih poremećaja u primarnoj zdravstvenoj zaštiti MKB10 i organizovali smo edukaciju lekara primarne zdravstvene zaštite zajedno sa lekarima, kolegama iz Sarajeva. Po istom programu smo edukovali naše lekare opšte medicine, kao i oni, uz podršku Komiteta za ljudska prava Norveške i Svetske zdravstvene organizacije. Pripremili smo, odnosno objavili 3 vodiča dobre kliničke prakse koje nam je naložilo Ministarstvo zdravlja za lečenje depresije, skizofrenije i alkoholizma. Edukovali smo veliki broj mladih da bismo učinili da se oni osjećaju zadovoljnim u sredini u kojoj jesu, da se spreči taj čuveni brain drain. Organizovali smo veliki broj i lokalnih škola i omogućili im da idu na razne međunarodne škole, kurseve u Mozli kliniku u Italiju, Salzburg, Louisville u Ameriku i na razna druga mesta. Razvili smo bogatu međunarodnu saradnju, naučnu saradnju, jer smatramo da, pogotovo posle konflikta i ratova, da istraživanje ima univerzalni jezik i da ćemo se razumeti kad radimo istraživanja i kada ne govorimo o konfliktu. I da će to biti korak ka pomirenju i tako smo imali veliki broj multicentričnih studija, 2 sam pomenula, o izbeglicama i o posttraumatskom stresnom poremećaju u opštoj populaciji. Istraživali smo suicid u 33 zemlje Evrope, demenciju, ličnost psihijatara, burnout sindrom, sindrom izgaranja, depresiju i dijabetes u kojoj je učestvovalo 18 zemalja i indikatore kvaliteta zaštite mentalnog zdravlja. To je bio poslednji projekat međunarodni, multicentrički, takozvani podunavski projekat u koji je bilo uključeno 5 zemalja i naravno i Srbija. A koji su novi izazovi sa kojima smo se susreli? COVID-19, pandemija je pogodila ceo svet i na neki način ujedinila ceo svet u toj pandemiji i na početku pandemije u aprilu ja sam dobila poziv da napišem rad za World Social Psychiatry koji je objavljen i kao što vidite naziv je Refleksije iz istočne Evrope. Rađena su mnoga istraživanja i održana mnoga predavanja, među njima ja sam to činila o mentalnom zdravlju u doba korone, a u oktobru prošle godine učestvovala sam na simpozijumu Evropskog udruženja profesora emeritusa, gde smo diskutovali o post-covid sindromu, o takozvanom long covidu, produženom covidu. Dok sam pripremala ovo predavanje, dobila sam i redovno dobijam vesti iz Svetske zdravstvene organizacije, ja sam ih dobila prekjuče, a vesti su objavljene u biltenu 12. juna. Svetska zdravstvena organizacija, kao što znate, zaključila je da je prošlo hitno stanje što se tiče epidemije i sada je ovaj period nazvala tranzicionim periodom i napravljen je tranzicioni plan da bismo se lakše, tako je Svetska zdravstvena organizacija naglasila, suočili sa eventualnim budućim pandemijama. A šta je post-covid sindrom? To je onaj produženi covid. Jedna najveća do sada urađena retrospektivna studija 6 meseci posle korone pokazala je da na velikom uzorku, kao što vidite, na više od 200.000 pacijenata koji su imali COVID-19, pronađena je povišena incidencija neuroloških i psihijatrijskih poremećaja. Kada su psihijatrijski poremećaji u pitanju, to su bili anksiozni poremećaji i afektivni. Depresija, čak i manija. Mali broj je bio neuroloških poremećaja posle intenzivne nege, 7% je imalo moždani udar, 2% demenciju. Ono što se opisuje kao posljedica dugotrajnog COVID-a je takozvana moždana magla ili brain fog, vrtoglavica, zaboravnost, dizartrija. Međutim, posle mnogih virusa, ne samo koronavirusa, se mogu javiti ovi poremećaji, pa je pitanje da li je to posljedica COVID-a, a posljedice se inače javljaju kod onih koji su imali teže forme COVID-a, kod njih se razvija dugotrajni COVID, ili je to postvirusni sindrom. Da se zaista događaju ovakvi poremećaji u dugotrajnom produženom COVID-u, pročitala sam prekjuče, a rad je objavljen u najčuvenijem časopisu Lancetu, jedan veliki rad na velikom kohortu kineskih autora, posljedice 6 mjeseci posle COVID-a i to posle COVID-a, teške forme COVID-a, koji potvrdio ovo što su već pronašle i druge kolege. Najteži, jedan od najvećih izazova je kolektivna trauma koju smo doživjeli, kolektivna majska trauma 3. i 5. maja ove godine. I danas je 45. dan tuge. U nedelju su bili parastosi, 40. dan i mnoga dečica su sa svojim dečica koje su preživjela išla da odaju poštu svojim izgubljenim prijateljima. Ovo je nacionalna tragedija najvišeg reda i to je nenadoknadiv gubitak za porodicu, ali i za ceo narod. Ovdje bih citirala Dostojevskog koji je rekao da svi ideali sveta ne vrede suze jednog deteta i ovo je rečeno u jednom dijalogu između u braći Karamazovima, u dijalogu dva brata Ivana i Aljoše Karamazova posle smrti njihovog oca. Šta se dogodilo posle kolektivne traume koju smo svi doživjeli kao šok? Prvih dana bila je tišina, u autobusima su svi ćutali i kažu mi oni koji su išli autobusom da je mogao komarac da se čuje. Posle toga se javila ljutnja, bes i razne aktivnosti, lične i grupne, čiji smo svedoci danas. Šta doživljavaju osobe koje su preživjele ovu traumu? Strah za ličnu bezbednost, jer škola se smatra sigurnim mestom, naziva se i safe haven, sigurni raj. Anksioznost, depresija, poremećaj spavanja sa noćnim morama, poremećaj koncentracije. Ja sam razgovarala sa nekim majkama čija deca su preživjela. Neka dečice imaju i krivicu zbog preživljavanja i misle možda su mogle nešto da urade. Neki su doživjeli akutnu stresnu reakciju i to je normalna reakcija na nenormalnu situaciju. Akutna stresna reakcija može da traje mjesec dana. Međutim, ako taj distres traje duže, može se razviti posttraumatski stresni poremećaj. On se čak može razviti i posle 6 mjeseci kao odloženi posttraumatski stresni poremećaj. A kasnije se mogu razviti i ozbiljniji mentalni poremećaj. Čak i deca koji su izbjegla taj užasan događaj mogu imati psihičke ožiljke koji će ih pratiti dugi niz godina. Na sreću, najveći broj ljudi i najveći broj dece, što sam pokazala i skoro na samom početku, ne razvija ovaj poremećaj. I zato je neophodna psihološka i psihijatrijska pomoć i prevencija koje su već preduzeti. Pitanje je koji su uzroci ove kolektivne traume? Drugi događaj u selima u okolini Mladenovca i Smedereva može se relativno lako objasniti. To je čovek od 20, već mladić, ali već čovek od 21 godine i takvi događaji se opisuju u literaturi kao copycat fenomen ponavljanja, imitiranja. Slično Werterovom efektu koji se odnosi na lanac samoubistava posle jednog samoubistva. Goethe je napisao čuvenu knjigu Jadi mladog Wertera u kojem se Werter ubija posle neuzvraćene ljubavi Charlotte i kada je objavljena ta knjiga, mnogi mladi su počeli da vrše samoubistvo, imitirajući samoubistvo Wertera, pa je knjiga čak bila jedno vreme zabranjena u nekoliko zemalja Evrope. Na sličan način postoji copycat fenomen kada se kriminalne radnje ponavljaju, imitiraju. Međutim, nejasno je šta se dogodilo onom dečaku od 13 godina. I da bismo objasnili ovaj događaj, bit će potrebno vreme i ekspertiza koja je u toku. Potrebno je da se primeni biopsihosocijalni pristup, da možda se radi o poremećajima ličnosti koji je zanemaran i mnogi psihijatri ga ne postavljaju kod dece, a on kod dece svakako postoji i može se lečiti, nije trajan. Kao što sam već rekla, ne razvijaju sva deca i sve osobe koje su doživjele distres poremećaj, neki prežive, čak mogu prolaze kroz oporavak i čak mogu doživjeti poboljšanje i duhovnost i promjenu egzistencijalnih doživljaja. I koje su perspektive na kraju razvoja zaštite mentalnog zdravlja? Prevencija mentalnih poremećaja, unapređenje mentalnog zdravlja, intersektorska saradnja. Mentalno zdravlje je odgovornost svih i da bismo pomogli, da bi bilo mentalno zdravlje za sve, na čemu insistira Svjetska zdravstvena organizacija, lečenje treba da bude usmjereno na osobu, kao što sam rekla, zatim ono mora biti personalizovano i farmakoterapija i psihoterapija, mora se primeniti integrativni, biopsihosocijalni, holistički pristup i odvijati u pentalogu, u zajednici sa stručnjacima, pacijentima, porodicom, socijalnom zajednicom i društva u sredini. I na kraju reći ću već čuvenu rečenicu nema zdravlja bez mentalnog zdravlja, što je logo instituta u kojoj sam ja radila i koji sam postavila. Najveći broj mentalnih poremećaja su izlečivi, ljudi se oporavljaju od problema mentalnog zdravlja i zato je neophodna prevencija i unapređenje mentalnog zdravlja. I ja ću ovdje završiti zahvaljujući vam se na pažnji. Ja mislim da nema vremena za diskusiju, pošto sledi sljedeći.
mislim da smo svi sada predali prezentacije, tako da možemo da krenemo. Evo imamo i pojačanje za... dobro. Moje poštovanje još jednom, dobro jutro. Želim da vam se zahvalim na učešću u ovoj važnoj sesiji. Kao što znamo, medicinski imidžing generalno je oblast koja je doživjela ogromnu ekspanziju u posljednjih 20 godina i u suštini broj dijagnostičkih procedura se povećava po nekom procentu od 6 godišnje. Znači, ogromno povećanje. Mi u Kliničkom centru Srbije gdje radimo imamo praktično povećanje za 3,5 puta u periodu između 2010. i 2018. godine. Utoliko pre želim da zahvalim organizatorima što su prepoznali važnost ove teme, ove oblasti i što smo u mogućnosti da organizujemo ovu sesiju koja je jako zanimljiva. Dakle, imat ćemo predavače koji su eksperti u svojim oblastima i koji će nam predstaviti svoje iskustva i trenutno stanje u različitim oblastima primjene medicinskog imidžinga, dakle kada je u pitanju prostata, kada su u pitanju karcinom rektuma, dojke i na kraju imat ćemo posebnu čast i zadovoljstvo da ovu jako zanimljivu sesiju zaokružimo nečim što jeste naša sadašnjost i što je budućnost, a što će nam predstaviti naš uvaženi kolega i prijatelj, ekspert, profesor Miloš Lučić.
Hvala, Ružice. Ja imam zadovoljstvo da vas pozdravim sve ispred Kraljevskog medicinskog odbora, čiji sam ja član, i da vam poželim dobrodošlicu. A odmah nakon toga ću i da najavim moju dragu koleginicu, profesorku Ružicu Maksimović, sa temom dijagnostička vrednost multiparametrijske magnetne rezonance i evaluacije karcinoma prostate. Izvoli, Ružica.
Hvala najlepše. Also, this is something that I would like especially to stress out. Our dear friend and colleague, expert from Russia, Professor Valentin Sinicin, is also here with us, and he's going to present us the topic regarding imaging of the rectal cancer. Also, during the session, we are going to hear the presentation of Cem Çali, our professor from Turkey, who is unfortunately unavailable to come to the meeting, but he's going to join us via Zoom. Regarding the topic that we are going to go together through, it is prostate adenocarcinoma, which is something that is quite frequent also in Serbia. As we know, approximately, I think there is a statistic that apparently 19% of the adult male population is going to have a cancer, and actually it is the most frequent cancer in Serbia. This is also in accordance to the statistics that we have in the world, and apparently at least 6 of 10 men that are older than 65 are going to develop prostate cancer during the lifetime. Regarding the diagnostic procedures that we may use for detecting prostate cancer, of course, there are some procedures that we can do before the medical imaging, like, first of all, clinical examination, of course, which is very important, and we shouldn't neglect the significance of clinical examination of those patients, and then, of course, a laboratory like PSA and the ratio between free and total PSA, and then, of course, ultrasound, which has been established for many years as the procedure that is part of the routine clinical examination of those patients. Today we are going to talk not only about MRI, but actually multiparametric MRI. And nowadays it is a part of routine clinical examination and the procedure that has to be done before the biopsy. So actually the main thing is to guide in a way biopsy, and to actually biopsy those tissues and those areas which has the higher probability or the highest probability to develop prostate cancer. As you can see, from here, actually, maybe this is better. So the problem with the biopsy before application of multiparametric MRI is that it fails to detect a quite significant number of prostate cancer patients, so more than 1/3 of the patients, or it may undergrade at least also 1/3 of the patients. So that is the importance of the imaging before the biopsy. So before, maybe a couple of years ago, that was really difficult to persuade clinicians to do MRI for those patients, but now the situation is actually completely different. So we are doing MRI before the biopsy. So what is the situation after the MRI? So we can have a couple of situations again, of course, because diagnostic value, sensitivity, specificity is not as high as we would like to be and to be absolutely sure. So in those patients where MRI is negative and there is a low clinical risk of developing prostate cancer, then we actually shouldn't do anything basically. But situation is different if the MRI is negative and then we have high clinical risk, then we should be advised to do biopsy again. And then of course if MRI is positive, then the biopsy should be done definitely. So what is significance of clinical application of MRI? We know that based on imaging we avoid unnecessary biopsies. And then, of course, we can also reduce the number of samples because we can target our biopsy and in that way to also reduce the number of false negative results. Regarding the other diagnostic procedures that we may use, unfortunately, this is not part of the routine clinical thing that to fuse the images from the different diagnostic procedures, but that is also quite an option. And based on this, there are several options that we can do in those patients. So it is either diagnostic or, for example, in those patients where there is a confirmation that we already know that there is a prostate cancer, and then using MRI, so basically multiparametric MRI, then we can initiate active surveillance. So this is also one of the possibilities that we can offer to the clinicians, because as you know, another option to follow the patient is actually active surveillance. And then, of course, the third possible option is to do some kind of either interventional procedure or the treatment, depending on the possibilities of those institutions. So in those patients which are negative on the biopsy, then we may think about repeated biopsy, and then that means repeated the imaging, and then in case where the biopsy is positive, so follow up also maybe, as we have pointed out also in the previous slide, so active surveillance also could be advised. So let's see a little bit about the imaging of the prostate. We see that there is a transition zone, central gland, then peripheral zone, which is quite homogeneous, of high signal intensity. And this is something that could be considered as normal, although there are some certain inhomogeneous areas which may be due to inflammation, and then we are going to talk a little bit later about those things. Then this is anterior stroma, which is very well preserved. In this case, this is a normal patient, and then we see as a thin line, which is of lower signal intensity. This is the same normal prostate in coronal view. This is how we are doing the measurements. So we are doing on the transversal or axial planes, and so this is lateral. Then here on the sagittal view we can do the AP view, or maybe we can do AP view here. It doesn't matter. But also there is a third measurement which should be done on the sagittal view, and when you multiply all those values and multiply with 0.5, then you can get the volume of the prostate. So regarding the things that we are using, so this is a little bit of maybe too many information, but those who are already doing prostate imaging, they know that we have to fix some kind of parameters, and especially it is important for diffusion to be as high as possible. Regarding the sequences that we are using, this is morphologic sequences T1 and 2T, then functional imaging regarding diffusion weighted imaging, then dynamic contrast enhancement imaging. That is something that basically is not part of PIRATE score, and then spectroscopy, we should also have in mind that it does still exist and it could be used, but actually it is not recommended and it is not part of the PIRATE scoring system. If you use those sequences, then specificity may be up to 90% and the negative predictive value is apparently 85%. So what do we see when we are using T1 imaging? As you can see, on T1 imaging, the whole prostate is of lower signal intensity, and therefore it is good for visualization of hemorrhage, for example, so those areas which can give us higher signal intensity. Then we always do overview of the whole pelvis. So not only direct imaging of the pelvic structure, prostate structures, but also we are doing the whole examination of the pelvic in order to see the lymph nodes, all the lymph nodes where we may expect metastatic process. Then, of course, this is important in order to evaluate neurovascular structures and in order to evaluate if there is extracapsular propagation, and then in this way to define TNM grade. Regarding T2, as you can see, this is a normal, so prostate zone is of hyperintensity, it is of increased signal intensity, and this is also good for imaging of maybe periuretral region and infiltration in those regions. Also using this sequence we can evaluate, and in comparison with the T1 we can evaluate hemorrhage and maybe associate prostatitis, so inflammation process which can be seen as the areas which are of lower signal intensity and quite regular. Especially is interesting diffusion weighted imaging, as you can see here. So this is one of the diffusion images, and this is ADC map, because then we are looking at those areas which are of lower signal intensity. According to the high B values, that is very important, and when we increased our higher B values up to 1,500 and 2,000, then we actually got a better resolution and better imaging results. What is important to know? It is important to know that even the normal peripheral zone and transitional zone has their own values, as you can see, which are quite different. And then especially if we are talking about tumors in those areas, in tumor peripheral zone, transition zone, then we see also that these values may differ among themselves. There was an interesting study where they divided patients into 3 groups, basically with benign conditions and prostatitis and carcinoma. So carcinoma is of course something that we would like to detect as soon as possible. And as you can see here, that there was a statistically significant difference between group 1 and 3, so benign lesion and carcinoma, and prostatitis and carcinoma. So for this one, it is actually quite difficult, I would say, but anyhow, it was shown in this study that this kind of differential diagnosis is still possible and reliable. This complicated slide is just to show that at least what we are doing in our institution is actually to do overview of the pelvic structure. So we are doing pelvic examination, and then we are doing targeted examination of the area of course of the prostate. Also, it is important to know that multiparametric imaging of prostate we can do not only before the biopsy, before the procedure, but also after the procedure after the surgery, for example, because we may also see some local recurrence of the disease. In this case, it is quite nice, actually, because we can really see hypervascularity and increased signal intensity after the application of the contrast media. But however, this is, of course, not always the situation, especially if you have fibrotic tissue, which we usually have, and then differential diagnosis is not an option. PSMA is a method that would be advisable in those patients. However, it is still not available in our country, but hopefully next year it should be applied also here. The indication for performing MRI after the surgery is also, of course, to see if there are some lymph nodes, distant metastases. So these are the situation which that's why it is important to have MRI before the procedure. So in case that you don't have the pelvic before the procedure, you don't know whether this is the new lymph node or it is a lymph node that we can actually follow up. And the last sentence here, that there is a low sensitivity in detection of low-risk patients. So this is really a huge problem, and therefore PSMA would be something that would be really helpful and important to do. But for now, the follow-up of those patients is based on laboratory values and imaging that we have. So this is basically MRI. Pirate score is very important, as you can see. So these are the grades starting from 1, 2, 3, 4, and 5, and then we should define where the lesion is according to the prostate segments. So this is a pirate score for the focal lesions which is in the periphery and the focal lesion which are in a transition zone. You can see different characteristics of those lesions, and then we try actually to see where we are going to put those patients based on the imaging characteristics that we have. What is interesting also here that when we use contrast media, then the contrast media would usually help us to define where to put those patients, either 3 or maybe 4, and even then sometimes it is very, very difficult. When we are looking at the lesions, when we are talking about the peripheral zone, then our main image would be ADC map. However, when we are looking in the transition zone, then we should look actually at the T2 imaging. So this is something that is a kind of guidelines what to do first or where to look first, but of course then we have to look all the images and to compare them and then to come to the final conclusion. So correlation of the focal lesion between T2 map and first of all diffusion, then ADC map is very important, and you see now there is a focal lesion in the posterior part of the peripheral zone at the base of the prostate. And then here is, I don't know, because there is a lot of light, so I don't know if you can see, but this was first a wash-in kinetics, which was very vigorous, and then this is wash-out, and this is something which is consistent with the diagnosis of prostate cancer. And then regarding those dynamic studies, we can see that there are different types of the curves, like you can see here, type 1, type 2, there is a plateau, and then type 3, this is very typical. If you have the curve like this one, so with extensive washing kinetics, then washout, then this is very typical for the tumor. We can get curves like this one. So, for example, in one prostate, which is very clear, we can have tumor lesions, focal lesions like this one, which does have wash-in, which is very steep, and then wash-out. And then, in comparison to this one, we have one which is a little bit growing during the time. So this is obviously not related to the focal lesion, which is a tumor. And then regarding the tumor lesions, so we can see all those images that we are taking into account, having in mind that Pirate's system is something that is changeable throughout the time, and then we have to look what the new versions are. So this is the latest one, and as you can see, spectroscopy is not really included. Also, what we have to have in mind is that actually diagnostic value of MRI is different, and that depends on the area. So it is very well known that in the anterior part of the prostate, sensitivity and specificity is actually lower than in the posterior part of the prostate. That was shown in one of the articles, but however, overall sensitivity and specificity still is quite good. Then what is also important, that's why I think we have to pay special attention to this one, is that once when you see that the areas of reduced, actually increased cellularity, which are those black areas that we can see here, you see there are several of them. So sometimes they are associated with actually no other things which can indicate prostate cancer, and this is also a problem because clinicians then they don't trust us, and then they put if they put patients to active surveillance, then that is okay. But if they are going randomly from one to another, then we may lose some time and important information, because it was shown actually in this study that we shouldn't neglect those areas of increased cellularity with a significant proportion of the patients that have already prostate cancer, although PSA may be completely normal. You know that PSA and ratio between free and total PSA is actually completely normal in up to 20% of the patients. Another problem that we have is also the thing that in chronic prostatitis we also have quite inhomogeneous presentation. For example, in this case, we see approximately triangle the area of the lower signal intensity, and as soon as you see those kind of regularity, which is not associated with pathological process, with certain assurance, we can say that yes, this is really something that is related to inflammation and actually not associated with the focal lesion. As you can see here, we have a little bit where we saw the triangular lesion. There is no there are no any other signs of the process. So that means that we have actually to compare everything. This is a patient that, as you can see here, had the prostate PSA, which was approximately 11, and then the biopsy was done. We put Pirates 2, and the biopsy was done, and really it was shown that there was no tumor focal lesion. So you see that the whole prostate is really inhomogeneous. However, there is no focal lesion that you can really identify as a tumor lesion. Also, at that time, we also did some, we did an spectroscopy initially. We are not doing spectroscopy, but this is of course with the contrast media, and then we see that there is increased intake of the contrast media. However, there is no, in none of those points where we measured, there is no steep washout kinetics. Then this is another patient where PSA was, as you can see, 6.78. Then we put benign hyperplasia, and it was really shown that it was hyperplasia because, as you can see, the contrast had wash in and then wash out, which reached the plateau. The point was that there was a lesion here in the anterior part of the transition zone, which actually shown to be within the benign hyperplasia. However, if you have a situation like this one, and what is important also to remember, that in case that we have patients with Pirates 3, usually they are not going to have the biopsy. Usually they are undergoing active surveillance, and then later on we will see what is going to happen with their laboratory findings. Regarding the Pirates 4, if you put Pirates 4 to one of those patients, then that means that the probability of developing and being positive on the biopsy is really very high, and those patients are going to have the biopsy. So this is one of those patients where we see the focal lesion in the anterior part of the transition zone, in the mid and base part of the prostate, and then we see here lower signal intensity of diffusion, but we see reduction here, which meaning increased cellularity on ADC map. Also, you can see here there is a focal lesion after the application of the contrast media. So this is very nice example. And then you also see on the sagittal view. But interesting story about this patient is actually the patient didn't come for some other reasons, but actually his only reason was that he had problems with urinating. And the problem was that he had a hernia of the urinary bladder, as you can see here. So this was his main problem, and this was the reason why he actually went to see a doctor. But fortunately for him, then the focal lesion was discovered, and he had a biopsy, and he had a surgery later on. And I would like to show you PIRATES 5. This is unfortunately very advanced stage of the disease. As you can see, the whole prostate is really a huge tumor. You see that PSA was 700, which means as soon as you see those high values, then you are absolutely sure there is metastatic disease, probably in the bones everywhere. So this was unfortunately, this patient was very late discovered, and unfortunately the outcome was not good at all. So if we go back to the beginning of our story about this gentleman, then we can say that actually multiparametric imaging, what he can expect, this gentleman, from multiparametric imaging, he can expect that he can have a biopsy which is targeted, which means that the diagnostic accuracy of this biopsy is going to be better. So he is going to have benefit also from active surveillance in case that he's not for the surgery, and we can follow up those patients with really significant diagnostic value and indicate and actually discover the small recurrence of the disease in case that it's going to happen. Thank you very much.
Professor Maksimovic, thank you very much, but as we are running late a little bit, we'll leave the questions for the end of the session.
Okay, and now it is my great pleasure and privilege to ask Professor Valentin Sinecin to present us MRI for staging and monitoring of rectal cancer. Please, Valentin.
Thank you. Thank you. Dear Chairman, dear friends, доброе утро. May I have my slide on the screen? Thank you very much for invitation. It's a great pleasure to be here with you. And I'm known because I work a lot in the field of cardiovascular radiology, but also for many years I've worked in general hospital, and we have quite a big experience with cancer oncological patients, in particular in patients with with rectal cancer. Is there any problems with?
There is a problem with the presentation. There is a faulty file or something. Yeah, it can't read some pictures.
Maybe I have it in my computer, so maybe you will invite the next speaker, and yes, after that I will continue. Yes, sorry.
Sure. Dobro, možemo i tako. So we, because of the problem with the presentation, so I would like to ask you to help Professor Sinecin. So I would like to ask you to help Professor Sinecin, and now I would like to ask Dr. Aleksandra Jarić, the role of MRI in the planning of breast cancer treatment. She is very experienced, she is our expert, a very well-known expert in the breast imaging, and it will be a great pleasure to hear what you have prepared for this presentation. Thank you very much.
Thank you. Ja sam svoju prezentaciju pretpostavila da pričam na srpskom jer je takav auditorijum, a slajdovi su mi na engleskom. Tako su mi rekli da, tako da mi je velika čast i zadovoljstvo što u okviru ove sesije mogu da istaknem ulogu magnetne rezonance u lečenju karcinoma dojke. Kao što znamo, to je visoko senzitivna metoda kojom možemo da otkrijemo kancer, ali i da stažiramo otkrivenu bolest. Takođe služi kao dopunska metoda ukoliko su nerazjašnjeni, nekonkluzivne, prethodno određeni dijagnostički modaliteti mamografijom i ultrazvukom, a veliku ulogu imaju u praćenju postterapijske dojke kod žena koje su imale operaciju i postiradijacionu zračnu terapiju. Takođe, postoje i druge indikacije o kojima ću malo kasnije govoriti. Kao što sam rekla, magnetnom rezonancom možemo otkriti primarni karcinom dojke, ali tom prilikom veoma često otkrivamo i dodatne fokuse ove bolesti u istoj dojci koje su praktično bile okultne na mamografiji i na ultrazvuku. Zbog toga upotrebom magnetne rezonance u lečenju karcinoma dojke to sve može dovesti do smanjenja stope smrtnosti, ali i do smanjenja pojava lokalnog recidiva. Iako skrining mamografija košta 10 puta, odnosno skrining magnetom dojke košta 10 puta više nego skrining upotrebom mamografije, ova metoda u sklopu skrininga jeste preporučena, ali kod žena koje imaju visok rizik za razvoj ove bolesti. Osnova pregleda bazira se na upotrebi gadolinijumskog kontrastnog sredstva koji se, znači, aplikuje intravenski i zbog toga smo mi u situaciji da pregledom magnetnom rezonancom otkrijemo promene koje imaju neoangiogenezu. Zapravo, krvni sudovi koji su povezani sa tumorom imaju povećanu vaskularnu permeabilnost i zbog toga usvajaju kontrastno sredstvo, kojom brzinom ga usvajaju i na koji način ga ispiraju, kao i detekcija same lezije i njene morfologije, nama pomaže u razlikovanju i diferencijaciji da li se radi o karcinomu dojke ili o nekoj drugoj leziji u dojci. Senzitivnost ovog pregleda je visoka, ide i do 90, čak nekad i 100%, ali specifičnost je još uvek u nekim srednjim vrednostima do 72%, zbog čega za radiologa koji interpretira nalaz magnetne rezonance još uvek je to veliki izazov da odredi da li se radi o benignoj ili malignoj promeni. Što se tiče dijagnostike invazivnog duktalnog karcinoma, senzitivnost je jako velika, skoro 100%, zato što invazivni duktalni karcinom na magnetnoj rezonanci se predstavlja kao mas lezija koja usvaja kontrast i dobro se diferencira od ostalog parenhima. Što se tiče lobularnog karcinoma i duktalnog karcinoma in situ, senzitivnost je nešto manja zbog toga što se ove lezije na magnetnoj rezonanci predstavljaju kao non-mas lezije koje usvajaju kontrast i nekada ih je teško razlikovati od ostalog parenhima. Još uvek, znači, nismo tačno definisali kolika je to senzitivnost, ali negde nešto je manja od senzitivnosti kada pričamo o invazivnom duktalnom karcinomu. Znamo da duktalni karcinom in situ se najčešće otkriva mamografski jer je on prezentovan kao kalcifikantna lezija, a mi znamo da se na magnetu kalcifikacije ne mogu dijagnostikovati, zato može i biti previđen i nedijagnostikovan ukoliko samo radimo magnetnu rezonancu, a ne uradimo prethodnu mamografiju. Međutim, 10 do 15% DCIS-a koji se prezentuju kao nekalcifikantne lezije mogu da se otkriju magnetnom rezonancom, a mogu biti preskočene, odnosno ne budu definisane prethodno urađenom mamografijom. Specifičnost u otkrivanju karcinoma dojke i dalje varijabilna, kreće se od 37 do 100% i zavisi od različitih faktora, pre svega od vrste premenjenog protokola prilikom pregleda pacijenta, da li smo zaista odabrali pacijenta koji ima indikacije za ovaj pregled, ali zavisi puno i od iskustva radiologa koji treba da interpretira ovaj nalaz. Što se tiče lažno pozitivnih nalaza, kada radimo magnetnu rezonancu, oni su najčešće udruženi sa postojanjem nekih benignih promena u dojci, kao što su fibroadenomi, intramamarni limfni čvor može da simulira karcinom u dojci, proliferativne i neproliferativne fibrocistične promene u dojkama, zapaljenske promene, zone sklerozirajuće adenoze ili atipična duktalna hiperplazija i lobularni karcinom in situ. Takođe, treba biti veoma oprezan kada se radi magnetna rezonanca kod žene koje su premenopauzalne, zato što kod njih postoji fiziološka varijacija normalnog žlezdanog parenhima u usvajanju kontrasta i nekada, ukoliko je pregled određen u nepovoljnoj fazi ciklusa, može doći do prepokrivanja promene ili do lažno pozitivnog nalaza. Tako da ovde, znači, treba biti oprezan i pacijentkinje koje imaju menstrualne cikluse se zakazati pregled u optimalnoj fazi, a to je negde od 7. do 10. 12. dana ciklusa. Što se tiče upotrebe magneta u skriningu karcinoma dojke, on nije preporučen kod asimptomatskih žena koje imaju prosečan rizik za nastanak karcinoma, zbog toga što ima ograničenu senzitivnost, ali i zbog toga što se prilikom ovog pregleda mogu definisati i otkriti neke promene za koje je posle potrebna dodatna dijagnostika i veoma je teško ih do kraja razrešiti. Međutim, žene koje apsolutno imaju indikaciju da se kod njih radi skrining magnetom dojke su žene koje imaju dokazanu BRCA1 i BRCA2 mutaciju, imaju porodičnu istoriju karcinoma dojke ili jajnika kod bliskih rođaka, imaju muškog rođaka bliskog po krvi koji je imao karcinom dojke. Takođe, pripadnost nekim etičkim grupama za koje znamo da imamo i urođene mutacije genske i ostale mutacije koje su utvrđene genske kod pacijentkinja, apsolutno su indikacija da ih pratimo magnetom. Što se tiče žena koje su zbog Hodgkinovog limfoma u mladosti imale supradijafragmalnu mantl zračnu terapiju, one takođe predstavljaju jednu rizičnu grupu, jer znamo da je dojka radiosenzitivan organ i da zbog toga što su pretrpela takvu iradijaciju u mladosti može doći do razvoja karcinoma dojke, tako da i njih trebamo uvrstiti u ovu grupu gde bismo radili skrining magnetom. Što se tiče primene magnetne rezonance u našoj kliničkoj praksi, apsolutno se koristi za staging bioptirano dokazanog karcinoma dojke. Kada imamo pozitivan limfni čvor u kome je histološki dokazana metastaza, mamografijom i ultrazvukom nismo pronašli primarni tumor, naravno da ćemo uraditi magnetnu rezonancu da bi pokušali da definišemo tumor zbog koga je došlo do metastaze u limfnom čvoru. Takođe, ukoliko imamo žene koje su imale hirušku intervenciju sa pozitivnim marginama, radit ćemo magnet da bismo procenili da li zaista postaje rezidualna bolest u toj dojci, da li je potrebna reoperacija. Kada postoji sumnja da postoji invazija pektoralnog mišića i nismo sigurni prethodno određenom dijagnostikom, takođe će nam pomoći magnetna rezonanca, kao i u proceni odgovora na sprovedenu preoperativnu neadjuvantnu hemioterapiju. Takođe, u postterapijskoj dojci, kada imamo ožiljak od operacije i mamografijom i ultrazvukom dobijamo neki nekonkluzivni nalaz i nismo sigurni da li u okviru toga postoji recidiv ili ne, magnet će nam apsolutno dati odgovor na to. Kod nekonkluzivnih nalaza mamografije i ultrazvuka, ali kada se radi dopunski magnet, ali naravno kada prethodno odradimo sve moguće dopunske projekcije, uveličanja, tomosintezu, ciljani ultrazvuk i ne možemo da odredimo o kakvoj promeni se radi i da li bi trebalo da se bioptira ili ne, uradit ćemo i tada magnetnu rezonancu koja će nam verovatno dati dalje pravac postupanja. Ova metoda služi i moguće je njom i raditi vakuum asistirane biopsije i preoperativne lokalizacije promena koje se ne vide drugim dijagnostičkim metodama, a postavljanje je sumnja da su suspektni i da bi trebalo da se otklone. Velika primjena danas je evaluacija silikonskih endoproteza, bilo da su one implantirane u cilju augmentacije ili nakon subkutane mastektomije. Što se tiče ovog skrininga za žene sa velikom rizikom, znači moramo da kažemo da su to žene koje imaju barem dva prva srodnika koja su imala karcinom dojke, mada u nekim novim studijama pominje se i veći broj srodnika da je bitan ukoliko odlučujemo na koji način ćemo ove žene pratiti. Takođe, kod žena gde je rađena biopsija nekih promena u dojci, dobijeni su nalazi histološki za visoko, da kažem, high risk lezije, kao što su atipična hiperplazija ili lobularni karcinom in situ. Takođe ćemo njih pratiti magnetom. Kod žena koje nisu rađale, gde je dojka jako denzna i gde je mamografija apsolutno smanjene senzitivnosti, a ponekad i ultrazvuk, kod žena koje su imale ranu menarhu i kasnu menopauzu, kod žena koje su na hormonsko-supstitucionoj terapiji, kod gojaznih osoba, pošto znamo da je to jedan od rizičnih faktora za nastanak karcinoma dojke, kao i kod žena koje su već imale i operisane i lečene od karcinoma dojke. Sada hoću samo da naglasim i da pošaljem jednu poruku, a to je da mi u standardnoj praksi ne preporučujemo upotrebu magnetne rezonanse koja isključuje da se pre toga rade mamografija i ultrazvuk, a takođe i negativna magnetna rezonanca ne isključuje, ukoliko postoji sumnjiva promena na mamografiji i ultrazvuku, da se uradi biopsija. Znači, to su neke ovako poruke koje su bitne kod nas dijagnostičara da nam daju pravac šta dalje. Što se tiče kontraindikacije, one su opšte kao i za sve ostale preglede na magnetu. To su pacemakeri, neurostimulatori, neki stari modeli klipseva na aneurizmama, veštačke valvule. Klaustofobija može biti problem kod žena da izdrže ovaj pregled, kao i gojaznost, jer prosto ne mogu da nisu kompatibilne sa otvorom u koji treba da uđu radi pregleda. Takođe, problem može da bude i manjak ovakvih uređaja i uopšte lekara koji se bave magnetnom rezonancom dojki, a i cena ovog pregleda je dosta velika u odnosu na ostale dijagnostičke metode. U hiruškom pristupu lečenja karcinoma dojke imamo dve mogućnosti. Rade se ili poštedne operacije ili radikalna mastektomija sa ili bez ugradnje sekundarne rekonstrukcije, ugradnje endopriteze. Da bi hirurg odlučio koju vrstu operacije će primeniti, znači on mora da ima u vidu pre svega veličinu tumora, da li je taj tumor multifokalan ili multicentričan, kolika je njegova proširenost, da li ima invazije pektoralnog mišića ili invazije mamile, kao i da obrati pažnju na lokalni status limfnih žlezda, da li su one zahvaćene, kao i da vodi računa o opštem stanju pacijentkinje i udruženosti nekih drugih bolesti koje bi komplikovale veličinu i ekstenzivnost operacije. U svemu tome preoperativna magnetna rezonanca dosta pomaže, jer ukoliko njom dokažemo dodatne fokuse u istoj dojci ili otkrijemo, na primer, fokus karcinoma u suprotnoj dojci koji nije viđen prethodnim metodama, u svakom slučaju to može promeniti tok odluke o kojoj vrsti operacije će se raditi. Nakon ekcizione biopsije dojke, kada histološki imamo potvrđene pozitivne ivice resekcije, da ne bi radili ponovo operaciju, mi radimo magnetnu rezonancu kojom zaista možemo da procenimo da li postoji rezidualna bolest ili ne. Međutim, postoperativne sekvele smanjuju senzitivnost ovog pregleda i zbog toga preporučujemo da se pregled radi barem 28 dana nakon operacije, kada je njegova senzitivnost od 89 do 94%. Takođe može biti korisna metoda kada hoćemo da razlikujemo ožiljak od recidiva u postiradijacionoj ili postoperativno izmenjenoj dojci, jer te zapaljenske promene nakon iradijacije zaista smanjuju senzitivnost mamografije i ultrazvuka. Međutim, i ovaj pregled je preporučeno da se radi barem 6 meseci nakon operacije ili čak do 24 meseca nakon sprovedene iradijacije, zato što Do tada, znači, su dosta izražene te sekvele koje nam smanjuju senzitivnost pregleda. I evo jednog primjera, vidimo mamografsku projekciju leve dojke, gde centralno retroareolarno vidimo, to je postoperativna dojka, jednu zonu asimetrije i narušene strukture s nekim slabije intenzivnim kalcifikacijama, gde zaista nismo bili sigurni da li postoji recidiv ili ne. Uradili smo magnet i videli smo da je to samo postoperativna sekvela, tako da ova žena prelazi u redovne kontrole. Ovde sam želela da prikažem na ovom slajdu kako izgleda postiradijaciono izmenjena dojka. Zaista senzitivnost ostalih pregleda je manja u odnosu na pregled na magnetu, jer je dosta zadebljala i koža i povećana celularnost i tako dalje. Međutim, mi smo uvideli na magnetu da je to apsolutno, znači, nalaz uredan i da tu nema nikakvog recidiva. Što se tiče dodatnih primene magneta kao dopunske procedure, mamografije i ultrazvuku, ona je danas uobičajena u ustanovama gde imamo mogućnost da sprovodimo ovaj pregled, ali smo u obavezi zaista, kao što sam već ranije rekla, da odradimo sve dopunske projekcije mamografske, da uradimo ciljani ultrazvuk i zaista kada nemamo drugog načina da donesemo odluku šta ćemo sa pacijentkinjom, onda na magnet dosta pomaže, jer može da otkrije i promene koje su veličine čak i 0,5 mm. Evo, ovo je prikaz jedne pacijentkinje koja je imala, znači, karcinom desne dojke, zbog čega je urađena subkutana mastektomija i stavljena endoproteza. Mamografski pratimo levu dojku koja je dosta denzna i senzitivnost je smanjena i mi nismo sigurni čak ni ultrazvukom da li tu postoji neka sumnjiva promena. Radili smo magnet i utvrdili da je to potpuno normalno tkivo dojke i da nema nikakvog suspektnog izlivanja kontrasta u levoj dojci. Što se tiče preoperativnog magneta, ovo je karcinom dojke koji je već dokazan, znači biopsijom vođenom pod kontrolom ultrazvuka. U cilju preoperativnog planiranja urađen je magnet i videli smo da osim tog tumora koji smo videli mamografski ultrazvučno, postoji dodatni fokusi, tako da plan ovog lečenja u smislu operativnog semenja i svakako se neće raditi poštedna operacija. Takođe, veliku ulogu imaju u proceni odgovora na sprovedenu neadjuvantnu hemioterapiju, kada, znači, vidimo, možemo biti sigurni da li postoji reziduum bolesti zbog planiranja daljeg hiruškog zahvata i lečenja. Što se tiče evaluacije implanta, zahvaljujući specijalnim sekvencama, danas dosta primenjena metoda koje možemo biti sigurni da li postoji intrakapsularna ili ekstrakapsularna ruptura i svakako kad postoje i neke estetski razlozi, kada pacijentkinja zbog takvih razloga ide na operaciju, preporučeno je da ipak preoperativno uradi magnet da bi se procenio integritet proteza, ali i da se napravi uvid u ostali parenhim dojke. Evo, ovo su neke slike gde vidimo, znači, dojke gde su ugrađeni implanti iz estetskih razloga koji su apsolutno imaju intrakapsularno raslojavanje. S druge strane vidimo pacijentkinju gde vidimo duplo u konturu implanta na mamografiji. Ovo je kontrastna mamografija, jer pacijentkinja zapravo ima ugrađeni implante iz estetskih razloga, a ima palpabilan tumor centralno, zbog čega smo radili kontrastnu mamografiju, ali i magnetnom rezonancom utvrdili da ima i ekstrakapsularnu rupturu ove proteze. I evo samo za kraj, ja bih citirala profesorku Evu Haris, koja je osnivač nauke o održivosti sa Univerziteta Berkeley u Americi, koja je rekla da tehnologija sama po sebi nije magični metak i da su uvek iz potrebe stvorene nove tehnologije i unapređivane stare, ali da ključ ostaje naučnih istraživanja u ljudskim resursima i da svi programi i projekti zahtevaju ljude i da svi ljudi treba da se oko toga udruže da bi dali neke rezultate. Hvala.
Hvala koleginice. Pošto je inače, nažalost, malo kasnimo, možda je najbolje da nastavimo sa predavanjima, a ukoliko nam ostane dovoljno vremena, onda ćemo da odvojimo par minuta za diskusiju, pošto znate da u 12 sati ima sljedeća sesija. Professor Sinicin, here we are. I hope that this is going to work
Thank
this
you.
time.
The second try. Thank you. Next. First of all, again, does it? I cannot move it. Okay. For a beginning, I would just remind a fantastic talk from Ružica Maksimović. She gave it in Russia some years ago about Russian doctors in Serbia. So, Ružica, thank you very much. We are still recording this talk. It's my hospital. I work in the University Medical Center of Lomonosov Moscow State University. And in my talk, we are continuing moving, as I understand, from pelvis up. Objectives about to understand the new requirements of imaging of rectal cancer and to be familiar with principles and for initial staging of MRI, to be familiar with the modern protocol for MRI. Again, for introduction, we know that during the last maybe 10 years, we see tremendous changes in the approaches to treatment of rectal cancer and approaches to diagnosis. And all of a sudden, I remember 15 years ago, MRI was not a tool for rectal cancer at all. Today, it's a standard modality for staging and follow-up of patients with rectal cancer. It's already put into the international guidelines about treatment of rectal cancer. I will show you examples. And of course, there are some opinion leaders. From my point of view, what I know, that's a lot of publications from the Gina Brown from Great Britain and our good friend Regina Bitstan. She's just recently she was a president of the European Society of Radiologists Congress. I know she's a very good friend of Serbian radiologists and Russian radiologists, and she has done a lot for spreading the knowledge about imaging of rectal cancer. We know that there is a standard TNM classification of rectal cancer for detection of lymph nodes, of metastasis. And for staging, we know that there are T1, T2 stages when tumor is still within the wall of the rectum, and T3 when already tumor leaves the serosa and spreads into the mesorectal fat, and T4 it's a spread to adjacent organs. And as you see from the graphs, of course, like in every cancer, outcomes of rectal cancer are heavily dependent on staging and, of course, on early diagnosis. So, like with prostate, there is an international agreement to divide patients with rectal cancer into the low-risk patients, with intermediate risk and high-risk patients. Low risk, it's T1, T2 tumor, no extramural venous invasion, negative circular resection margins, I will come to that, N0, MM0. Surgery can be gives practically 100% treatment of these cases. For intermediate risk patients, from my point of view, majority of our patients which come to our hospitals are intermediate risk patients. Here, standard approach neoadjuvant therapy and radiation therapy allows us to achieve very good results even without surgery. The same about high risk patients. And what I like, we know the Bible for all oncologists in the NCCN guidelines about treatment of oncological patients, all types of cancer. And if you look into the workup of treatment of rectal cancer, we see that there is pelvic MRI. It's a standard approach to which is, by the way, preferred to rectal ultrasound for staging of the cancer, and PET-CT is not routinely indicated. I will come to them only for unclear situation. Again, so it's not a standard approach to staging of rectal cancer. MRI is, as you see, in the front line, on the first place. About protocol. Protocol is quite standard. We know that the backbone of pelvic MRI for prostate, for rectal cancer is T2 weighted images in different planes, including the oblique axial planes along the axis of the rectum. Of course, T2 weighted images with a high B value, like for prostate. And interesting that in contrary to breast imaging, for example, and to prostate imaging, gadolinium contrast enhanced imaging is regarded as optional. For example, Regina Bitstan says that for staging of the rectal cancer, she sees no advantages of added value of the contrast enhancement MRI. So again, what is not recommended? We remember 20 years ago, there were a lot of talks about use of endorectal coils for prostate cancer or for rectal cancer. Today, because it distends the rectum, it compresses the prostate, and today our images are so good that can we do very fine diagnosis without these artifacts, without endorectal coils. So endorectal coils are gone. So filling of the rectum with contrast media usually not recommended. And optional, as we said, some centers use it, something not. It's spasmolytic agents before MRI, contrast enhancement, nothing wrong. I believe it can give extra information. So in our center, usually we use, like for prostate, contrast enhanced MRI. And for non-moving structures, 3T MRI is slightly better for image analysis, but so far as I know, as the same for prostate, from the diagnostic point of view, there is no difference from the diagnosis, but for radiologist, images are looking better. Perfusion MRI is disputable. It's not in the standard approach for rectal MRI. It's mostly so far it's a field of research. It's not a standard for clinical practice. So what are the main questions? Location of the tumor. Is a high cancer, middle cancer, or low rectal cancer? The T stage of the tumor. First of all, it's differentiation between T2 and T3 stages. Definition of the free resection margins for tumor resection. End stage, detection of the pelvic lymph nodes, and detection of the extramural vascular invasion, MEVI. It's a very specific pathology for rectal cancer. You can see it with a prostate cancer, for example. Also, I will come to them. There is a mnemonic assistant about reporting, like distance from the inferior part of the tumor to transitional skin, T, staging, A, anal complex sphincters, puborectalis muscles, N, nodal staging, C, circumferential resection margin, and E, extramural vascular invasion. As for landmarks, why we like MRI so much? Because we see very well mesorectal fascia, which is extremely important for staging of the cancer. We see outer walls of the rectum. We see lymph nodes in mesorectal fat, and we see venous vessels inside the mesorectal fat. That is extremely important for staging. And I mentioned it, classification of the rectal cancer according to the allocation: low, mid, and high. Low rectal cancers, it's a specific area because they involve anal complex. So actually, because for the sake of time, I'm not going to discuss approaches to low rectal cancer because there are a lot of peculiar things about it. They are more rare than mid or high rectal cancer. About the staging, as I mentioned it, it's very important to differentiate T3, A, B, C, D, and this the distance from the wall, how far they spread into the mesorectal fat. And T4 is much easier because it's spread to peritoneal cavity and the adjacent organs. For T1 and T2, as I said, usually people believe that you cannot reliably differentiate even with help of MRI, T1 and T2. But actually, for the treatment approach to treatment, it's not so much important. So, for example, here's a case from our center. This is T3 tumor, large tumor invading with touching mesorectal fascia on the left side. Or, as I said, one can differentiate 3T AB with a minor spread of the tumor into the few millimeters into the mesorectal fat, or more substantial, more than 8 millimeters into the mesorectal fat, as you see on this image. And of course, T4, in case of T4, you see the tumor already touches adjacent organs, or for example, pelvic muscles. That's, in that case, diagnosis is quite obvious. As I said, I'm not going to discuss low rectal cancer. What's important is nodal staging, because with MRI quite often we see small lymph nodes in the mesorectal fat. They are very easily seen. The problem is that it's general, like Ružica said about the prostate MRI. With MRI, mostly we are saying about the nodes probably malignant or probably benign, looking mostly at their size and sometimes at their contours, yeah, if they are speculated or heterogeneous or they are round. But from this point of view, MRI is not so reliable like PET. Of course, PET sees pathology in the metastatic lesions in the mesorectal lymph nodes much better. But from other side, if you see many increased lymph nodes in the mesorectal fat, in that case, probability of metastatic disease is quite high. But nevertheless, I said, in the doubtful cases, like this case, you see, we see with T2 MRI and with DVI, we see plenty of lymph nodes around the rectum affected by cancer. But PET-CT shows us tumor, but no accumulation of the FDG in these increased lymph nodes. It was benign enlargement of lymph nodes. On MRI, it looks like metastatic lymph nodes. In reality, they are not. So please be cautious. Another specific feature of MRI is the definition of the circular resection margin. It's a distance between the mesorectal, mesorectal fascia and the outer border of the tumor, and you see the CRM plus is the distance less than 1 millimeter between the tumor and the mesorectal fascia. So this is CRM status plus. It's positive if measurement is less than 1 millimeter. And what I said, what's peculiar for MRI, it's extramural vascular invasion, EMVI. It's not, we see these implants is in the mesorectal fat of regular shape, and they are not lymph nodes, they are implants of the tumor cells into the small veins, venous plexus, right, in the mesorectal fat. That's also important for staging. It's a tumor embolia. Also MRI, because we see very well structure of the tumor, there's a special type of mucinous tumors of the rectum, and they give, you see, unhomogeneous bright signal on T2 weighted images. It's a very important feature because usually it's believed that prognosis of mucinous rectal cancers is worse than of regular non-mucinous tumors. There were several trials, like accuracy trials, show that, and they had shown a prognostic value of MRI staging for prognosis of the patient. So you see that, for example, for patients with CRM negative patients, prognosis was much better than for patients with CRM plus positive, defined by MRI. So that's why, because of this trial and another trial, Mercury trial, again, they shown that results of MRI have predictive significance for prediction of the patient's prognosis. That's very important. So for defining the course and treatment of patients. Also, MRI is important for restaging of rectal cancer after radiation therapy. There is one problem, because we know that radiation therapy produces a lot of fibrosis in the tumor tissue and in the fatty tissue around the rectum. In that case, I believe the problem-solving tool is diffused weighted imaging, our favorite tool, and there are plenty of publications about this. Also, we are living in the era of different grades and scales. There is a TRG, MRI tumor regression grade, which after radiation therapy, there are 5 grades, 1, 2, 3, 4, 5. Complete response, good response, moderate response, slight response, no response, grading like dense fibrosis with no obvious residual tumor, or more than 50% of fibrosis with some minimally visible tumors, or less than 50% of fibrosis with mostly of the mass is visible tumors, and of course no response. As an example, you see again we had Department of Radiation Therapy. We see that before radiation therapy, a large tumor, DVI and ADC map, and after CRT, you see no areas of restricted diffuse in the rectum. That's a complete response, TRG1. TRG2, after radiation therapy, you see decrease of the tumor, and there is again no visible mass. TRG3, you can see some parts of the restricted diffusion, and inside the mass, obviously there is a good dynamics in decrease of the tumor volume. And in case of TRG4, in that case, we see still remnants of the tumor tissue. And TRG5, of course, there is no effect of radiation therapy after CRT. And again, saying about role of DVI, you see that in two patients which, according to DVI images, maybe look very similar, DVI can differentiate between grade TRG2 and TRG3, for example. You can have a look. And also there were papers saying that probably, again, last week's prostate, using the ADC maps and calculating the absolute values of diffusion restriction could be also some additional parameter biomarker showing course of the disease. And again, as I said, for example, in this case, you see the prominent fibrosis after radiation therapy with very small volume, much less than this mass of the probably oncological tissue remnant of the rectal cancer, which is confirmed by PET. And of course, there is plenty written about standard protocol. We are living in the era of computers, of the structured reporting. So all these grades and scales are implemented into structured reporting. You see one of them is in English, and another one is in Russian. We implemented it in our center. New developments, as I said, I'm moving to the end of my talk, is perfusion MRI. So far, nobody uses this routinely in clinical practice, but maybe after some research, maybe we will find out what help it can be for better staging. PET-MR, of course, PET-MR is better than PET and MR separately, sure, but still there is big issue about economical impact of such approach, because it's quite expensive and takes a lot of time. For a scientific center, it's fine, but for the mass application, it's a big issue. And of course, we cannot live without radiomics and without AI. It's obvious. Today, it's in vogue. A mass of publications about AI in all kinds of pathology, including oncology, prostate, and rectum. Plenty of publications saying that yes, we can increase better predict prognosis using AI. We will see. Of course, we know that's not replacement for radiology. It's just our assistant, electronic computer assistant, but not a second radiologist. So, and actually, I believe that my take-home points are quite obvious. Obvious that pelvic MRI and the standard approach, it's a must for staging of, not for primary diagnosis, but for staging of the rectal cancer. Selection of treatment strategy and grading of treatment results. It has a high predictive value. So far, it looks like approach to rectal MRI is quite standard, but we are looking maybe for some new developments thanks to progress of the MRI technology and development of artificial intelligence. And just to end up, just for self-promotion, in Russia we have a new international journal in radiology, digital diagnostics. I'm its chief editor. It's in Scopus, so we accept papers in English. It's a Scopus 4, of course, for a beginning, but we are looking for better. So you are welcomed. We have papers already from many countries, and actually we translate also papers submitted in Russian, English. We translate, if it's submitted in Russian, we translate it fully into English and to Chinese also. So if you will submit it in English, we would transmit it in full, translate it in full into Russian and Chinese. Thank you very much for your attention.
Thank you very much, Professor Sinitsyn, for your great lecture. I'm sure that there will be some questions for you on the end of the session. Now it's my great pleasure to introduce you one of the rising stars in breast imaging from Novi Sad. It's Assistant Professor Marijana Basta Nikolic. So, Professor, the floor is yours.
Thank you very much, ladies and gentlemen, my dear colleagues. This is really a great pleasure for me, and I would really like to thank the organizing committee for this kind invitation. As Professor Maksimovic pointed out at the beginning of this session, the radiology is really tightly connected to the technological advances, and these technological advances are sometimes really miraculous. Unfortunately, when we speak about breast cancer, no matter how technologically advanced we are, at this point, we cannot say for 100% sure who is going to develop breast cancer and if a woman is going to get a cancer, when that is going to happen. And we can put some efforts into prevention, but we cannot prevent cancer for sure. So the only thing that we can do is to be proactive and to try to actively search for carcinomas. Here you can see the many phases of the breast cancer. So many clinical presentations. So breast can look like these lemons, just a little bit bigger. However, when the cancer is clinically visible, then we are already almost too late. So our ultimate goal is to try to find breast cancer when it is as small as this lemon seed here. Why is it so important? Similar to rectal cancer, similar to prostate cancer, the lower the stage, but the better the survival rate is. And not only the survival rate, but at the same time, the quality of life of those patients after therapeutical procedures. The only way we can achieve this is using what I like to say magic in medicine, and that is radiology. So only radiological imaging techniques can actually find this small cancer. The focus of my today talk is going to be mammography, which is still a golden standard for breast cancer diagnosis. Despite being a gold standard, it of course, as many other imaging techniques, has limitation. The major limitation of mammography is that it is two-dimensional technique with summation. So, especially in dense breast, there is a significant overlap of potential lesions and normal tissue, which significantly lowers the sensitivity of mammography and, in many cases, higher the recall rate, which gives a specific burden, both financial and a work burden for healthcare professionals, and also it causes stress for the patients. They are always afraid when we call them for additional checkup after mammography. Breast density is really an important factor for many reasons. First of all, as the density of the breast increases, also the risk of breast cancer increases, and at the same time, sensitivity of mammography significantly decreases. Let me try to explain it with the loaf of bread. I'm not a good cook myself, but if we want to make a sandwich, and for example, imagine that this bread is a breast, and inside the breast we have, for example, an egg or a cheese. If we do mammography examination of our sandwich, then there is a high chance that the cheese is going to be hidden by an egg. Or, in other words, that normal tissue can overlap and hide the lesion. Luckily for us, with the development of technology, we have found a way to cut our bread into slices, or to actually divide the breast into slices so we can clearly see part of the breast where the egg and the cheese is, or where actually the lesion is without overlapping. This technique is called tomosynthesis, and it has been in clinical use for over 15 years now, and there are numerous studies which have confirmed that tomosynthesis significantly increases the detection rate of carcinomas and also other lesions. But the problem is, with tomosynthesis, we find the lesion, but then what should we do with it? So every suspicious lesion should be further characterized, either biopsied or followed up. So the first thing that I'm going to mention today is the vacuum-assisted biopsy, stereotaxic biopsy, under the guidance of tomosynthesis, or in other words, 3D stereotaxic biopsy. It is very useful for lesions that we see only by tomosynthesis. Also for the lesion that we see in only one projection. For discrete lesions, for architectural distortions within the breast, of course for microcalcifications. With this technique, we can very well see vascular structures within the breast, and in that way plan our procedure, plan the pathway of our needle. It is excellent for posteriorly located lesions, lesions that are near the skin, and also for small breasts, thin breasts, which are otherwise very complicated for the standard 2D biopsy. Another great addition is lateral arm approach, which is specially designed for thin breasts. In this kind of approach, the needle goes parallelly to the detector from either left or right side, and in that case, we can actually jump over the obstacle of not having enough thickness of the breast tissue. So here you can see when we do a normal approach, when we fire the needle, we need to have some space. In thin breasts, that is sometimes impossible. However, when the needle is parallel to the detector, we have plenty of space to do our biopsy without any potential harms to the patient and to our machine, of course. So, the targeting of the lesion by tomosynthesis is really very simple, and it is performed in just one click. So, in just one click, afterwards, those coordinates are actually being transferred to the biopsy unit. So we have X and Y coordinate similar to the 2D biopsy, and the Z coordinate, or the depth of the lesion, is actually number of the slice on tomosynthesis where the lesion is best seen. After we put the needle inside the breast, of course following the coordinates, we do pre-fire image to see and to check if the needle is following the exact pathway, and then we can do post-fire image, so to see if the needle is in a correct position. Afterwards, we check the biopsy site, so this is post-biopsy image, and of course we can check the position of the marker. Sometimes we can avoid some of these images, for example, post-fire and post-biopsy, but at the beginning, when we started doing this, we weren't actually skipping any of those steps. At the end of the procedure, of course, we do radiography specimen to check if there are microcalcification within our tissue sample, and the procedure is done. 3D biopsy lasts much shorter compared to the conventional 2D biopsy, mostly because of the much easier positioning and targeting the lesion. Also, the successful rate is much higher. In our institution, we have performed, well, less than 200, maybe 160, 70, and we couldn't do biopsy in only 2 cases, only in 2 patients, out of which one patient had microcalcification that turned out to be microcalcification of a skin lesion. So the patient had skin keratosis, which actually mimicked microcalcification within the breast. And another very important advantage is significantly reduced irradiation dose, especially if we skip some of those post-fire or post-biopsy images. So here are some examples. This is a patient with very discrete, I hope you can see them, so very discrete microcalcification in the upper lateral quadrant of the left breast. So we easily performed the biopsy and histopathology confirmed DCIS. This is a patient with very small breast that was transferred to our institution from another hospital because the breast was thin and the lesion was superficially localized. So we performed the biopsy, and I was a bit nervous before doing it, but everything went so smoothly that it seemed to be too good to be true. But sometimes complications happen, and with this patient, when I pulled out the needle, I got a fountain of blood. So we were all covered in blood. Patient started bleeding very heavily. We were pressing the breast, putting a compression for more than 30 minutes. She didn't stop bleeding. So we tried to put sutures ourselves. We are radiologists. We don't make these sutures very successfully. At least I didn't. But luckily for myself, I have a husband surgeon, so I called him and he stitched the woman. He came to lunch covered in blood, so his shirt was bloody. It was really a heavy bleeding, but at the end, everything went fine. So patient had hematoma. We evacuated that hematoma 7 days later, but we have proved cancer for this patient and really helped when this complication wasn't severe and it resolved over time. So this is another patient also transferred from other institution, very thin breast, very small breast, and I hope you can see very discrete microcalcification within the breast. For this patient, we opted for the lateral arm approach. So here the needle was going parallel to the detector, and we did the biopsy without any problems. So you see there are microcalcifications within the specimen, and this was fibrocystic breast disease, so no cancer. Similar case, also unsuccessful with 2D biopsy. So here you can see 2 clusters, I hope you can see 2 clusters of microcalcifications that are really very close to the skin. So we opted to do biopsy of these clusters because it was a bit more further from the skin compared to this one. So again, we opted for the lateral arm approach. We did biopsy. Here are the microcalcification, and we have proven LCIS for this patient. So as my colleague Dr. Jaric suggested, maybe this patient should undergo MRI before the operation to see if there are some other foci within the breast. So the first 3D biopsy was performed 10 years ago in USA, and at our institution it was performed in 2010 during COVID lockdown in a very difficult situation, and from that point we are continuously doing it, and I'm really in love with this procedure, as I already discussed with my colleague, because it is really very easy, rather safe, and good, very good procedure. On the other side, we have another innovation, which is actually spectral contrast mammography. Spectral contrast mammography is functional imaging method, which is actually similar to MRI. So it is based on vascularization and contrast uptake, and the indication for contrast mammography are rather similar to those of MRI. And there are also, they have similar sensitivity and specificity. The advantages of contrast-enhanced mammography compared to MRI is that it really lasts much shorter, so 6, 8 to 10 minutes. It is cheaper and it's, maybe more comfortable for the patient, but it is a 2D method at this point, so we are lacking the third dimension, and it has irradiation, which is absent in MRI. The procedure itself is rather simple. So before we start imaging, we do contrast administration, intravenous contrast administration. The contrast we use is the same iodine contrast used for CT examination. The dosage is 1.5 milliliters per kilogram. And then when we administer the contrast, we wait for 2 minutes for the contrast to distribute evenly within the breast. Then, after 2 minutes, we compress the breast and do all two projections for both breasts. And for each projection, the machine actually makes 2 images. One of them is low image, which has a kilovoltage which is below decay edge of iodine. So on these images, we actually do not see contrast enhancement. These images have a nice resolution, and we can use them as diagnostic ones. On the other side, high energy images, their kilovoltage is it's upper, so it's upper compared to the iodine K edge. So here we only see the imbibition, but these are not for interpretation. Then the machine itself does automatic subtraction of these images. So at the end we got this final product where we clearly see the contrast enhancement of the lesion. So here we have a patient. You see this severe architectural distortion. The breasts are rather dense, so we opted to perform contrast-enhanced mammography, and here we see additional foci similar to preoperative staging with MRI. Another quite helping and important role of contrast mammography is in cases similar to this. So in upper lateral quadrant of the right breast, we saw a lesion which we couldn't detect by ultrasonography. So we performed contrast-enhanced mammography, and we see that there are no enhancing lesions, so no biopsy, just follow-up is recommended for this patient. And this is a great example of combining of these two techniques. This is actually a colleague of ours from our hospital who is one of those patients who are very reluctant to come for an examinations. They are very afraid, and they just want to come and to hear from you that everything is okay. Unfortunately for this patient, not everything was okay. So here we can see architectural distortion in the left breast, but ultrasound was completely normal. So she said, "You see, doctor, everything is okay, just I'm going to go home." She didn't want any additional tests, but somehow we made her do contrast-enhanced mammography. So we see an enhancement of the lesion, of this distortion here, but also another foci of, within the same breast. I repeated ultrasonography once again, but still I couldn't find any suspicion. There were some areas of attenuation, but I wasn't sure if any of these corresponded to the lesion. So at the end, I decided to do vacuum-assisted biopsy of the distortion, and we have confirmed invasive ductal carcinoma in this patient. She was operated, and she's well now. We are surveilling her, and at this point, everything is good. So technology is constantly developing, and it is going to be developing even in the future. And we should really it gives us a helping hand, but no technology is valuable without a human factor, at least at this point. So we should take the best from these technologies and makes us even better, train, become more experienced. We should share our knowledge on conferences like this in order to achieve as better results as possible and give the best medical care to our patients. Thank you very much for your attention.
Thank you very much. Excellent talk. Thank you. We enjoyed it very much. Unfortunately, we are a little bit limited with the time, so we are going to proceed with the next presentation. This time, unfortunately, we are not going to have the speaker on site, but our dear colleague and friend Jem Chali sent us a presentation, and here he is, his presentation. By the way, he's watching us. In the communication with him, I realized that he's present actually online, so he's watching, and this is the good time to say hello. We are missing you here, but at least your presentation is here. Welcome, Jem. Can you hear us?
Hi.
Ah,
Hi.
hello,
Thank
hello.
you. How are you?
Fine, thank you. You?
Yes, thank you very much. I'm so sorry that I could not be physically there.
We are sorry too, but this is at least one of the advantages of those technologies that we have nowadays, so it's a great pleasure to see you. And we are waiting for your presentation now, so are you going to give us the presentation now?
Well, we have a recorded presentation, so I'm here for any questions.
Yeah, this is what I thought, so I think the presentation should be here. Apparently, I'm not sure if we have it. Can you please wait just for a second?
Yeah, I'm here.
Gospodin je poslao prezentaciju, on mi je tako i rekao, tako da bi prezentacija trebala da bude kod nas. Možda bi mogli da zamolimo profesora Lučića da predstavi svoju prezentaciju, pa da umeđu vremenu vidimo ako možemo da proverimo sa prezentacijom od profesora Čalija. Excuse me, we are going to call you back in half an hour, and then actually in half an hour, and in the meantime Miloš is going to give a talk, okay?
Yes, okay.
Okay.
You cannot find it, I can do it online again.
Okay, thank you.
And many regards to Miloš.
Thank you, thank you.
I'm going to try to replace you with this presentation. Ladies and gentlemen, it is my sincere pleasure to address you today, and I would like to express my gratitude to Professor Maksimovic for this kind invitation. I think that today I'm not going to be as exact to teach you how to make the exams, but I will instead try to do something that could be a warning of the cutting edge of technology that is emerging, firstly in radiology and then after in some other fields, including the whole humanity. But the fact is that we are all talking about the AI recently. Artificial intelligence is something that is all around us and that is actually conquering the field of radiology pretty much, and soon it will be irreplaceable in our daily work. But at this very moment, I would like to start with the last words of Jorge Luis Borges' Los Conjurados, or The Conspirators. He said, ¿acaso lo que digo no es verdadero? Ojalá sea profético. That means, if my words are not true at the moment, perhaps they would be prophetic. So, these wise words are actually just the beginning of the fact that radiology today is based on several values, and one of these values is, of course, evidence-based medicine. That requires also the evidence-based radiology, and we are all aware of the fact that the procedure, how to treat and how to apply the technology is related not only to clinical results, but also to the technological potential of the diagnostic methods. Now, we went one step forward. We shifted the whole paradigm, and actually today we're dealing with a value-based radiology, which includes the financial moment and the aspect where we actually have to consider how much do we have to pay for the exam, and what would be the final benefit, what would be the value of the exam for the patient. On the other hand, we are shifting even one step forward. We are not still there, but precise radiology, precise medicine, and precise health are something that is emerging. And that means that we are actually dealing with smart devices, smart gadgets all around us, including our homes, including the toilets, including the shirts, that would use a specific and very sophisticated methods to screen for the breast carcinoma, for the rectal carcinoma, for diabetes, and so on and so forth. So these are the things that are going to emerge in the future. Nowadays, in the upcoming radiology trends, but also medicine, is patient-centric value and quality. And this patient-centric value and quality is the center of our professional development. That means if the patient is in the middle of all our interests, of all our professional interests, that doesn't mean that our family and our beloved ones are not the center of our world, but the center of our professional interest is the patient. And the patients would like to have information on okay, the patient would like to have the information on what is happening with their exams. They would like to have the ability to appoint the exam as quickly when needed in the near and convenient location. That means in a hospital near to their residency, and they would like to have, they expect to have the great customer service, and of course they need to understand the costs of their exams, and this is what is today presented to all of them. Of course, there is a problem, because in radiology, 450 million people will have a need for diagnostic imaging in the whole world, but 90 million worldwide will be misdiagnosed. Why? Because we don't have enough radiologists. We don't have enough competent radiologists, and we don't have enough equipment in the world. And of course, 2/3 of the world population lack access to the radiologist. Could you imagine that? And this is one of the facts that World Health Organization presented 2 years ago. So, patient-centric value and quality is actually an excellent concept. And this is what I'm not going to enter because we are lacking time this time. I'm not going to enter into all of the aspects of the patient-centric value and quality. Please do read this excellent article in Telematics and Informatics. It will explain everything. The fact is that in the whole system, machine learning, algorithms, engineering, data science, and analytic systems are actually very important. So that means the future is already here. And this future fell on their knees in front of one simple virus that actually defeated the whole medicine and the whole human society globally. So where is actually the balance today? I don't know, but we are proceeding with these algorithms and with the AI. What is actually the basis of AI in radiology? It is based on quantitative imaging biomarkers. And these biomarkers are actually the characteristics that are objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, and or as a response to a treatment during the therapeutical interventions. And the difference between the biomarkers, biological marker, and quantitative imaging biomarker, or QIB, is actually in the fact that we can image the data within the images that are produced in radiology. So in neuroradiology, we went far away, and neuroradiology is at this very moment leading the whole process. And the biomarkers must be fully non-invasive. They should provide different contrasts. They should enable insight into the brain, but not only in the brain, but the tissue of interest. Be measurable and be quantitative. They should enable the analysis of the whole organ, brain in this case, and specific tissues. And they should be a portal to beyond image analysis. Now, in regard to beyond image analysis, why radiology? Why not pathology? Pathology is perfect for pathology. It's perfect for digitalization. Why? Because radiology is already digitalized. The pattern recognition, that is the basics of pathohistology or histopathology, is not applicable at this very moment because histopathology is not digitalized. We produce digital images. And these digital images are not the images anymore. I spoke to Professor Alexander Margulis before, 2 years before, when he became a golden medalist of the European Society of Radiology. And we had this discussion that images are today much more than data, and than pictures. They are data, and these data are not only the data that we see. There is a huge amount of data hidden in the digital images, beyond the picture that we can see as a radiologist. So we have to dig for them, and these data are called radiomic data. Now, nowadays, radiomic is not only radiomic, it's radiomic, radiometabolomic, radioproteinomics, radiogenomics, and so on and so forth. Even if you read I Tumori, Italian oncological journal, you will see that actually there is a whole master class education, 1 year of education, and you become Master of Omics at the University of Milano. And this is amazing because, you know, we are going forward, we are going into the digital, and this is the unstoppable process. As I already said, the human civilization already fell on the knees during the recent events, during the pandemics. But no, we are continuing with the digitalization. And what are our biomarkers in radiology? They provide different information. Those information could be anatomical, structural, functional, dynamic, molecular, and so on and so forth. But the techniques are different. So we can use different techniques to obtain those information. And of course, we can use a lot of biomarkers starting from number of lesions, location. These are also biomarkers that provide information, but also cellularity, axonal, myelin damage, brain activation, connectivity, vascularity, perfusion, capillary permeability, and finally in molecular and hybrid imaging, metabolism and biochemistry. And to stress again, the most important characteristic of a qualified biomarker is biological relevance to the disease process, study sensitivity, that means diagnostic value of the biomarker, and reliability, read good reproducibility. Because if the biomarker is not reproducible every time we use the same technique, then we cannot use it. And where are the backdraws in the whole process? Since the imaging biomarkers must be accurate, specific, sensitive, validated, objective, and precise and reproducible, the problems occur in the process of imaging acquisition. First, because different vendors have different ways to acquire the images. Then, image contrast is related to different protocols. And these different protocols, different sequences, different ways how to obtain the image will provide a different contrast. Image processing and image post-processing are different story. Here we have different softwares, different methods, so the variability of the image quality is present. And the last but not least, image interpretation. It depends on the expertise of a radiologist. Variable interpretation means not every radiology has the same level of expertise, same level of knowledge, and same level of experience in reading the images, and that produces errors. So the errors are solely human-based in this process. What does it mean? It means here comes the objective guy, called artificial intelligence. Is it objective? I don't know. But the fact is that recently you had the opportunity to read the interview of Blake Lemoine and his conversation with Lambda, which is Google artificial intelligence. He implied that Lambda is feeling like a human being. Of course, there is one very important thing that was not performed, and this is a Turing test, because without the Turing test, you know who Alan Turing was. A famous mathematician that actually broke the Enigma code during the Second World War. He placed the basics of artificial intelligence already in the first half of the 19th century. So the fact is that can artificial intelligence be conscious? This is for something else. Today, we are dealing with a lot of AI companies, and this is normal because the amount of money that is in the area of artificial intelligence is huge, is humongous. And because of that, we have a lot of companies dealing with it, and in radiology, and we have different companies dealing with different body parts to try to provide the information plus in the process of image production and image diagnosis. The fact is that most of us do not understand what artificial intelligence is. Recently, I received the request for peer reviewing of one of the publications, for one of the journals, and there was a simple error, because we need to understand that we start from the neural networks, and these neural networks are subsets of a deep learning system. a lot of neural networks that are the most simple algorithms in the field will try to train itself to perform tasks like image recognition within the deep learning protocol. Then, in the machine learning protocol, a subset of deep learning, many of the complex algorithms will join together in order to enable machines to improve at tasks by adding the experience. And after that, artificial intelligence that will mimic human intelligence using logic, if-then rules, and so on and so forth. So this is the order. And in radiology, at this very moment, the most important task is to automatize the image feature detection and analysis. So, what will become when diagnosis is automated? Well, let's go to one example, shall we? Usually, unlike MRI, CT is considered as much more simpler. I don't know if there are many radiologists in the audience, so do you agree with me? CT is simpler than MRI. I prefer MRI, but we will stay on CT postulate this time. So this is a CT matrix, and this is a CT scanner. Why CT matrix is not two-dimensional anymore? Because we are not acquiring scan by scan. It's not computerized axial tomography anymore. It is MDCT, multi-detector or multi-spiral CT, so we acquire the volume. And from this volume, we actually extract the images that are readable to a radiologist's eye. And these images are here, a normal window, the bone window, and a subarachnoidal window. Usually, these three windows we use for CT, head CT. But the fact is that there are 4,000 Hounsfield units between air and bone, actually. And there are 256 shades of gray that are recognizable by your screens. That means your cell phones and so on and so on. When we window to create these images, we are actually limiting the data and narrowing the bandwidth to increase the contrast to be seen by human eye. But the fact is, we are losing data. And these data that are preserved are understandable and readable to human eye and to radiologist's brain, because we need the radiologist's brain to read those images. But radiologist's eye can distinct less than 30 shades of gray on images, not even those 50 from the literature. And the fact is that these limitations are present if we want human brain, radiologist's brain, to read images and to create the radiology report as the final product of radiological exam. Now, can you see what is on this image? This is the simplest example. I don't see anything, because the brightness is -99 and the contrast is +81. And let me tell you, this is something that I would like to possess very much and to drive. Now, with the different windowing, you see what is this. It's a Aston Martin DB5, James Bond famous car. So it's a dream, but you cannot see the dream, although the dream is there. Windowing is influencing what we see. Now, artificial intelligence does not have this problem. Artificial intelligence see DB5 even on the first image. And they are reading raw data and creating radiology report on the basis of the reading data. Where is the problem? The problem is in the black box protocols that are actually affecting what AI produces in the radiology report, and is this the same what the human eye sees? Why can't we validate those data at this very moment? Because there are no human influence. How AI actually explains and learns within the black box protocols, how they learn to recognize what they should see. Now, one of the examples that appeared a couple of years ago is a genius synthetic MRI concept, where actually all of the data are within one sequence, and you extract out of this sequence what you need: T1 signal, T2 signal, T flare signal, stir, S-tau, inversion recovery sequence, very important, we always forget that, and of course proton density, the genuine MRI sequence. So this sequence allows us to create one sequence within 6 minutes instead of using all of these sequences separately in an exam that lasts more than 30 minutes. The next step arises from Mark Griswold's research on MRI fingerprinting, where actually we use the rapid one-scan approach to quantitized MR imaging. Why is quantitative MR imaging important? Because here, with the MRI fingerprinting and quantitative MRI, we're not fighting against the physics. We are not fighting against the law of physics. We are actually trying to produce the signal that is readable to machine. And then every single voxel out of this gained and received data will be compared to some remote database, like when police or FBI, I don't know, who is using the fingerprints of the suspect, and then compare it to some remote basis of the fingerprints, and they receive the match. Here we receive the match what is within the voxel. Is it partly tumor? Is it normal? And what is the percentage of a normal tissue, what is the percentage of a pathological tissue, and so on and so forth. So we're creating the picture, and this is the example that this is not only in neuroradiology, this is also in cardiac imaging already present, and you will read about it in the upcoming years. Mark Griswold has more than 100 PhD students of physics working on these facts. Now, in the application of the AI, a limiting factor is if you want to introduce the AI into your institution, into your hospital, you will face many different steps that you need to pass. The major problem is, of course, clinical use and validation, certification, and deployment. Why? Because radiologists are those who are not willing to use a new technology. Is this a fear? Could be, because if we understand the concept of a market, and this is the concept of a marking, renovation, still share from competitors fast within current category and occasions, remains within a category and the main consumer set. So this is something how to improve your business. Innovation grows entire industry or category through new occasions and users, while also driving major share growth. But disruption that emerges here creates an entirely new category or market. It is reinventing consumer behavior. And why am I saying this? Because the digital disruption is entering into the radiology. Not entering, it is already there. So, two views are presented here. One is the view of Keith Dreyer, who said that the radiologists will be the centaur diagnosticians, allowing machine to make us smarter, help us do more, and give us more value. That means we are going to be hybrid radiologists. The other one is more pessimistic by one neuroscientist, Vivian Ming. She is completely dark in their thoughts. She said, there is no single human skill that cannot be done by robots or artificial intelligence, so do not enter radiology. We should perhaps rephrase the question. We are facing the time when the radiologists are going to stand against AI, like Ned Ludd, you know, for the Luddism during the Industrial Revolution in the UK during the entrance of the steam engines into the industry and the production. They tried to destroy the machines. So is this the possible scenario? We'll see. But the fact is that most probably we will have radiologists without the use of AI and radiologists enhanced by AI. So the fact is that singularity is already there. You know what the singularity is. It is actually one of the possible definitions is the creation of greater than human intelligence. But the singularity also exists in the black holes, and this is the place where the gravity is so high that everything else stops to be visible or exist. Singularity in the human and machine intelligence is actually the point where one meet another. It is considered that the first indication and the first idea of singularity was presented in one of the NASA technical report in 1993. You can read this report. It is available in the open access on this address. So the fact is, how are we going to survive as a human civilization in a post-human era when smarter intellect would exist on our planet? And the fact is that human intellect and the human knowledge grows exponentially. The machine intelligence grows with geometrical progression. So this is where we met. We already met. Singularity is behind us. What will happen in the future? The fact is that quantum computers brought a new dimension into the computation, and the difference between the bit as one single information in today's computation is in a binary system. That means 0 or 1 is actually replaced by a qubit, and a qubit is actually 1 bit to we don't know how much squares, n squared. Why? Because one quantum can be at the same time, at the same place, at the same time, at a different place, and at different places in the same or different time. So machines are getting smarter, and one of the definitions is also a point at which our prediction about the future breaks down. So the possible outcomes of this lack of knowledge, what is going to happen in radiology, what is going to happen with the artificial intelligence is, of course, AI scenario, which we have artificial intelligence, superhuman, human artificial intelligence within the computers. Intelligence amplification is another concept. Intelligence amplification tells us that the human intelligence will be increased to brain-to-computer interfaces. Biomedical, internet, and digital Gaia are also different scenarios that may appear. Time frame is expected by 2030. It's very near. But to tell you about the amplified intelligence amplified, Elon Musk has recently, a couple of days ago, received the FDA approval to start testing his neural implants that would serve as the interfaces between the human brain and the machines, computers. So FDA approval is there. He's starting to testing on the humans. And when we would speak about these things, that brain-reading computers may record the words that we didn't see, would look like a science fiction. But the fact is that several already published articles would prove that this is not the case. Brain waves are readable by quantum computers. So another scenario may occur, and this is BioNet scenario, biological network of brain-to-brain interfaces to create one super consciousness. This could be science fiction, but it is not. In scientific reports, 2090s, the first communication between enhanced by a computer between two human brains were actually proven in one of the labs. Until then, the patients would still need to come to our centers for the diagnostic exams and would not be allowed to send their to scan themselves by accessible applications. But the problem at the end is as it is today, the level of entropy and insufficiently unreviewed information that are widely accessible on a World Wide Web is growing unstoppably. On the other hand, the qualified knowledge is constantly decreasing. Why? Because the educational processes are not getting better. They are losing their quality. And because of that, then the time when the general level of insufficient education prevails, the scientifically based knowledge, the gate for the new dark age reopens. And dark ages, we had several in the history of humanity, in the antique ages, in the Middle Ages, so on and so forth, many times. What are the gates for the triggers for these situations? Is pandemics, lack of knowledge, increase of global stupidity, and losing the scientific knowledge in the process continuously. Now, I will just imagine that there are people who believe in Terry Pratchett's great twin and believe that the world is a flat disk. I like to read him, but I like to read Terry Pratchett, but of course I don't believe in it. Hopefully you do not too. At the end, instead of conclusion, be careful with what you see and be careful with what you don't see. This is the future of radiology. Thank you very much.
Thank you very much. It is a really great pleasure. It's a nice wrap-up of the session. This is how we actually planned when we were designing the session. Professor Lucic always give us another view on the current issues in radiology about where we are, and as you said in your presentation, regarding the human intelligence and technology intelligence, we have already met. So we are living actually in this area already. So what the future is going to bring us, we don't know actually. But let's hope for the best. I hope we are going to avoid this dark age that you have mentioned as one of the last slides. Thank you very much once again. We really, I can say, I think, on behalf of all of us, we really enjoyed the presentation so much. I would like to ask the technicians, do we have the presentation from Professor Charlie? Okay, nice. Here we are.
Hello, Margaret. Hello, my Serbian colleagues, friends. First of all, I want to apologize that I could not be with you in Belgrade physically. And also, I want to thank Professor Maximovic for her kind invitation. What I'm going to talk in the next 20 minutes is how we image the brain tumors. I'm Professor Dr. Cem Çallı from Izmir, Turkey. Today I'm going to talk about the role of imaging before treatment, because I don't have time. Perhaps next time, if we have time, we can talk about the after treatment brain imaging. What is the goal of imaging actually when we talk about the brain tumors? First of all, when we do the imaging, we should say that is it a tumor or it's not a tumor? This is the most important thing. Then, if it's a tumor, what type of tumor is this? So, only the imaging findings are not always enough for that. So, what you have to do, you have to look at the age of the patient, definition, duplication of the tumor, and the signal intensity on MRI, density on CT sometimes is very helpful. And also we should look at the enhancement pattern, and still can be made the differential diagnosis. Not always we can do the differential diagnosis, but then we have some other techniques, especially MRI techniques, which I'm going to mention today. So this is a T2 weighted image, and this is a post-contrast image, and what we see here actually, that is a hyperintense lesion which shows heterogeneous enhancement. So it might be an anaplastic astrocytoma, it might be glioblastoma, maybe lymphoma or metastasis. Well, actually, it's not always easy to answer with this conventional pre-contrast and post-contrast images. Sometimes you might be astonished by this. Well, the neuroimaging techniques I mentioned about CT, but today I'm going to mention mainly on magnetic resonance imaging. So with the magnetic resonance imaging, actually we have the conventional MRI, I mean the T1 weighted images, T2 weighted images, flared images, and so on. Well, actually, if you are dealing with the tumor imaging, you need the other ones like diffusion weighted imaging, diffusion density. diagnosis. One of them is actually the isostrat dehydrogenase, which is, if this is a wild type, although the imaging findings tell you that this is a low-grade tumor, it is actually, if it's ADH not mutant, but a wild type, now it's a glioblastoma. So it's a high-grade tumor. So the imaging findings may not fit with the final histopathological or molecular diagnosis. So this is very important. In 2016, actually, the WHO 2016 classification, we are introduced with the IDH mutations, BRAF mutations, H3K27M mutations, and so on. So we were just getting used to them as a radiologist, but then in 2021, we have actually more molecular techniques that actually it's not always possible to find these, to show these mutations or alterations by means of imaging. So it's really difficult for us nowadays. And also what has changed, if there is actually, we were saying, if the tumor was IDH mutant and grade 4, we were saying that actually it's a glioblastoma, but it's also changed. If the tumor is IDH mutant, we now call it astrocytoma grade 4. Well, if to say glioblastoma, the tumor should be actually IDH wild type. This has also changed in 2021. Another imaging technique which helps us very much is actually the diffusion-weighted imaging. What we expect with the diffusion-weighted imaging, it's very useful actually in the differentiation of a high-grade glial tumor from lymphoma. So it's important preoperatively to have this differentiation. The reason is that the operation, the surgical planning, and after the surgery, the chemotherapy schemes are completely different. So actually, when we look at these tumors, this is a grade 3 glial tumor, this is a grade 4 glial tumor. We have, from the diffusion-weighted imaging, we can calculate the apparent diffusion coefficients. It's almost the same. We cannot make the differentiation. But in this case, there is a very low ADC, and you can also calculate it's prominently less than the other glial tumors. But actually, this is lymphoma. So lymphomas, because they are very hypercellular, they show diffusion restriction, and it helps us, diffusion-weighted imaging helps us to make the differential diagnosis. Here we have an enhancing lesion in the midbrain with a little bit edema around it. When we do perfusion, the perfusion is increased a little bit, not too much. So it's about 1.5 or 2 folds when compared to the normal white matter. And also we have an increase in choline, and we have diffusion restriction. So diffusion restriction and little bit increase actually in the perfusion. So this is actually a lymphoma. It's a typical for lymphoma. Another case we see in the bilateral thalami and also the basal ganglia enhancing heterogeneous enhancing lesions. When we look at the diffusion-weighted imaging, we have these dark areas on ADC map. So there is diffusion restriction. When you do the perfusion, there is a little bit increase, not prominent, but a little bit increase in these enhancing areas. And also, this is also very typical for lymphoma. This case looks similar like the previous case, and what you see again in the both basal ganglia thalami enhancing lesions, and we have a little bit diffusion restriction, yes. So we thought it might be a lymphoma, but when you do perfusion, actually, there is a prominent increase in this tumor. Like you see the red areas over there, here, and also here. So this is a prominent increase, and this is not compatible with lymphoma. So this is actually a glioblastoma. As you can see here, the perfusion increase. So perfusion helps you very much. When we talk about perfusion, we have 3 methods actually. The ones that I showed you till now was dynamic susceptibility contrast, which is a very short one, and it's very practical to use it. There is another one, a longer one. Again, but you do it with the contrast, which is called the dynamic contrast enhanced perfusion. The other name is T1 perfusion, and the other name is the permeability imaging. Again, with this glioblastoma case, you can see the increased K-trans and also increased extracellular volume within the glioblastoma. With the low-grade tumor, although it shows enhancement, there is no increase in the T1 perfusion. And also, this is another case. In this case, be careful that this is the diffusion-weighted imaging, and this is the ADC map from the diffusion-weighted imaging. What you see actually is the diffusion restriction. I told you if there is a diffusion restriction, it might be a lymphoma, not a glial tumor. And when you do actually here the perfusion-weighted imaging, there is an increase about twofold. So for glioblastomas, it's about 5 to 6-fold increase in perfusion, but actually for the lymphomas, it's a less increase. So diffusion restriction plus we have this mild increase in perfusion. Again, this is a lymphoma case. So with this case, if you do T1 weighted perfusion, you see very low values of volume, extracellular volume. And also just to compare, to differentiate using T1 weighted perfusion, it's very easy to differentiate between the glioblastoma and the lymphoma. So one of them shows very high perfusion and the other one shows low perfusion on T1 weighted perfusion images. So coming to MR spectroscopy, I mentioned a little bit about MR spectroscopy. What we expect with the low-grade tumors, actually, we expect to see a decrease in N-acetyl aspartate and increase in choline. Well, with the people say that with the higher grades, you have more increase in choline. In those cases, more than 2-fold increase. But in this case, when you look at this one, there is almost more than 2-fold increase in this case. Well, but it's a low-grade tumor when looking at the perfusion. So for the differentiation, for the glioma grading, actually, perfusion is much more trustable when compared to MR spectroscopy. So you cannot trust the MR spectroscopy for the tumor grading. Another thing that you can use to differentiate the low-grade and high-grade tumors is actually this one, which is the susceptibility weighted imaging. It has been shown that in the low-grade tumors, there are small hypointense areas, but this is very less. With the higher grade, you see much more, you start to see much more, and with the grade 4, highest grade, you see a lot of microbleeds inside the tumor. So which is called the ITSS, intratumoral susceptibility score. You can also use this one with the S susceptibility weighted imaging to make the differentiation. And you can see here in this case, in the both sides from the corpus callosum lesion, there is an expansile lesion which we call shows heterogeneous enhancement, which we call the butterfly glioblastoma. And then with the susceptibility weighted imaging, you see a lot of microbleeds, so saying that this is a high-grade glioma. And another case for you, just to show you again, this is a high-grade glioma, glioblastoma, grade 4, and you see a lot of hemorrhage inside it, so you can use it. Another finding that I want to tell you is this one. So we have a T2 weighted image hyperintense lesion. This is the flare, and this is the post-contrast. There is no contrast enhancement. So for conventional imaging, we say that this is a low-grade glioma. And also when we do perfusion, there is no increased perfusion, again, in favor of low-grade glioma. And when we do SWI, there is no microbleeds inside, again, in favor of low-grade glioma. But there is an interesting finding here, which is actually called the T2 flare mismatch. When you look at the flare image, you don't realize it on T2, but you see there is actually a hyperintense rim around this. So this is actually typical for IDH mutation. So this tumor is an IDH mutated tumor. And also another tumor here is, as you can see, in the frontoparietal lesion. There is no contrast enhancement. That's good. And there is no diffusion restriction. There is no increase in perfusion. Again, in favor, all of them are favor of in a low-grade glioma. But here, SWI can help you, because with the SWI, you may not need a computed tomography. because you can see the calcifications here. So the calcifications are on the SWI images are hypointense like this one, and also they are also hypointense on phase images, so it's with the calcification. And of course, if the tumor has a calcification, you might think of oligodendroglioma instead of astrocytoma. So, of course, to say with the new classification that it is a oligodendroglioma, pathologically, you should correlate it with 1p19q co-deletion. So this is also important. Another lesion in the left cerebellar hemisphere, there is a prominent edema around it. And what we see here, there is an enhancing lesion, no diffusion restriction. My first diagnosis would be actually a metastasis in a patient with 50 years old age. Well, when you do perfusion, there is a prominent increase in the perfusion. So this prominent increase, when you compare, when you measure it, it's more than 10 times increase, 12 times increase. So this is very typical for a tumor which is called hemangioblastoma. So with the help of perfusion, you can make this differentiation from metastasis very clearly, because in metastasis, of course, you expect an increase in perfusion, but not as much as this one. So this is the tumor which shows the highest perfusion, and the preoperative diagnosis is crucial because these tumors tend to bleed a lot during the operation. So it's better to preoperatively know that for a neurosurgeon that this is not a metastasis but a hemangioblastoma. Ring enhancing lesion. This is just to show you how perfusion helps, and also how diffusion helps. When you look at the center, there is diffusion restriction. So this is typical actually for a pyogenic abscess, and this is not a tumor. And when you look at the enhancing part, actually the perfusion is less than the normal white matter. So if it was a tumor, we would expect increased perfusion, but now the perfusion is less than the normal white matter. So this is actually, all the findings are compatible with an abscess, not a tumor. So you can make the differentiation by means of diffusion-weighted imaging and also the perfusion-weighted imaging. So for the biopsy guidance, when you want to do a biopsy, what you want to do is you want to target the high-grade areas. Of course, you can use spectroscopy. This is the spectroscopy from the normal area. So the NAA is the highest. This is from the low-grade area. We have a little bit increase in choline, but in this area, there is a prominent increase in choline. And also enhancement is over there. And also when you do perfusion, the increased perfusion areas is over there. So if you want to do a biopsy from this case, you should target actually this area. So for the surgery planning, you should both do, if the tumor is located in the eloquent area, so you should, like the motor area or the speech area, and then we use preoperative the functional MRI and also MR tractography. So with this MR tractography, you see what you see here is actually the corticospinal tract, because the surgeons doesn't want to injure the motor area and also the corticospinal tract. Otherwise, the patient will be hemiplegic after the operation. So in this case, the motor area is anterior and displaced anteriorly when compared to the normal side. It's not in the posterior, it's in the anterior location. And also when you compare both corticospinal tracts with MR tractography, it is medially displaced. So don't touch the anterior and don't touch the medial part of this tumor. And of course, you can show them together. So if the tumor, to take this tumor out, the approach should be on the posterior, not touch the anterior, not the medial part. And also, again, another tumor here, which doesn't show enhancement, and also it's a low-grade tumor. There is no perfusion increase. But when you do for the motor area, is what you see. There is the motor area is just lateral to it, and the supplementary motor cortex is in the medial. When you do MR tractography to show the corticospinal tract, it's in the anterior and posterior. So it's intervene the corticospinal tract. So it's very difficult to take this tumor out. The reason is that actually in the anterior, in the medial, in the posterior, in the lateral part, there are motor areas which is very difficult to take this completely out without harming the patient. I will finish with this case. I showed you this case, this high-grade glioma. This is located in the left hemisphere, the dominant hemisphere, and the location is very close to the Wernicke's area. So they wanted to know if the Wernicke's area, where is it located? And then when we do perfusion MRI, functional MRI for the speech, we see that the Wernicke area is just posterior to the tumor. So don't touch the posterior. The tumor is here, and also here is the Wernicke's area, and here is the Broca's area. And then, of course, there is a fasciculus connecting the Broca's area and Wernicke's area, which is called the arcuate fasciculus, and the arcuate fasciculus is here, as you can see. So the tumor is here, the arcuate fasciculus is in the medial part, and the Wernicke is in the posterior part. Don't touch the medial and don't touch the posterior part. So this is very important. So to take home messages, conventional MRI like T1, T2 weighted and post-contrast images, of course, they are the gold standard technique in the tumor diagnosis. For the glioma, of the differential diagnosis of glioma, you should use the diffusion-weighted imaging, perfusion-weighted imaging, which I like very much. And also you can use the MR spectroscopy in some cases. For the grading, I would suggest to use the perfusion-weighted imaging. So also for the differential diagnosis of lymphoma, primary central nervous system lymphoma, of course, ADC, I mean the diffusion-weighted imaging is important. So for the surgery or radiosurgery planning, you should use the diffusion tensor imaging, which the other name we call MR tractography, to show the tracts, and also functional MRI actually to plan the surgery. So thank you for your attention, and I wish you will have a successful Congress.
Charlie, for a wonderful presentation, but we are running late with our session, so we have to postpone the questions for the next time that we see you. Thank you, all the lecturers together, and see you some other time. Thank you.
Dear chair ladies, dear guests and colleagues, welcome to this session about cardiomagnetic resonance. That is hot topic, not only in Serbia, in Belgrade, but also in the whole world's cardiologist and radiologist sessions. This is a night moment. We have here the National Congress of Diaspora, and this is the nice opportunity to meet us and exchange our knowledge, also our experiences. I am very proud that I have privilege today to be the co-chair lady with Professor Ružica Maksimović, who built all in cardiomagnetic resonance together with Professor Ida Jovanović. I've been learning a lot from them, and this is the special privilege for me to have the session today, but also to have very important speaker, our guest, Professor Robert Manka, who is coming from University Hospital in Switzerland, in Zurich. And I would like to say just shortly that I met Professor 7 years ago when I was there for the postgraduate course in heart failure. But our friendship and professional cooperation is very strong and resulted in several education of our younger colleagues that were accepted in Zurich Hospital and that could have the opportunity to find the knowledge and to share the knowledge. And this is the main conclusion of every successful Congress, to share the knowledge. Please, dear Professor Manka, take your position.
So, thank you very much, Maria, for this kind introduction. Thank you very much for the faculty and for the chairperson to invite me to speak about my passion, which I always like to share with all the audiences and all the doctors that I meet. So I have to have this presentation was given to me to speak about arrhythmogenic cardiomyopathies, which is a hot topic, I have to say. It changes a bit, so I will try to find the way through so you will easily understand what happens there. So first, we have to say that the classification of arrhythmic cardiomyopathies is a bit complicated. And most likely you cannot read all the small parts because it's a little bit too small, but I will try to guide you through this within my presentation. So it's quite easy to remember. So we have cardiomyopathies which are connected to the desmosome of the myocytes in the heart. And then there are non-desmosomal diseases which are classified as special mutations of special proteins in the myocardium. Then there are neuromuscular diseases like the most people of you know, like Duchenne or Becker. Then there are inflammatory diseases. Then there are arrhythmogenic cardiomyopathies inherited within the electric system, congenital ones, and also special infectious diseases like Chagas, we know from South America, like Brazil. So I have talked now about desmosomes. Sometimes this is not clear what a desmosome actually is and why this brings cardiac arrhythmia. Just to go back, desmosomes are the part in the heart that connect the myocardial fibers, and they're made out of proteins. And if you have a genetic mutations, mostly these genetic mutations affect those proteins, and by destroying those proteins, they change their function, and they get fibrotic, they get fatty, and by this they induce later arrhythmias. And in the past, when we talked about arrhythmic cardiomyopathies, we mostly talked about right ventricular diseases. But now, over the year, this knowledge has changed, and we don't speak anymore about ARVC. We speak about arrhythmic cardiomyopathy, and we decide on which gene affects which parts of the heart. So we have genes like the PKP2, which is the most prominent one. It's the plakophilin 2, which mostly affects the right heart. But it doesn't mean that at some point of progression of the disease, it will also affect the left heart, right? And then there are genes that are mostly prominent on the left part of the ventricle. You see the F, this is the FLNC, it's the filamin protein which gets affected, and this disease is mainly at the left. But at some point this can progress over time and will become a biventricular disease. And if we get a patient in the scanner, we never know at which part of the disease we see him. It's not that all those diseases start early, like in adolescence or at young age. There might be triggers like sports, for example, which can enhance the disease, so we don't know where we see them. So just looking at the site where these genes affect the heart is not enough. We have to somehow find out at what stage we see those patients. The European guidelines of cardiology, they give us a strong support to use CMR in patients with arrhythmic cardiomyopathies, but also in patients with heart failure. And actually in all patients, this is very helpful because CMR is the method. We call this gold standard for assessing volumes, the myocardial mass, and the ejection fraction. And it's the preferred method to diagnose fibrosis. This can be done by late enhancement, focal fibrosis, or diffuse fibrosis using mapping techniques. We will hear about this in the other presentations as well. And it's the only method actually to detect myocardial edema using black blood and T2 mapping. So CMR is actually like a box of chocolates, I would say. You can choose what you do. You can eat them all if you want. You can have the sweet ones, the bitter ones, with the nuts. So you just pick what you want and you put them in the row. So first, usually, you start with function. Function is the mainstay, and from function you will already know a lot. So I will show this in some cases. You can add ischemia, you can add tissue fibrosis, you can add flow, and you can do all this in about 45 minutes during a scan. So here are some examples. So because speaking about images and not showing that, it's not fair, I have to say. So you see on the left side, you see a normal heart. So everyone can easily realize that this is a normal heart. Your normal chamber, normal sizes, function is normal. In the middle, you see a dilatation of the left ventricle, and you see trabeculations. You can nicely detect this by the first view. And on the right side, I'm sorry that the movie is not running, you see a dilatation of the right ventricle. So from the first glance, you already know which is the problem and where I have to look more for it. Using those fibrosis detection, we can decide if this is interstitial fibrosis or reactive fibrosis or infiltrative interstitial fibrosis. So from the techniques we have, we can decide which we have. Usually, when we talk about reactive interstitial fibrosis, this is something that happens to all of our hearts all the time. So it's just a sign of aging. So actually it's a good sign, but at some point it might be too early or too late. We can detect this. Usually it happens when the blood pressure is not controlled well or we have an aortic stenosis. Mainly when people think of fibrosis, it's after myocardial infarction, after myocarditis, or in sarcoid, for example, or in typical infiltrative diseases are amyloid and fibrous diseases, which are not the topic today. By seeing the localization of this late enhancement, we can say which kind of disease we are facing. It helps us. However, in daily clinical practice, this is not always so easy. You see, this is a picture taken from a publication where they always take the most beautiful ones, but in real life we have to know that it's not so easy. But looking at the endocardial localization, it's most likely ischemic. If you have a transmural or an epicardial inflammatory disease, it's very much likely. However, LGE, you have to know, it's an absolute non-specific thing. So only if the interstitial space is wide, it will sit there. It is specific to any kind of disease, so just the localization and the transmurality. So now we start with a small quiz. Maybe some of you know already what we are facing. So on the left side, we have a patient, 60-year-old, normal left ventricular function, right ventricular function is impaired. She comes with non-sustained ventricular tachycardias. The other one on the right, I'm sorry, for you, 40 years old, normal left function, right ventricular function is decreased, also comes with non-sustained VTs. And I think we all agree that both have ventricular dysfunction of the right ventricle, but they look different, right? Do you agree? So the left one is a more global one, and the right one is a more focal one. And this is the clue to this disease, actually, right? But without late enhancement, it gets still very difficult to see. So the next step, as I said, you give the contrast, you do late enhancement, and by looking at the localization, the disease gets very easy and actually quite clear. So the one on the left, you see transmural late gadolinium enhancement, but you see late gadolinium of the inferior wall and the papillary muscle. So this can only be one disease, right? Any ideas? So it must be ischemic, right? It must be ischemic because you have an infarction of the inferior wall of the papillary muscle which affected the right ventricle. And the left one is an arrhythmogenic cardiomyopathy with a plakophilin 2 mutation which affects the subtricuspid area. So if you see this, be always aware in a young patient to see this. Good. These are other examples. This is, as I said, desmosomal disease. It's a biventricular disease. It's a desmoplakian mutation, which is actually more a left ventricular disease. But look at the age. It's a patient 62 years, so the disease already progressed. So you see the thinning of the right wall. You see the thinning of the left wall. You see the fat infiltrations in the myocardium. So this is clearly, at this stage, a biventricular disease. With late enhancement, you see the late enhancement everywhere in the myocardium, around the right ventricle, within the left ventricle. So this, at this stage, is a biventricular disease. This is another desmosomal mutation, which is more early in the stage. You see that the left ventricle is infected with fatty spots. You see late enhancement only in the left. You can suppress this by the techniques, but this is clearly only on the left side. So we are very early in the disease, right? And by seeing this on the CMR, it makes actually easy for everyone to depict this. So you see along the infralateral, these fatty infiltrations, they they call them like red bites, so they are missing this part of the myocardium. And in the past, we always thought that ARVC is the bad part of this disease, but latest publication show that actually the most deadliest version of arrhythmic cardiomyopathies are these ones that affect the left ventricle only. So if you have a patient with this phenotype, you have to be very careful with him, and there's a high risk of sudden cardiac death. And in the past, we thought this is a genetic disease and inflammatory disease. But nowadays, there's new data around that we see that if they start, there is an overlap. At some point, they come as a myocarditis. And this, for example, is a young patient. He was 19 years old, a typical myocarditis patient with a typical location of the late enhancement, like in myocarditis. But it is a desmosomal disease, a desmoplakin mutation, which come with rushes of myocarditis. Then they stay calm again for some time, and then they come again with the myocarditis, and this happens again. So if you have a young patient which comes often with a myocarditis every 2-3 years, you have to think this is a desmosomal mutations which just comes with inflammation. So just to be sure that this is the case. There are differences on the injury and on the prognosis depending on what kind of mutation you have, if it's a desmoplakin or placophyllin, so in which ventricle is affected. And there's one very interesting thing we never talk about, or really little about, is that the heart can get tired. We usually think it cannot get tired, and we call this the ARVC-like cardiomyopathy. It is something that happens mostly to athletes which train a lot, and the myocardium gets tired. And we call this like a desmosomal fatigue. So the desmosomes, they train every day, and by some point they get tired. And this is an example of a 52-year-old. At the moment, he is a master athlete. He has molecular genetic analysis were all negative, but because he's doing this athlete training since already, I don't know, almost 40 years, his myocardium became weak. And so that's why you see from the phenotype, it looks the same as a typical placophyllin mutation, but it's not caused by a disease, it's just caused by tiring, that the myocardium is tired. And we call this the cardiac desmosome reserve. So if you train, it's important to have you have to stop at some point training and continue training, so the desmosomes can at some point get relaxed and they can function again. So have this in mind. You can have genetic negative patients, but because they're doing so much training to the heart, the desmosomes get tired and the phenotype looks at the end the same. These are non-desmosomal diseases. It's the classic titin mutation, which is the most often in dilated cardiomyopathy. You can see this one is a dilated ventricle, recurrent VTEs. You see late enhancement of the septum, and this causes at the end arrhythmias. Depending on how the late enhancement looks like, we have a new entity which we call the ring-like late gadolinium enhancement. You see there's a ring within the myocardium, and if you have a patient with this presentation of late enhancement, they are the ones with the highest risk of sudden cardiac death. So in these ones, again, you have to watch for them. You might introduce an ICD earlier than the recommendations would say, because maybe ejection fraction is still good, but they have a high risk of sudden cardiac death. This is another step from arrhythmias. That's the neuromuscular dystrophy, which we usually know as Becker or Duchenne patients. They have, when you look at the CNE images on the left, you see the CNEs look actually quite normal, and you would think that this patient does not have any problem of the heart. But adding late gadolinium enhancement, you see this whole fibrosis of the lateral wall, and all patients having this in Duchenne patients, they have a high risk of arrhythmia and again a high risk of sudden cardiac death. Another is the inflammatory ones which have to watch, especially also in sports patients or patients after a flu or COVID. If they start too early with the sport, and this is a 36-year-old male swimmer, he was in the national team. He had the myocarditis 13 years ago, and he continued to train, and you see what happened to his heart. He has a typical athlete's heart, a dilated heart, which is okay for an athlete, but if they stop at some point, the heart should come back to some extent, but there shouldn't be any fibrosis, and this patient has a clear fibrosis of the myocardium, of the septum. It tends to be a little bit already like a ring, so these patients are at high risk. So we always need to tell them that they have to recover. Depending on the localization and the extent of this, there's a dependence on prognosis. And a very important inflammation of the heart, it's the sarcoid, which can have many presentations, and you can see this one, it's affected the right ventricle, so you might think at the beginning this is maybe an ARVC or desmosomal disease, but it's clearly an inflammatory disease, and from imaging at this point it is very difficult to see the difference between a genetic disease or an inflammatory disease. Also here, if there is late enhancement in those diseases, patients are at very high risk of sudden cardiac death. So now I would like to conclude my presentation. Cardiac MRI is a strong method. It has a class 1 and class 2A indication by the ESC guidelines. It clearly differentiates, like in our first case, from ischemic and non-ischemic diseases. We can characterize the cardiomyopathies and know their prognosis as a strong partner. But at the end, we have to combine all our information. We need to have our clinical information. We need our imaging. Maybe we need histology in some cases, and we certainly need more and more genetics in order to get the right patient management. And by this, I would like to thank you for the invitation, and also like to acknowledge my colleagues, because I'm here and they have to work at home, so it's nice to have them. Thank you very much, and the motto is from all over the world to Serbia, and now I invite you from Serbia to Zurich. We have our online grant rounds, which are fantastic to join. It's free, it's on Zoom, and we have excellent speakers like Stefan Achenbach, for example, will speak to us in September. So thank you very much.
Thank you, dear Robert, for this extraordinary presentation, as always. I think there is no such disease in cardiology that was more illuminescent by cardiomagnetic resonance than this arrhythmogenic cardiomyopathy that was called earlier of the right heart, and you so clearly show that it could be by both chambers. And I would just like to comment that you show us how important is clinical view and clinical judgment of the patient, and also imaging, no matter of molecular testing. Molecular testing is very important, but even it is negative and we have clinical judgment and imaging view by ourselves, we need to treat the patient. Until some from the audience think about questions, I would invite Professor Ida Jovanovic.
Thank you, Professor Manka, for a fantastic presentation. I'm a pediatric cardiologist, so during childhood, we have really a lot of patients with LBB block, you know, extrasystoles, I mean arrhythmias with the right origin. Majority of them are benign, but some of them not. But bearing in mind that arrhythmogenic cardiomyopathy is late onset disease. It's not starting during the childhood, but we still have a lot of kids doing sports very aggressively. And then something start to change in their hearts. So we offer the CMR, so the borderline findings because of the sport and so on. I would suggest to offer them genetics, bearing again in mind the heterogeneity of those findings, genetic findings.
Yes, I agree. These diseases develop over time, and you might be phenotype negative for a long time. And unfortunately, about 50% of patients with ARVC, their first presentation is sudden cardiac death. We have to know this. So this is important, yeah.
So what do you offer? Would you suggest genetic testing in those
Yes,
kids?
of course, we should do this. And by doing genetic testing, we will also learn from genetic testing, because maybe we don't know the panels we have to use. There are different panels. We might not know what actually there is the clinical relevance at the moment. And on the other hand, sometimes we see a genetic difference, but it might never penetrate actually into any phenotype. So I think we need to learn there as well a lot. Yeah.
Thank you very much.
Are there any other questions? We can also have at the end. Now, thank you, dear Robert.
Thank you.
I would invite Professor Ružica Maksimović about a very important topic on myocarditis. And I would just like to comment that we have some patients that have diagnosis delivered by some doctors that they have myocarditis. But without this clearly diagnostic, we cannot be sure that that is the proper diagnosis. And this topic is also very, very important to judge our patient. Do they have myocarditis or not? CMR, that is supreme diagnostic. Thank you, Professor.
Thank you very much, Maria, for this kind introduction. And this is exactly what I wanted to say at the very beginning, because myocarditis is really the disease with many faces, as we already know. And first of all, I would like to thank the organizer for inviting me to this very important session and to talk about this very important issue, because as we know, the diagnostic procedures are taking place in every aspect of the clinical life, and it is important to know how to handle basically those information that we have. So images are not only the pictures, but are the data as well. Having this in mind, according to the guidelines of the European Society of Cardiology, as we can see here, there are there is a set actually of diagnostic tools that we are using in evaluation of patients with myocarditis. Apart from ECG labs and echo, we are going to talk about CMR, and we are going to talk actually about the different options and diagnostic value of those things that were already mentioned by Professor Manka. So we are going to talk about senior sequences, about morphology sequences, T2, first of all, for evaluation of edema. We are going to talk about mapping, and as it has been already very well known, sensitivity for CMR is really very high. To some extent, it is important to remember that the diagnostic value of individual diagnostic criteria is really different, but altogether, the overall diagnostic accuracy is pretty high. Also, it is important to note that when we are talking about CMR in patients with a suspected myocarditis, as you can see here, the CMR is taking place here among the other procedures. So it is very important to know that we need to have more clinical information. As Professor Manka already mentioned, because he mentioned LG, fibrosis, and these kind of things that we are going to talk as well. That response of the myocardial tissue is non-specific. So we are going to see LG in many situations, in many clinical entities, and this is our task actually to define within which clinical entity it does belong. Okay, it's working. So today we are going to talk about scene imaging. We are going to talk about late gadolinium enhancement, perfusion imaging, and mapping. So the maps are those things that are quite new in the setting of CMR, and we are talking about T1 and T2 images and T2 mapping, similar to those techniques that are being employed in other areas of magnetic resonance when we are using in some other clinical settings. According to the Lake-Lewis criteria, as we already know, we should have certain criteria in order to have the diagnosis of myocarditis. That is myocardial increased signal intensity in T2, which is indicating presence of edema. Then global myocardial early gadolinium enhancement, that is ratio between myocardial and skeletal muscles. So for this purpose, sometimes it was before the introduction of mapping, it was used comparison with the skeletal muscles. And then at least one focal lesion of LG, that means fibrosis. So in those cases where at least two or more criteria are being fulfilled, we are talking about the myocarditis. This is an example of the presence of edema. As you can see, the arrows are pointing out at the edema. So this is of high signal intensity, which means white, similar to the MRI image in all other tissues. So when we see something which is white, we know this is edema. Then we are talking about early gadolinium enhancement. You know that for the late gadolinium enhancement, we are waiting 10 minutes in order to take the image. However, if you do it immediately after the application of the contrast media, you can see hyperemia in case it is being present. And late gadolinium enhancement or fibrosis is the white line which is here. And the distribution is really different depending on the etiology of the disease. But of course, when we are talking about myocarditis, then the situation is more being concentrated on the mid part of the myocardium. So intramyocardial lesions and intramyocardial presence of LG. According to the new development of the software, the reason is that the upgrade of the Lake-Lewis criteria was done as it was published in this paper in 2018. So apart from the main criteria being myocardial edema, non-ischemic myocardial injury, that means injury which is not subendocardial but rather subepicardial, intramyocardial. Apart from those criteria, then we are talking about other supportive criteria like presence of pericarditis, for example. We are going to see a case of the pericarditis together with the myocarditis as well. And of course, we are talking about other things that might be supportive for the diagnosis of myocarditis, like regional or global wall motion abnormalities. In case that we are using those upgraded Lake-Lewis criteria, then the diagnostic accuracy might be up to 95%. When we are talking about mapping, the major thing why we are using mapping is that to identify those areas which might have some pathological problems. You have realized that our eye is sensitive to some extent. It is sensitive to see the difference between normal and pathological areas. However, that is not enough because there are some processes which we cannot really visualize. So that's why, especially in those cases where we have diffuse illness, diffuse pathological process that is going into every part of the myocardium, then we cannot see the contrast. And that's why this is the role of mapping, so T1 and T2 mapping. In T1 mapping, which is based on T1 images in MRI, we may find increased values of T1 maps in acute myocardial infarction, myocarditis, amyloidosis, different kind of cardiomyopathies. On the other hand, we may see decreased values of mapping, like in diseases of iron deposits, fatty tissue disease, and so on. What is important is that first of all, we are using mapping without the contrast media. So we are talking about non-contrast examination, and then it could be followed by, of course, by application of the contrast media. Generally, according to the guidelines that are still existing and are in clinical use, basically we don't need to do T1 after the application of the contrast media. In case that you are doing this, it would be very good to calculate extracellular volume, because it was found out that extracellular volume as a parameter is more stable than T1 and T2. The problem is with both T1 and T2 that they are highly dependent on some other things, like the machine that you have, meaning the number of channels, then the software that you are using, strength of the magnetic field. Also, it is also dependent on the characteristics of the patients, meaning that these normal values, both T1 and T2, are highly dependent on many things and can differ, and usually they do differ among institutions. So if we go back to T2 mapping, which is important for visualization of edema, for example, then we see that there is a limitation in those cases, again, where we have diffuse myocardial edema, because we don't see the natural contrast. So that's why T2 mapping is very important for this issue. This is, in short, the protocol that we are using. I think it's more or less the same now, where the other institutions are also using the same protocol. Again, I would like to stress out that we are using maps, both T1 and T2, and also before the contrast media and after the contrast media, although that is something that is maybe not necessary in case that you don't plan to calculate ECV. On the other hand, why it is important to calculate ECV? Because it is more stable, and then you can really follow the progress of the disease or the regression of the disease in those cases where you do have the follow-up. So this is the reason why we initially defined our normal values, and you can see here. So this is a value that was based on 62 patients, and what is important to note is that there are some differences between mid part of the heart, apical and basal part, and this is in accordance to the data in the literature as well. I would like to show you one patient that was done a long time ago, so before the maps were applied, but later on I'm going to show you some case, a case also where we applied the maps, both T1 and T2. And I would like to show you because this is a really nice example how edema decreased. It is obvious that the patient had edema in many parts, in many segments of the heart, throughout the whole heart, so from the base to the apical area. And then what is also interesting is that late gadolinium enhancement, so that means the fibrosis was really present in almost all parts of the heart as well. That was also proven. That is a case from Professor Ristic, of course. So now we know also what happened with the patient. And anyhow, the patient had the follow-up, and we can see that the ejection fraction was, of course, better. And it is very important to know that there is no edema now anymore. However, regarding the late gadolinium enhancement and fibrotic tissue, that was still present, and this is what we usually do see. It is interesting that there was a big study that was done in patients in Italy. That is a very famous ITAMI study, where they identified actually two patterns of the late gadolinium enhancement. One was this one, which is present fibrosis in anteroseptal part of the heart, and the other one inferolateral. So this is quite interesting for us, because once when you look at it, then just to have idea what the problems may be, because it was shown that those patients with anteroseptal pattern of myocardial enhancement had a worse prognosis and were associated with arrhythmias. And at this point, because we are talking about myocarditis, I have to mention also COVID, because we have a great experience in patients after the COVID infection. I know that Professor Zdravkovic also is in the same situation, because we are contacted a lot about our patients, and privately, I must say. And I just would like to show that interpretation, once when you have enough clinical data, of course it's the must. That is something that we have to have, because as you can see here, in that it was shown in this study, there is any kind of late gadolinium enhancement may be present in the patients after the myocarditis. Then this kind of enhancement may be subendocardial or transmural. It may be mid-myocardial, and the problem is what to do actually with those patients with the subendocardial, sorry, because it is the same pattern that we can see in ischemic heart disease. So that's why it is important to have all the possible information. On the other hand, it is quite clear that myocarditis as inflammation may be combined with some other entities as well. In this study, it was shown how many segments were involved in COVID infection, and I just wanted to show, because this is something that we have experienced more or less in the same, but the thing is that regarding the late gadolinium enhancement, it was really this area that was present, so basal and mid part, inferolateral and posterolateral segments. This is, in short, I'm not going to go into details, but we had a lot of patients after the COVID infection, and the range within which we examined patients was actually pretty wide, I must say, but this is life, because some of those patients who didn't have any kind of cardiovascular problems after the COVID infection started having, so they were de novo basically cardiovascular patients, and this was the reason why we examined those patients. And this is one of the typical presentation, I would say. Male patients that had COVID infection in September 2020, and he had some symptoms like tachycardia, fibrillation, shortness of breath, and so on, without any basically previous finding, and his ultrasound was completely normal. I just wanted to show the results that we have. So we normally do both ventricles, the left and right ventricle, in order to compare the results. And as we can see, his ejection fraction was borderline, and while the rest of the parameters were quite normal. I would like to say that in our center, the normal T1 value is approximately 1,100. So all these values that you can see here, because we then measure at the different points, are increased. So that was the case with the native T1, so before the contrast media, after the contrast media, and then when we waited 10 minutes to actually the contrast media go into the myocardium, then we saw that there are also some focal regions of fibrotic tissue that is present in different areas. And of course, these are different projections, so meaning that we managed to see some issues that was not possible basically to see using any other diagnostic procedure. And I would like just to show you one case with pericarditis, because in our group there were some patients that had associated pericarditis and without associated pericarditis. But this is quite nice. This is almost an example from the textbook where you see diffuse enhancement of the pericardium, which can be seen quite frequently, not frequently really so diffuse and surrounding the whole heart, but more or less more focally. So altogether, with good clinical background and with good imaging, and once when you settle down and your whole system for the imaging, CMR is really good diagnostic procedure and can bring us a lot of important information which are necessary for further clinical workup of those patients. Thank you very much for your kind attention.
Thank you, dear Professor, for this fantastic presentation, and we could learn a lot. I would ask if anyone would like to comment or to ask Professor. For me, it's always pleasure to listen to Professor Maksimovic that put the cornerstone for cardiomagnetic resonance. And we have, through our work, learned a lot about heart. I'm cardiologist, but I could say that until I found cardiomagnetic resonance, I couldn't understand completely all problems in cardiology. And now when I have that images, I quite sure that I understand much more patients' disease. That is something that is very important for me. Would you like to comment?
Yes, I agree completely. I agree completely. It's completely another perspective. So those new techniques are giving us such parameters, especially for the flows, that amazing. We are going completely to change our perspective about the structure of the heart and works. And okay, this is
and to different level understanding.
Yes,
I think
absolutely.
For all of us.
So for all of us, thank you,
Yes.
Dr.
Thank you very much. Thank you.
So our next speaker is Dr. Sarah Elgeman. She is a consultant for adult congenital heart diseases and imaging in adult congenital heart diseases. Dr. Sarah finished her education in Egypt, but now she's working at the Liverpool Heart Center and Chest Hospital in the United Kingdom, as well as the National Heart Institute in Egypt. Dr. Elgeman is extremely active in a European Association for Cardiovascular Imaging. So we are waiting for your presentation, Dr. Elgeman. Thank you.
Thank you. I'd like to really thank all the chairpersons, and I'd like to thank Maria especially. We initially met in Zurich, and I've enjoyed working with her and collaborating with her ever since. So I'll talk about CMR in ACHD. I'm an ACHD cardiologist and an imager, and we are having more patients with adult congenital heart disease than we are children as a result of an improvement in the diagnostic methods to assess these patients, as well as interventions and surgeries that have been going on for the past few decades. So it is really important that we need to know that we will all be seeing more of these patients. Some of these patients will present early on in childhood, in which they'll need to be operated early on, and they might need reoperation or further intervention later in life. But sometimes these patients also get diagnosed later in life. And sometimes we do get some surprises when we initially assess these patients clinically. It is also important to know when assessing patients with congenital heart disease, as they grow up and they go into adulthood, they may suffer from sequelae as a result of their underlying heart condition, as a result of the previous interventions that they've had from the surgeries they've had, as well as these are patients that are young patients and they want to have and live through life normally. The female patients may want to get pregnant, have babies. Patients may present with arrhythmias, and they might present with acquired heart disease, like normal coronary artery disease later on in life. So we have to be really mindful of how we're going to be dealing with this patient population as we are having more adults with congenital heart disease in Europe than we do our kids. So as a result of this increasing population, we will be seeing more patients referred to CMR. And usually the patients that are well known to have congenital heart disease, and particularly the complex ones, they're usually referred to tertiary centers. But we have to keep in mind that many patients are imaged by non-congenital cardiac imagers, as we don't have enough people with a congenital background to image these patients. And they are an increasing population. So it is something that we do have to keep in mind. So in my talk today, I'll talk a little bit, which I've mentioned already, but about the background. We'll talk about a how-to step-by-step approach. We'll talk about disease-specific findings. I really won't go so much into the prognosis today, the use of CMR in assessing the prognosis of these patients. But I promise you, I will get lots of great images. And Oh, this is repeating itself again. Sorry about that. So when it comes to cardiac MRI allows us really to get really good images in which we can assess function, we can get assessment over morphology, anatomy, as well as data on flow, as well as angios and assessment for fibrosis. But we must keep in mind that once we put the patient inside the CMR board, that we have to make sure that we have planned all the images that we want to take and required everything we want to take, and that we've answered our clinical question. Because once patient comes out of that board, we can't acquire any additional images. When we have done with the scan and we come to assess the patient, and sometimes we'll find patients that we think that are referred for just a different type of scan, and we do get surprised by finding a congenital anomaly. So it's very important when we do notice an incidental congenital anomaly, or when we're normally reporting, to always mention the position of the heart, evaluate the visceroatrial situs, in which we can identify that by looking at the atrial appendages, evaluate whether ventricular looping, whether D-looping or L-looping, which is in other words saying which side is the right ventricle in relation to the left ventricle. And I find that just much easier to say that, just say right ventricle is to the right of the left ventricle, or the right ventricle is to the left of the left ventricle. To evaluate the position and relation of the great vessels, determine the atrioventricular and the ventricular arterial concordance, and to look for any associated anomalies that we can assess with these patients. So let's just talk about some incidental or some interesting case scenarios. So in patients that can present to us, and which more of us sometimes we'll see often some incidentally, we see some of the simple congenital heart defects such as ASDs, VSDs, and PDAs. And these can be incidentally, in which we diagnose on the scanner, or they've been referred to us. And here we have a patient in which we have here that there was LV dilatation, and it was just the indication here was to diagnose the cause of the LV dilatation. And this was an incidental finding in which usually we're able to identify this on echo, but it wasn't identified. And we can appreciate here that we have the left ventricle does appear to be larger than the right ventricle. Here, this is a modified view in which we can see the main pulmonary artery, and this is the descending thoracic aorta, and we can appreciate that there is a small jet. And when we see this appearance on CMR, we have to be suspicious that there is a PDA. And we look here at this image, which is a modified sagittal view. We can appreciate seeing the signal void jet of the from the arch of the descending thoracic aorta to the distal MPA. And it's important that we can acquire nice angio images showing the PDA, the shape, the length, and to determine also in these patients that what is the flow. And also to assess the flow in these patients. And here when we assess flow and how we're going to do that is really important, because we'll need to do something for this patient. If we have show signs of QP, QS of more than 1.5, but we also have to keep in mind when assessing these patients that they also have a risk of infective endocarditis. And it's important when we assess flows, because often we just acquire flow here above the aorta and above the pulmonary. And here QPQS means that, right? And here QPQS, and we would calculate that in which as we're acquiring flow just proximal to the site of the shunting, in which the QP here is actually going to be the aortic flow, and the QS is actually going to be the pulmonary. There is another way in which we would calculate the QP, QS, in which if we were to acquire the QP as the flow that's distal to, in which we would do here, we would look at the flow of the RPA and the LPA, and that would be the QP. And here the QS would be the flow combined of the SVC and the descending thoracic aorta just above the diaphragm. So that's really important when we keep in mind when assessing QPQS in this patient population. As for secundum atrial septal defect, sometimes they're diagnosed early in life, but often they're diagnosed in the 5th, 6th, and 7th decade of life. And cardiac MRI does allow us to assess the QPQS, to assess the significance of the shunt. We can assess the right ventricular volumes, RV function, and really get a good sense of the morphology of the ASD, where it is in position. And even we can get an assessment of, sometimes we are able to get assessment of the size of the defect and the presence of any the interior, posterior, superior, and inferior ribs. And this is really important, as this does help to guide us for planning, whether we just need to follow up this patient or if the patient needs anything further. So it really does provide us a lot of useful information in which we were able to assess function and flow and anatomy without having to do anything that requires radiation or nothing that's any invasive for assessing flow and for assessing hemodynamics. But we also have to keep in mind, sometimes with patients with ASD, they do have associated anomalous pulmonary venous drainage. And it's very important to note where the anomalous pulmonary venous drainage is, whether it's located cardiacally, whether it's close to the site of the ASD defect, whether it is higher up, draining into one of the SVC, or draining into one of our systemic venous veins, just to know whether it's possible to be able to reroute the anomalous pulmonary venous drainage back into left atrium. So it's really important to note this finding in order to assess whether this anatomically can be rerouted to the left atrium or not, as well as what we previously mentioned. It is important to note that there is the site of the morphology of where the ASD, the type of ASD, whether it's a secundum ASD, it can sometimes we've noted also coronary sinus ASDs, as well as secundum ASDs and primum ASDs. So all these findings are really important to note when we assess this patient population. As we can see here in a patient in which we have, this is the left, in which we have here, we can appreciate that we can see the ASD between both atriums. And we can acquire angio images that are actually quite similar to what we would get with an invasive, which you get with a radiation angio, such as a CT angio. And here we have this is a coronal orientation in which we have the right atrium, SVC, and anomalous pulmonary venous drainage draining into the posterior and lateral aspect of the SVC. And here we can take a measurement here. And what we would measure here is the distance between the lower aspect of the anomalous pulmonary venous drainage from the where the SVC drains into the mouth of the right atrium, as that will help us to determine if it was too high up, if it'll be too hard to reroute this pulmonary vein into the left atrium, and also we would determine the QPQS, as that's also a factor, and whether this vein is a large vein or a small vein, and if there's any accessory veins that drain normally into left atrium that also from that same lung lobe. So those are all important determinant factors of whether we would be addressing this or not. Other factors, as you previously mentioned, is looking at the right atrium volumes and function, the presence of any tricuspid regurgitation, in which we can deduct that indirectly from flow, and looking at volumes as well, and calculating the QPQS. When it comes to patients with coarctation of the aorta, these patients also sometimes do present in adulthood, or sometimes they are patients that are known to have coarctation of the aorta that have already been previously treated surgically or by stents. Often patients that have had previous stenting of the aorta, it is often difficult to assess them when we re-image them by cardiac MRI due to the blooming artifact of the stent. But sometimes we are still able to get some good, useful information, particularly in patients that have had bicuspid aortic valves and do have bicuspid aortopathies, in which we want to surveil them for those. So in patients that are presenting for the first time with a new diagnosis of coarctation of the aorta, we look at all asymptomatic patients with a gradient across the coarctation of 20 millimeters of mercury. We also look at asymptomatic patients who do present with more than and equal to 20 millimeters of mercury, hypertension, or hypertensive during exercise, or show evidence of LVH. In patients in which there is 50% or more aortic narrowing, regardless of the pressure gradient, the presence of extensive collateral circulations, in which the intervention may be indicated even if the gradient is less than 20, as these collaterals are offsetting the tightness of, or rather the gradient that we would see at the site of the coarctation. We would also look to see if this was an isolated or this was associated with any associated congenital anomalies, or such as a bicuspid aortic valve, and is there any aortic stenosis or aortic regurgitation, as well as the presence of any aortopathy. And of course, in patients that had previous treatment, we look for any previous any complications at the site of the previous coarctation, site repair, whether it's an aneurysm or whether it's recurrent coarctation. And this is here in which this is a patient that was known to be hypertensive, a 40-year-old patient, and we can appreciate just looking from here on the three-chamber orientation, we have eccentric opening of the aortic valve, as we would see in a patient with a bicuspid aortic valve. And here we can appreciate the valve morphology of the bicuspid aortic valve, the anatomy of the site of the stenosis of the coarctation, in which we can appreciate here, as well as what I previously mentioned, looking at the aortic size. And we can do flow assessment, in which we can appreciate here we have a diastolic tail when looking at flow analysis for this patient. This is a patient population that we'll be also increasingly seeing more, as the first operations for this patient started in the 1950s, and we are seeing more of these patients. So patients that have had a tetralogy flow repair, in which the older patients will have had a repair through having an incision through their ventricle and infundibulatomy in order to release the RVOT obstruction and to repair the VSD. But now, younger patients now, and the young adults that we should be seeing will have the surgeons would have gone through the atrial incision and gone through the tricuspid valve in order to do the repair, in order to preserve the integrity of the right ventricle. As these patients who've had ventriculotomies, they're more at risk as they'll be closed by a patch, so they'll have more increased evidence of having akinesia and aneurysmal dilatation of the RVOT. And it does, as regards to the repair and follow-up of these patients, particularly when we plan and when these patients do need something doing, if they do need something else doing for their pulmonary valve, as regards for, say, like percutaneous pulmonary valve intervention. So it's really important. So this patient population, they're at increased risk of developing pulmonary regurgitation, residual or recurrent RVOT obstruction, RV dilatation dysfunction, tricuspid regurgitation. They might have a residual VSD or ASD. And residual VSD could be due to patch dehiscence, aortic dilatation, regurgitation, and LV dysfunction. And here we have an example of a patient that's had a repaired tetralogy of flow, and which here we have the echo images, and we can appreciate here this patient has severe pulmonary regurgitation. There's no evidence to suggest that there is any evidence of significant pulmonary stenosis. We can appreciate here on the peristernal long axis and short axis, as well as the apical view. The images are, it's difficult to clearly define the right ventricle, but there's evidence to suggest that the right ventricle does look dilated. Cardiac MRI can help us to really assess these patients, as we can get clear assessment of the RV anatomy, the size, the function. We can look for the presence of any regional wall motion abnormality, even in which we can see whether we can see that the patient has had any patch repair at the site of the infundibulum here or not, and to really get a better understanding of the anatomy of the patient, as well as to look at the pulmonary valve and to assess, is there anything as regards to, and look at the RVOT to see if there's any evidence of any recurrent RVOT obstruction. Is there pulmonary stenosis? Is there pulmonary regurgitation? And to be able to quantify that with flow. As the pulmonary valve, it does move up and down between frames, so I tend to take a stack of flow in order to assess the pulmonary regurgitation. And it is really important to know that when we identify patients that have severe pulmonary regurgitation, it is that the valves that are currently on the market, whether surgically or for intervention, that these valves tend to last 10 years. Sometimes they'll last a lot shorter, and sometimes they do last a longer. So it is important that patients, it's also important to know that patients that do have severe pulmonary regurgitation, they're able to tolerate the regurgitation. It's not like aortic regurgitation, in which which is severe, in which we usually see a more rapid deterioration. Sometimes we can have patients with pulmonary regurgitation that's severe for maybe several years, and it's not causing any RV dilatation. So part of the ESC and the ACC guidelines is to really look to identify, is there any evidence of progressive RV dilatation? Assess the volumes. If we have an RV end systolic volume index of more than 80, or an end diastolic volume of more than 160, or the presence of a progressive RV systolic dysfunction, or increasing of the tricuspid regurgitation, that it's really important that these patients do need something doing. And here is a nice example just to show that how CMR can really quantify the pulmonary regurgitation here, in which this patient has a regurgitant fraction of about 42%. It's also important to note in this patient population to look for fibrosis, and I tend to at least do a late gadolinium enhancement, not for every time that I scan these patients, but I try to do one once every 5 years. This was recently published by Dr. Sarah Gonim at the Royal Brompton, in which they worked out a mortality risk score in which the extent of the RV LGE enhancement was associated with an higher risk of mortality. So it is something important to look at and to score this for this patient population. Maria, how am I doing on time?
Yes.
Do I need to wrap?
I'm afraid, yes.
Okay, so I will wrap it up, and in which I'll say that in patients, as we are having patients with that are increasing, becoming older with congenital heart disease, that CMR is a crucial assessment of the diagnostic workup of both the pediatric and adult patients with congenital heart disease. It is important to be used in conjunction with other imaging methods to provide comprehensive assessment. And we have to know what is the clinical question we want to, what is being asked, in order to provide the accurate acquisition and we'll be able to ask the clinical question for these patients, as it's really important to take a step-by-step approach when assessing these patients, as we can usually be able to get a lot of information anatomically and physiologically with accurate assessments of volumes and flow data. And thank you.
Thank you, Dr. Sarah Hageman. It was really comprehensive talk. Thank you very much. Is there anybody to ask for question?
Thank you, dear Sarah. It was a very nice presentation and a very hard topic for cardiologists, radiologists, pediatricians, it's always very tough to give the diagnosis, but it is very, very important. And of course, and this topic also moves us to a better diagnosis. I must say we met almost 7 years ago, and you were our guest, Professor Maksimovic and me. We organized the first Balkan Congress of Cardiomagnetic Resonance, and I hope you will come again to Belgrade. You're always our dear guest. If there is no questions from the audience for our dear Sara, then I would invite Professor Rožica to invite our next presenter.
Yes, thank you very much. Thank you very much, Sara.
Thank you.
We are expecting here next year here in Belgrade. Thank you. It is my great pleasure to present the next speaker. That is going to be Associate Professor Goran Lončar from Institute for Cardiovascular Dedinje, who is going to give us presentation about CMR in hypertrophic cardiomyopathies. What I would like to point out, for those who are from Serbia, we all know Institute for Cardiovascular Diseases Dedinje, but for those who are from abroad, I would like to just stress out that this is one really very important, huge center with number of extremely high number of procedures, one of the top in the world as far as I know, and we were informed. Thank you very much for coming here. And in Institute for Cardiovascular Diseases, there are of course a lot of diagnostic procedures. One of them is CMR. So Professor Lončar is going to give us overview on the CMR in hypertrophic cardiomyopathy. Thank you very much.
Dear Professor Maksimovic, thanks a lot for these nice and encouraging words. Distinguished Professor Ida Jovanovic, distinguished Professor Marija Zdravkovic, my friends, I'm really grateful to be here, and thanks a lot for this honor to be with you and to be part of this conference. Dear friends, dear colleagues, my topic is cardiomagnetic resonance in the context of hypertrophic cardiomyopathy. And as we all know, it's not so easy to have consensus about the definition of the cardiomyopathy in general, and the last and the most accepted one is that cardiomyopathy is a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease sufficient to cause the observed myocardial abnormality. And as we all know, the classification of cardiomyopathies includes several entities such as hypertrophic cardiomyopathy, dilative cardiomyopathy, arrhythmogenic cardiomyopathy, and restrictive cardiomyopathy. All of these entities are well known to have genetic or familial causality, and on the other side, non-familial, non-genetic causality. And it is not so simple to deal with these diseases in everyday clinical life. Some of them, or many of them, are not so frequent. So if we do not see them frequently, we are losing knowledge. We are losing good clinical patterns. So it's really necessary to refresh our knowledge from time to time in order to be able to be on the good level in respect to the evaluation of these entities. Because the focus is HCM, as you can see on this slide, there is familiar and non-familiar clinical context. Familial, we can have patients where we cannot detect a specific gene mutation responsible for the disease. On the other side, we have many genetic mutations, well-defined, well-evaluated, especially related with sarcomere proteins. We should not forget that there are some other diseases which can induce hypertrophy of the myocardium, such as storage disease, and I will mention them in the further of this presentation. And as we can see, just genes in this context of cardiomyopathies are very, 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 very complex ones. And we can see that even the same genes can provoke several different phenotypes, such as that one gene mutation can be responsible for both dilative cardiomyopathy and hypertrophic cardiomyopathy. And why I point out this, the issue is that we should really know very well clinical context of all these disease states, imaging issues, of course, in order to be able to well discuss and evaluate genetic disorders in these diseases. Just missense variants in MIH7, you can see so big numbers, and that's why we really need experienced clinical cardiology genetician to be involved in this game, and hopefully. Dédigné sent one young medical doctor to Pitié-Salpêtrière Genetic Reference Center in Paris a few days ago, and she will be there for 1 month. And that's the single way to really have adequate knowledge in respect to this issue. So let's go to the topic with more focus. So hypertrophic cardiomyopathy was first time depicted in 1869. But the first and very, very serious description of disease has been done by Morrow and Braunwald, very famous pioneer in cardiology. So they operated patients with aortic stenosis, or at least they thought that it was aortic stenosis, aortic valvular stenosis, but it wasn't. When they opened the patient, they saw that the obstruction was at the level of the LVOT, and they called it functional aortic stenosis. So it is, as we all know, usually familial disease. It has great heterogeneity in presentation, in ongoing clinical development scenario. Some patients are calm throughout the life. Some patients die suddenly. Some patients go into heart failure very soon. Some patients are affected by AFib and so on. So it is present in all phases of life, from newborn to elderly. Non-obstructive form is predominant, and the incidence in general population is 1 in 500. So the point which is important to point out is that hypertrophic cardiomyopathy includes hypertrophy of the non-dilated left ventricular, at least at the beginning of disease pattern. Unexplained by conventional causes. It has genetic mechanisms, and clinical problems are various. It can be sudden death, different arrhythmias such as AFib, ventricular arrhythmias, heart failure at the early phase. It is diastolic dysfunction. It can be, of course, and systolic dysfunction leading to heart transplant in some late stages. Then we have problem with myocardial ischemia in some patients. So it is really interesting clinical context. And the role of CMR is well established in the last HCM ESC guidelines from 2014. And we have that cardiac magnetic resonance has the highest level of recommendation. Here it is pointed out in cases where with echo we cannot get all acquired information, but nowadays we know that every patient with HCM should have cardiac magnetic resonance due to many reasons, which I will point out later on. So this is the newer guideline, ESC guidelines for the management of patients with ventricular arrhythmias and sudden cardiac death, where it is pointed out that CMR with LG is recommended in hypertrophic cardiomyopathy for diagnostic workup. We are not satisfied with the older criteria for assessment of the risk for sudden cardiac death, because there is accumulating that data regarding the usefulness of CMR acquired data in order to predict future events in this clinical context. So there are various patterns of hypertrophy in HCM. We all know that sigmoid septum is not so rare, especially in elderly patients with hypertension, and we should keep it in mind. Then we can see that HCM can present with asymmetric septal hypertrophy. Then we can have the mid-ventricular hypertrophy of the left ventricle, then apical one, and of course we can have patients with concentric hypertrophy of the left ventricular myocardium. Of course, RV involvement should be always evaluated in this context. There are some papers, such as this one, that telling us that almost 1/3 of the patients has affection of the right ventricle. So when we are talking about HCM, CMR and HCM, of course, LG has important place. We should talk about. I will tell a few data about frequency of LG in this context, about typical spatial distribution, and about various morphology. What is well known is that when you have patients with HCM and with LGE, these patients have worse prognosis compared to those without LG. We all know that LG is very important for us in everyday clinical life, in everyday CMR life. And there is interesting notion of Professor Bucciarelli in 2012 who said that there is evolution of LG from bright is dead to bright is bad. We all know that we don't like to see the bright white areas of the myocardium after gadolinium injection. But what we know now is that the prognosis is worse with the greater amount of LG, with the greater amount of bright on LGE images. So practically 2/3 of patients with HCM presents with the LG. Of course, it depends on the unit volumes and whether it is we are talking about HCM clinics. The distribution of LG can be very various, and it is well represented on this slide. So we should carefully evaluate LG distribution in our patients. And what is logical, but of course proved, is that when the wall is thicker, there is higher incidence of the LG accumulation in these patients. Of course, another important issue is that if you have more LG, you have a greater chance to have progressive disease. And it is well proved in several papers. Progressive disease means that patients can develop heart failure or sudden cardiac death, or it is an alarm that we should react more promptly in respect to all accessible tools to save and to improve the quality of life of our patients. LGE in HCM and its distribution is very important from the prognostical point of view. For example, if we have transeptal LGE, especially in young patients, it can correspond to the high risk of sudden death. On the other side, if we have limited LG at the level of RV insertion points, it can correspond to lower risk of sudden death. Apical HCM, we all know that it is frequently very difficult to evaluate apical HCM by echocardiography, and this is one very nice paper clearly demonstrated that practically all patients with this apical hypertrophy were not well evaluated by echocardiography. On the other side, CMR quite precisely can evaluate these patients, and we can see even the ratio of the apical versus basal thickness of the left ventricular wall. We all know that in the usual cases, in normal cases, there is decreasing of the thickness of the myocardium going from the basal to the apical portions. In apical HCM, of course, it is vice versa. And what is always some kind of alarm is that there is always ECG changes in this kind of patients, which should be an alarm in our outpatient during our outpatient activity. HCM risk sudden cardiac death calculator that we use in clinical practice, predominantly regarding imaging techniques based on echo, but of course with new guidelines, CMR will get a very important place in this domain. And just one study, for me a very interesting study, comparing echocardiography versus CMR in the HCM context, and we can see that there is I can say big discrepancy, especially in respect to the maximal left ventricular wall thickness, which is always necessary parameter to be in our reports in these patients. And we can see that echocardiography underestimated in 1/3 of patients maximal wall thickness, or overestimated in almost 60% of patients maximal left ventricular wall thickness. Underestimation was based on the fact that echo is not so good when we have focal left ventricular hypertrophy, especially at the apical portion of the left ventricle. Then when we have, of course, poor acoustic windows, which is in approximately 50 to 20% of our patients in everyday clinical life. By overestimation included evaluation of the right ventricle, problem with echo when we need to measure compacted part of the myocardium when we have lots of left ventricular trabeculations and so on. So a tale from the clinic, one patient, a male patient, 58 years old, NIHA 2 functional class, palpitations based on AFib, paroxysmal atrial fibrillation, with normal coronary angiogram, and we can clearly see on these cine images additional feature that is related with the obstructive form of hypertrophic cardiomyopathy, and it is systolic anterior motion at the level of the mitral valve, and consequently mitral regurgitation. So not only wall thickness, kinetics, but also we need to well evaluate papillary muscles, its position, then mitral valve, then whether there is obstruction at the level of the LVOT, and of course severity of mitral regurgitation. These informations are very important for routine clinical practice, because interventional cardiologists who perform alcohol septal ablation needs this information before final decision, of course in line with other exams in respect to this procedure as a therapeutical option. Of course, LG can be very different. Here we have more, diffuse, spotty, patchy LG in different regions of the heart. We can quantify amount of LG, amount of fibrosis, which is very important. And there are different papers telling what amount of fibrosis is necessary to push more towards, for example, ICD in respect to the prevention of sudden cardiac death. So CMR provides accurate assessment, which is not always easy, of amount of myocardium affected by fibrosis. We should always think that every hypertrophy is not always HCM, hypertrophic cardiomyopathy. We should always have in mind amyloidosis, then Fabry disease, then some other genetic disorders. I will tell a few words afterwards about them. This is one male patient, almost 8 years old, NIHA 3 functional class, presented to my outpatient department with the paroxysmal atrial fibrillation, already hospitalized in one hospital in Belgrade, and during a routine clinical checkup it was practically obvious that there is greater chance that this patient is affected by cardiac amyloidosis, and we have of course CMR to contribute to be a necessary piece of the puzzle in this interesting diagnostic pattern. And we did, of course, a CMR, and we can see some red flags for amyloidosis in this patient. There is pericardial effusion, there is concentric hypertrophy, big atria. So on T1 mapping, we see values, all values are very, very high. It is really typical for amyloid deposition in the left ventricle, and diffusely elevated T1, problem with the Luke Locker determination of the inversion time, and typical pattern of LG, which really confirmed our big suspicion on amyloidosis. We can see LG, subendocardial, circumferential in the basal parts of the left ventricle, apical spurring. We can see also affection of the right ventricle, of the atria. So it is really typical image of cardiac amyloidosis. On the other side, we can have patients. I got this patient in my outpatient department with the diagnosis of HFpEF. We should always ask why elderly patient has HFpEF, especially in the context of left ventricular hypertrophy. And of course, CMR can give us a very important response. And in this patient, we see that T1 value is completely normal in all segments, basal, medial, apical segments, and there is no LG in the myocardium, and of course taking into account all necessary clinical information, such as that this patient was affected by dysregulated hypertension for many years. We are quite sure that this patient has hypertensive heart disease. When we see patients with hypertrophy, we should always think, of course, on Fabry disease. It is not so frequent, but we should think about it. And on this slide, we can see that T1 is significantly decreased, meaning that there is lots of lipid accumulation. This is lipid storage disease, and that's why T1 is decreased. And of course, in context and in line with other exams, we will reach the final diagnosis, and we will provide adequate treatment to these patients. Then on disease, glycogen storage disease, such as this young lady with origin from Serbia, but living in Zurich. Very interesting disease, a big hypertrophy of the left ventricle with huge amount of fibrosis, and not only fibrosis with the pointed inflammatory process expressed by high T2 values. So this is also this clinical context we should keep in mind. So take-home messages are that CMR is really important in patients with HCM. Another important issue is that CMR has huge diagnostic, prognostic, and therapeutical contribution in this context. And we should always think about other potential causes of left ventricular hypertrophy. And I would like to say you that we are a new center working for almost 6 months. There is no queue there is no practically waiting list, so it is easy to schedule exam, and patients do not have to wait more than 15 days. Of course, in any case, when you consider, such as in Minoka, that you need exams more rapidly, please call us. You have phone number here, and we will respond to all your requirements. And this is beautiful mountain at the southwest of our beautiful Serbia. Its name is Mučanj, and I would strongly recommend to all of you to visit this part of Serbia. Thanks.
Thank you very much for your excellent presentation. Unfortunately, we are not having time for the discussion because we are a little bit late, but I'm sure there is going to be a couple of questions during our break, during the lunchtime, because this is a very challenging area, and there are a lot of issues regarding the differential diagnosis. Thank you very much once again, both for your presentation and for the recommendation to visit the mountain.
I have a privilege now to announce the next speaker. This is Professor Mario Zdravkovic. Professor Zdravkovic is not only a big fan and promoter of the CMR in our country. She is the chief of the CMR team in Bežanijska Kosa, a big hospital, and she's also a director of this hospital. And what is really characteristic for Professor Zdravko is her fantastic energy and the smile, which are almost infective for all of us. And she is always with us, organizing the Association of CMR in Serbia. So thank you, Professor Zdravko, for everything you have been doing for cardiology in Serbia. Your presentation is a CMR assessment of the myocardial viability as a gold standard for decision making. Thank you.
Thank you, dear Professor, for these nice words. I would talk today about very important topic about gold standard. CMR is gold standard almost in everything in imaging in cardiology, but estimating viability is something that is very important for our patients to know whether they should go for some procedures or they should not. So it's the main goal of viability testing is to identify is there significant viable myocardium that would likely result in improved outcome with coronary revascularization. So we need to know, do we have enough material to make better the quality of life and duration of life for our patient? Not to do because we think it could help him or her. We have to be completely sure, completely positive that that patient would have something better for him. This is the paradigm of myocardial viability. When we have the necrosis, that is not the only problem of patient that he has, because we have remote myocardium that is not zone of interest, but salvage myocardium at risk are very important zone of interest, and they are area at risk. We should then evaluate area at risk through number of these sequences that we could see in the previous presentations, and then when we take all this information, we should analyze them and give just one sentence to the colleague who is sending us the patient, whether to send that patient to revascularization or not. Why do we have problem if we don't perform CMR to that patient? We all know that except necrosis, we have also stunning and hibernation of the myocardium. Without CMR, we can only imagine where is the stunning and hibernation, but only a diagnostic technique that make us positive to have those parts of myocardium that presumably have protectable adaptation to ischemia that is going on around and that still have viability. We can do that only with CMR. And you can see the contractile dysfunction that we always see by echo, and first step is echo, of course, is provoked by several things. First thing, that is scar, and beside the scar there is ischemia, and then we have hibernating myocardium, and of course we have stunned myocardium, and we should react very fast, and we should know where to react and how to react. These are our sequences, and we heard a lot of so important things about getting these sequences and about how it is important to have your own values for T1, T2 mapping, as Professor Maksimovic showed. If you have white shades on your myocardium, then you have something that probably is completely dead, and you cannot help to the patient. But you need, if you have edema, we seen that fantastic case in presentation of Professor Maksimovic. Edema is the crucial point of further development, whether we could help the patient or his myocardium will die and go to something that is not myocardial tissue, and that tissue is some scar mass. Okay. It is very important when we perform evaluation of our patient to give two answers. Is there LGE? That is definitely that myocardial tissue and scar. And do we have in our patient ischemia? Because as you can see at this fantastic illustration, when we analyze ischemia and LGE and we put them together, then we have very, very complete information. That is why we are not satisfied only by cine images or sign imaging. We want to have stress CMR in those patients, and that is very important to have because we all use invasive FFR, and at every cardiology congress you can hear a lot of talks about FFR, but you see how very important and very precise for decision making is cardiomagnetic resonance with stress testing. So imagers, we are imagers here talking about, are very strong in prediction. What would happen with our patient? We don't need to send him to invasive procedure to have the answer. We can do non-invasive procedure. Of course, we need to have hardware, software, and our knowledge. So that is the holy trials in CMR. How do we estimate viability? If we have a scar transmural infarction, more than 70% of the myocardium, then we have certainly absent viability. And if it is less than 25%, then we have certainly preserved viability. And that is very important because sometimes ECG and echo would not be enough for our patient. And we won't send the patient for some procedure. Every procedure has a risk, especially procedure is in patient who has heart problem, and then you send him without knowing why are you sending him. You expect something, but you mustn't expect, you must be quite positive that your patient would benefit from that procedure. And if you can see, these are the pictures on scheme and real-life pictures in the patient with infarction. And that is how we evaluate the percentage of viability. And Professor Lončar showed us famous bullseye. It was known for echo, but now we can use it also in CMR and to see with all these different colors. Of course, we need to have special software to analyze that. It is very important in how many segments do we have LGE extensiveness and how much LGE in percentage, because this is very interesting diagram showing that if we analyze all these functional segments, then we know that the contractility would improve in those patients having less segments with LGE. These are data about viability and clinical correlation, but we can see that if patient has zero fibrosis, then he has a very high probability to regain contraction. So the amount of LGE, the amount of fibrosis, the amount of scarification. It is very important. If he has myocardial risk, we need to send him as soon as possible for revascularization. Extensiveness also matters, and especially number of non-viable segments. If we have patient with more than 4 segments in artery-related area, not in whole ventricle, but in artery-related area, because we're speaking about coronary arterial disease, so we are dedicated to artery-related area, then we would have poor recovery of wall motion. And if we have more than 10 segments of whole 16, then we will have poor recovery of L ventricular systolic function. And again, ECV. ECV is the most important parameter in post-analysis of the images because it is very stable, it is very reliable, and it gives us a lot of information. Of course, we need to have blood sample before our imaging on that day, and that Sarah Moharem emphasized. You can do everything with what you want when you have patient in your CMR machine, but after he went, you can do nothing more. So it's important to think and to be present while there is making of images if we want to make. Of course, we have standard protocols, but sometimes doctor wants to have also additional images. A higher ECV and ATT1 time means higher MACE in cardiology, and we know that, and that is the sign of exclamation in our patient. But ischemia that can be induced is also very, very important. And this is special diagram when we perform adenosine testing. We can analyze the flow through every segment of this myocardium. And we have these flow charts. We can clearly recognize that we have problems, as you can see with the low flow. The low flow is here in those areas that we have different colors at this picture. And different colors means that T1, T2 values are completely changed because the tissue is dead or in heart ischemia. Of course, then we can use this model, but we need to have special software. We do have it, and then to evaluate, do the patient have microvascular dysfunction? That is something that is very modern topic, because we can calculate microvascular dysfunction, and some patients with normal great coronary vessels have microvascular dysfunction. Patients with CTO lesions often have it, but also some other patients. We have some new techniques, but all of them are looking for T1, T2, and sometimes now today we have some new technique called stress T1 mapping test without usage of gadolinium. Of course, me first, I prefer LG. I need to say that because I'm very motivated to have picture with the standards. But that is something that is promising, and the most important thing today in development of cardiomagnetic resonance in the field of myocardial viability is technique of estimation of myocardial oxygenation, and without LG. That is something that would be revolutionary in, of course, further development of testing of viability. But you see, the first paper was published in November last year about estimating the level of oxygenation. It is very important. Second question is estimation of non-culprit lesions after myocardial infarction. Okay, until now we estimated culprit lesion and disaster around culprit lesion, but now we are very motivated to estimate non-culprit lesion. And I would say once more, in this publication you can see it, it's pretty new, that CMR, cardiovascular, is as sufficient as FFR. And that is very important for further development of cardiology and also for our patient. The main question and internal dilemma is how to select patients that would mostly likely benefit from revascularization. And what we need to show, we need to demonstrate viability at least for dysfunctional myocardial segments that could be revascularized by PCI. If we can do that by imaging, we can convince our colleagues, interventional cardiologists, that they will have significant improvement in ejection fraction that would help the patient. Because every intervention in cardiology, since we have invasive procedure, is also the risk, also for those patients. Risk vascularization does not predict better outcomes than optimal medical therapy, OMT alone. That is the big study that was also performed in our study, but the patient with severe left ventricle dysfunction most benefit from revascularization, and high peri-procedural risk must be balanced according to the late mortality benefit. But revascularization is always combined with OMT. In these patients with proved viability is certainly better thing. This is the new rules. These are the new rules that are helping us to understand how to make smaller rate of heart failure after myocardial infarction. But of course, we always need to say whether the patient have substantial amount of viable myocardium on viability testing. That's why viability testing is very important. If we have patient with ischemic heart failure, left ventricle, and moderately severely reduced left ventricle ejection fraction, so these are the most complicated patients, then we need to see whether they are suitable for revascularization. If cardiologists think that they are not, they have too much great risk, very high risk, then the patient would send to OMT and device therapy, CRT or ICD, and all this, it is possible in our center. But if we think he would be suitable for revascularization, then we would advise, if he has evidence of ischemia, he goes to OMT and revascularization. If he has no evidence of ischemia, then we would ask and advise viability testing. And after that, we shall make our decision. In the end, I would like to thank you for coming to this very important session that was judged by a Royal Scientific Board as one of the most important, and that's why we are here together. I would like to thank to my teachers, all of them who are there, but especially to Robert who came, also Philip Haaf. We had a pleasure to see his revolutionary slide about ECV and T1, Professor Keller in Berlin. But especially I would like to my team, to thank my team, you all who come today to be here, because everything we did and everything I did, we did that together. And especially to my younger associates, Vyacheslav, Andrea, Sloboda, and Maya, and my very dear technicians and nurses that are working with me in this, I think, revolutionary days of further education of cardiomagnetic resonance. Thank you very much.
Thank you, Maria. It was really a fantastic presentation. It's so important, and your messages. Thank you. Okay, I think we have to announce another speaker, which is Mr. Lorenzo Campaigns, Innovation in Remote Health Tech, around the clock of monitoring and care.
Excellent. Yeah, that's good. just want to maybe wait a little minute for some people. We get started. Wonderful. Hello. Let's talk about technology. My name is Lorenzo. I'm founder and CEO of Envilia Technologies. We are a UK company. We've got a branch office in Athens as well. Then you have Greek, quarter Spanish, quarter French, a little bit Mediterranean. We thought kind of cover all of Europe. Now, Envilia is a sector agnostic company, which means that we deal with all sorts of different sectors, verticals, and then we have a horizontal, which is our technology. We're very involved in the healthcare sector. We do fintech, we do drones, we do manufacturing, energy, agri-tech, sounds, acoustics, and online retail, amongst other fields. So the things we do is that we code experiences. We do things a little bit differently. We simplify life because we have a mission, above all, to use technology to make life easier for people. So by doing solutions with AI, API integrations, we don't need to reinvent the wheel. We simply use existing stuff and plug it into the life of users and make experiences much better for everyone. So let's talk a little bit about the global health tech landscape. Okay, it's a very vague and very vast field. So the idea is to see where people and where the trends are going. It's not just about the things that we do in the medical field or the software engineering fields. It's about what people do, everyday people, like us and others who have absolutely no clue how technology works. So throughout the last decade, we've all been hearing about AI since 2012. Started hearing about AI, especially in the medical field. There was AI to recognize melanoma, for instance, through imaging, which provided better results than actual doctors could do. And that evolved into having a lot of big data. We didn't really know what to do with it, but everything was going great. We had a lot of apps, a lot of wearables, a lot of different tools that everyday people and in all sorts of fields could use, right, to make life and work easier. We started hearing about value-based care, which means that healthcare became a lot cheaper by providing a lot more value, right, to the patients. And then we heard a lot about data sharing, right, and privacy in all sorts of fields, right? We saw Facebook, we didn't know what to do with it. It was good, it wasn't good, a lot of fines all over the world, and that's okay. And things evolved. We kept hearing about telemedicine, especially in the remote areas where healthcare was really difficult to get, not just because of money, but especially for distance. So something happened. COVID-19. It came and made life absolutely difficult to live. We didn't know what to do with it. We had all these tools, we had all these roadmaps, evolutions, everything was great. But with COVID, everything changed. So we were a little bit stuck. What happened to us? Well, we worked in the medical space, so we had a lot of health tech in hospitals, in clinics, all around Europe, in Turkey, Sweden, Denmark, Spain, Portugal, to mention a few. The day after COVID struck, we went from great to zero. No consultants were allowed in hospitals or clinics. No protocols were in place. So basically, we were all stuck. So the landscape and the trends, as you know them, evolved from COVID. So these are the trends, and not just trends that I personally think. This is Google Trends. Before and after COVID. So what we see here is basically AI has a very stable progression. It's in all fields of expertise. It works, we're adapted to it. It wasn't really affected. Now, value-based care, yes, it got better. And the thing with big data, it's not that big data wasn't good. It's just that we didn't know what to do with it. We had so much of it. So what we had to come up with is new protocols, new means of communication between us with patients, in all fields of expertise. So data sharing and privacy became a priority in all fields of expertise. And digital health tools started evolving, where everyday users could use the wearables, applications in healthcare and beyond. Telemedicine, as you can see, there's a big bump, and that big bump means that we suddenly discovered what to do during the pandemic, which means that we had people in remote areas who had zero access to telemedicine, to doctors, to any sort of medical equipment, pharmaceuticals, absolutely nothing. All of a sudden, we could use remote healthcare through apps, wearables, and provide support to all these people remotely, and that still works. It seems that we've changed the way we work and the way we see things, which is great. So let's talk a little bit about the innovations in remote health tech. This is a great study from Deloitte in 2023, and I recommend to everybody you go and check it out. The first thing they looked at is the virtual health delivery, which means that you don't need to go to a hospital, you don't need to go to a clinic. As long as you've got a mobile phone, you don't need to call them necessarily, but you can do a video call. You can talk to a doctor in all sorts of fields who can provide some health advice and things for you to do. And that's a lot cheaper as well. The second thing they looked at is the workforce. Now the workforce, as the population grows, the demand grows. So by 2030, we're expecting about 30 million doctors to be needed all around the world, which is absolutely ginormous. About 80 million of those will be needed in areas with low income, and that makes things very, very difficult. So this is where technology comes in. The digital transformation, electronic health profiles, applications, wearables, remote health tech is becoming the norm. We all like it. We know how to use a phone. We know how to call. We know how to do a Skype. We know how to do a Google Meet. So the rise in innovation in healthcare is here today. Now, health equity has become a priority, which means that people with low income in remote areas who never had access to healthcare, all of a sudden do have access, which is great, because it doesn't mean you're old and you don't know how to use a phone, or you're young and you don't know how to use technology. You now have access to it, which is great. Now, the thing is that, geographically speaking, the priority has become in recent studies to see, do we have the same life expectancy in the same geographical areas? And if we do, it's great. But if we don't, then there's a problem there, and we need to address it. Well, it seems that in the medical space it is being addressed, which is great. Last but not least is sustainability. Now, sustainability has to do a lot with climate change. It has to do with natural disasters. It's not how we're going to send people to help when there is an earthquake. It's how we're going to cope in hospitals and clinics with the correct tools and the correct medicine for an enormous amount of people. And this needs to be fast, it needs to be accurate, and it needs to work. So this is what we're currently looking at globally. Now, there's a lot of challenges with that, and it's not about privacy and data sharing or how to use a mobile phone, right? So let's talk a little bit about things we see every day, right? Let's talk about waiting times. How many of you have been to a hospital or a clinic and have waited for hours? Probably most of you, if not all of you. It's a common issue. It's global, it's a problem, and we really don't know how to deal with it. So just in the UK alone, to get a doctor to see you in A&E, for the love of God, you need to wait 4 hours in the UK. Now, if you want to book a meeting to see a doctor, whether it's, I don't know, surgery or something less important, you need to wait 4 months. Now, with all these doctors in the room, you understand what I'm talking about. And this is the United Kingdom. We're a UK company, so we totally understand what's going on here. But we're also in Greece. And in Greece, it's even worse. The A&E, you wait 10 hours. So unless you're dying, You're going to be there for 10 hours waiting, at least. Now, if you need to book a meeting to do a surgery, the minimum they're going to wait is 6 months. 6 months, for the love of God, to do surgery? Absolutely ridiculous. And this is just Europe, right? European Union. You call this what? Waiting hell. So what do we do about it? 2018, we got a company in the UK who came to us and said, look, we're consultants. We do tech. We build stuff. But we actually don't know how to build technology. So we need your help. So there was an application, and the whole thing we did was backed up by Bayer. Bayer obviously sells pharmaceuticals, and the more patients come and go, the more they sell. So we work closely with the NHS. We worked in the biggest hospitals of the UK, St. Thomas, many other hospitals. We launched it in 11 clinics across Europe. St. Thomas in the UK, in London, Asuta in Israel, Kocaeli in Turkey, launched it in Sweden, in Spain, Austria, plenty of other things. Now the good thing about it was that in St. Thomas, when we finished this application using wearables, which meant that everybody in the floor was wearing a wearable badge, anonymously, we could see in a real floor plan exactly where the doctors, the technicians, the patients, everybody in multiple floors were going throughout the day. Anonymously, we gathered data. And everybody had to wait 3 to 4 hours anyways, because they booked an appointment and they came to the hospital, and 3 hours later they were still waiting. So the waiting room was red. And it was crazy. Doctors going back and forth just to take blood. So we reduced the time from 3 hours to 30 minutes. How? They booked an appointment through an app. They got to the hospital. They got their badge. And after we plugged some AI into the system, we were able to reform the setup of the hospitals and the clinics so that we can tell doctors, you don't need 2 doctors to take blood. And you don't need to have, let's say, the water fountain all the way on the other side of A&E. The guy has a broken leg, he can't drink water. So everything had to be reformed so things would be much, much faster. They came in, they got a badge, within 30 minutes they were out. Amazing. So let's talk about another thing now. Acoustics. This room has good acoustics, probably by chance, but there's a good microphone as well. So you can hear things. This is a restaurant. Sir, do we have volume? Now, the average decibels that you get in a restaurant or in a hospitality space is 80 to 110 decibels. You have volume? Now this is crazy because you can hear each other. My voice needs to be much louder so you can hear me. So it's not just that my throat is going to have an issue, our hearing is going to have an issue. So we need better acoustics. And what we usually hear is urban planners. So where are the urban sound planners? Do you know anybody? Because I don't. Now, sound engineering is very important. And if I could get the sound, it would be amazing. Now, we don't call this fun. This is really not fun, okay? Especially for people with hearing disabilities, which are quite a few billion around the world. So, let's talk about education. With a 1.25 reverberation time in a classroom, the student who's sitting at the very back is definitely having a hearing issue. He doesn't always get what he's supposed to hear. The average decibels in a classroom are 65 decibels. So unless you're a very smart person, and even then, you're going to have an issue at the very back of the classroom. So how do we call this? Learning disability. Absolutely. We need to address the issue of acoustics in classrooms. Very important. Let's talk about another field of expertise, or another field in general, healthcare. The problem is that to recover, when I went to see my mother, for instance, in hospital, right, she was just ill, but in hospitals, the decibels are absolutely loud. So the New England Journal of Medicine called it a pandemonium. You hear all sorts of sound, beeps, bops, telephones, doctors, urgency. BBC said the noise levels are getting worse. Absolutely, ABC says the levels are going higher. And it's a known issue for decades, especially in the last decade. We totally need to address this issue. And don't think clinics, think public healthcare. Okay, this is where the problem is. It's public, it's free, and it's chaotic. So, the average decibels are 37 to 88 in a hospital. 88? That's in a pub. You hear that sort of decibel sound. It's crazy. So, impossible to recover, right? Definitely. So, Mumley came to us. Science mind. The founder woke up one morning and had lost 20% of his hearing with absolutely no reason. A very good friend of mine indeed. So he came to me, because I'm the tech guy, right? So we need to build this application, right? We need to do something about hearing, right? Not just in libraries and things, but everywhere. It's very important. So we've worked with Innovate UK, came up with a couple of grants in the last 5 years. And we've built this little device that you see that is planted at the very top of multiple floors in different rooms and gathers decibels and noise levels and gives you this aura. It can tell you if you've got good sound or bad sound. So you can make an educated decision about how to fix the space, not necessarily just with panels, so that people can talk. Not just people with hearing disabilities, but if you want to have a simple meeting, meet somebody for a date or for some professional meeting, you can't talk. You don't know where to talk. That's the problem. So we've worked with a lot of companies in hospitality, especially in London, in Shoreditch, and now we've got what we call verified for sound. Audio accessibility becomes the new standard. We start in London. We've installed this in the Queen Elizabeth Olympic Park. And last week, in the World Assembly of the WHO in Geneva, Marion, the CEO, was invited to present Mumley. This accessibility standard with this lovely badge means that you, I, and everybody can find a space to talk, to have a simple conversation. Now let's talk about our products in health tech. We've done a lot of great things for others, but we decided to do a few things for us too. The first thing is that we partnered with HeroTech 8. These guys do drones. What you see over here is called a drone in a box. It means it's got a charging station, it's got AI, it's got computer vision, it's completely 100% autonomous. It means that if it's running out of power, it will go back in the box, it will charge itself, and you can work as part of a swarm, which means we can cover large spaces, not just for security and inspection, but also for medical equipment transfer. At last, we can do it autonomously. So what we did, HeroTech especially, we installed it in Milton Keynes University Hospital, a complete autonomous solution, which means that in campus, which is very large, they could use an app to request medical equipment, right? All sorts of drugs from one point to the other, very simply done, with a good payload of about 2 kilos. The second thing we did is remote care support and monitoring. Super essential that one smartwatch can actually prevent death. We call this Emergence. Emergence was born from the need to actually provide healthcare and support at home. So in Greece, we worked with the Department of Growth and Investments, and we worked with the municipality in Athens. We did a pilot. We got 94 patients. We got about 6 team members within the organization, which were providing already care at home. But what they had to do is go through a pile of paperwork, go to the house every now and then, whenever they thought there was an issue and whenever they were planned to go, to check their patients. Obviously, that requires a lot of people, a lot of time, and usually care at home can mean, yes, you need to take your drugs, maybe I need to change your diapers, or maybe you need somebody to discuss, you're feeling completely lonely. There's a lot of reasons why you need to provide healthcare at home. So we've got this little watch over here. It's a watch, as you probably know smartwatches, right? Typical biometrics, pressure, heart rates, temperature, oxygen levels, great. But there's a difference here. There's an SOS button on the right-hand side, which means that the person can hit the SOS button at any time, and they can start a conversation with the municipality carers to tell them about the issue they're having. It's got a 4G SIM card, which means I know at all times, when the SOS button is clicked, of course, where the patient is. I also have an electronic health profile, which means I've got the entire history of the patient. I know their family, I know where they live, I know who to call, I know even how many drugs they need to take and at what times they need to take them, so I can remind them automatically, daily, hourly, as many times as I like. Now the cool thing is that on the other side, the carers have visualization. They can see on a map in real time exactly where the patient is, and at the time of the SOS call, they have a real-time biometrical status of things, so they can take an informative decision. Now the thing is that if the SOS button is not called, and all of a sudden the patient falls, there is also an automatic call done. And if the first number doesn't answer, we've got a second one. And if the second one doesn't answer, then we've got a third one. So by the third call, somebody should answer, which means if there's no response, I've got a GPS location, I've got a profile, and I've got a real-time monitoring of their health. Right there and then, I can send help. I can save their lives. And also, I can do that before the event, before it happens. I can get an alert to see if there's no pulse. Obviously, I need to call them, right? So I'm getting an automated SOS at the call center. Now, we can't do this alone, obviously. So we decided to partner with the best. He's here today, and we've partnered with Papapostolou Healthcare Technologies. Papapostolou is a large group. They provide the best tools, the best medical tools in Greece, now in Serbia, in Romania, and we intend to do this in the UK, Croatia, and abroad. And we don't just want to do it with wearables. We want to go beyond that. So let's start with the fact that we're going to bring emergence to hospitals. It means that hospitals can provide care to their patients remotely. GDPR, you ask? Of course, hospitals got that sorted. We don't need to worry about that. Clinics, the same exact thing. A little bit more private, but definitely the same. Last but not least, organizations of all sorts, insurance companies, big organizations that actually have patients and need to provide care. We're going to bring this technology to everybody, everywhere. Emergence is not just for hospitals, clinics, and organizations. We're going to bring it in shipping. When people leave and are in the middle of nowhere for 6 months, they do need care. They need remote care, they need to talk to somebody at any point in time, 24/7. We're going to bring it in trucking. Off you go, long haul. We can provide care to you. We're going to bring it in trains, long distance especially. Emergence is here to stay. Healthcare shouldn't be on demand. Healthcare should be preventive. Thank you.
Thank you, Mr. Lorenzo. This was a unique opportunity for us here to listen about such important project of the future medicine or medicine in the future, but it started now.
Thank you very much.
And I think that many people, many colleagues would be very interested to talk to you additionally, because now is the lunchtime. I invite you all for the break, and I first apply to talk with you about this project. Okay.
Thank you very much for this.
Thank you.
Any
Are
questions?
there any questions?
Actually, I have a
May I please?
I was really impressed by the fact that you said that the patient's medical history.
Yes.
How is it retrieved? How is it uploaded? How does that part work?
So the pilot we run means that we worked with the program that's called in Greece Healthcare at Home. The municipalities especially provide this, which means that they have a whole bunch of paperwork still where they get the people in the municipality to come over and say exactly what their issue is and what their medical history is, sign those papers, right? And off you go, we can provide that care. Now, we provide digital transformation now, which means that all this paperwork now for municipalities, especially in that program, is becoming digital. So I've got history now. I've got the electronic health record, right, which provides knowledge, right, as to what the status was, what it should be, even vaccines, right? Everything is that in that profile. So digitalizing everything is how we sort this out. Now the good thing about the application and the ecosystem is that not only you can take a picture, put the profile, but you also get the digital signature right there and then on a tablet, for instance, right? That's it.
And is this product something that might be available to, say, insurance companies?
Correct. Especially with GDPR sorted, could be number one. Definitely. Any other questions? Okay. Thank you.
Well done.
Thank you.
Dobar dan. Dobrodošli na sesiju koja je posvećena kardioonkologiji. Pored mene je profesorka Nevena Sečen i profesorka Sonja Šalinger i meni je čast da sa njima presedamo ovu sesiju. Ono što je do mene bilo, to je u stvari da sam samo inicirao ovu sesiju, zato što ovo jeste jedna od tema koje su u kardiologiji aktuelne poslednjih godinu dana i više, i poslednju godine smo imali preporuke Evropskog kardiološkog društva iz oblasti kardioonkologije i zahvaljujući trudu profesorke Sonje Šalinger mi imamo i džepno izdanje tih preporuka. Nažalost, po ugovoru, da kažem, koji imamo sa Evropskim kardiološkim društvom, mi ne možemo da se nalaze na sajtu otvoreno, nego su samo u formi džepnog izdanja, tako da ćemo vidjeti možda za kongres kardiologa da doštampamo još jedan deo, pošto smo imali kongres u Trebinju pre 10 dana i onda smo, praktično su podeljene sve te džepne preporuke. Možemo, ja mislim, da krenemo odmah, pa ćemo da ostavimo diskusiju za kraj. Ideja je bila da sa iz različitih uglova sagledamo problem kardioonkologije, znači tako da ćemo tu imati kardiologe, imat ćemo pulmologe, onkologe i temu, znači, koja se onako tiče nečega, znači što smo mi odavno znamo i svesni, ali znači sada to dospeva u fokus, znači i sa preporukama za dijagnostiku i lečenje. Tako da možemo sada da počnemo sa prvim predavanjem, to je profesorka Teresa Lopez Fernandez. I hope you can hear me, she's live, or yes, you can hear us? Je li ovo snimljeno samo ili je live? This is live. Hello, Professor. I have just explained a little bit that we are missing you because last night was a very beautiful night here and day, and environment here is really fantastic. Here with me is Professor Sonja Šalinger, and you know her very well. And Professor Nevena Sečen, she's from Novi Sad. She's from the Institute for Pulmonary Diseases, is that right? And the idea is to have the insight on cardio-oncology from different points, yes, like starting from cardiology, you will have the first talk, and then Sonja will continue, and then we shall have the talk about the cardiovascular adverse events on the anti-cancer agents, and the final will be chemotherapy by Dr. Marijana Milović-Kovačević from the Institute for Oncology in Serbia, in Belgrade here. Okay, I think we can start, and with this lecture we shall have the discussion. Maybe we can have the discussion first after your lecture with the questions, because the later part will be in Serbian. The slides will be in English, but please, you can stay with us and you can comment after each presentation or at the end what you find interesting. So please, thank you again for accepting to participate to our Congress, and you can have a lecture now.
Thank you very much for this nice introduction. In fact, it's a pity that I cannot be there with you, but yeah, some clinical tasks make my life quite complex in the last weeks, so I wasn't able to be with you. So I'm not sure if you are able to see my screen. Yes? I hope so. Yeah. So during the next minutes, my task is to summarize the key messages for daily practice that are addressed by the 2022 ESC guidelines on cardio-oncology. These are my disclosures. And as you know, these guidelines have been developed in collaboration with very important societies. It's not just an ESC guidelines. We collaborate with the European Hematology Association, the European Society of Therapeutic Radiology and Oncology, and also the International Cardio-Oncology Society. And of course, these guidelines could be not possible without the time invested and the effort of all this amazing group of task force members, including Sonia Salinger, that is with you in the room. And of course, before to dive into the details of this guideline, I want to thank again this amazing group of experts that came from different places of the world, and also the amazing team of reviewers that help us to put these guidelines in our offices in order to help patients and to help cancer patients to complete their cancer treatment, minimizing the risk of cardiovascular toxicities. So this is the central animation of the guidelines, and in fact this animation summarizes the key aspect of the text. As you know, the risk of cancer therapy-related cardiac toxicity is a dynamic variable that is influenced by several cardiovascular and non-cardiovascular conditions, and this risk changes during cancer treatment according to the type, to the intensity, to the duration of cancer treatment, but also is highly influenced by baseline cardiovascular risk. Cardio-oncology strategy aims to minimize both the risk of cancer therapy-related cardiac toxicity, but also the risk of unnecessary cancer treatment interruptions. So we need to work on stratifying the risk of cardiovascular toxicity, on implementing preventive strategies before and during cancer treatment, and also in the reassessment of the cardiovascular toxicity risk at the end of cancer therapy, in order to recognize cancer survivors who are at risk of developing late cardiovascular toxicity. And the good news is that we have a lot of tools that can help us in detecting cardiovascular problems: advanced echo, CMR, cardiac CT, biomarkers, ECG, and the new tools with anatomical intelligence. But the main challenge we face is that we need to manage a large population of patients with cancer who need cancer treatment, sometimes who need lifelong cancer treatments, and most of them are under his 60s and with pre-existing cardiovascular toxicities. So we need to decide how to use in our daily practice all these tools that we have to detect early cardiovascular problems and to manage cardiovascular toxicities. So that's why the first recommendation of the guidelines is to assess the cardiovascular toxicity risk and to communicate the result of this assessment to the patient and also to all the healthcare professionals involved in the cancer care of this patient. I'm going to present you a short clinical example. So this is a 64-year-old woman, current smoker with a past history of hypertension and obesity. And she suffered a diagnosis of thyroid cancer a few years ago, then an atrial fibrillation, and last year a Hodgkin lymphoma. And she was referred to our clinic by the hematologist, and the main question is if she can receive anthracycline, because this therapy, R-CHOP, that is the standard treatment of non-Hodgkin lymphoma, includes anthracycline. And this is the second case I want to present you. This is a 71-year-old man with a type 2 diabetes and dyslipidemia. He is symptomatic, and he has a new diagnosis of lung cancer, non-small cell lung cancer, last year, and the oncologist wanted to start neoadjuvant treatment with carboplatin, paclitaxel, and also pembrolizumab. So here the question is a little bit different. And they ask us if complementary tests are needed before the use of immunotherapy. So guidelines recommend to assess the risk of cardiovascular toxicity using this risk score, the HFA-ICOS performance that are now included in the ESC Pocket Guidelines app. and help us to stratify the risk of cardiotoxicity in 4 categories: low risk, medium risk, high risk, or very high risk. On top of this pocket app, you can also find this performance very easy for your daily practice in the ESC website. So if we evaluate the first clinical case using this performance, because of the cardiovascular risk factors, we get a moderate risk of cardiovascular toxicity in patients who are going to receive anthracycline. But, as you can see, if we just focus on clinical evaluation, we miss important information for patients who are going to receive anthracyclines, because we do not have information of cardiac function, and probably it's also interesting to have information about cardiac biomarkers. So that's why in the guidelines we set precise recommendations to complete this clinical cardiovascular toxicity risk assessment using imaging tools, particularly echo and cardiac biomarkers, for patients who are going to receive drugs that can lead to heart failure, left ventricular dysfunction, or other significant cardiovascular events. In the case of patients who are going to receive anthracycline, there is a strong recommendation, plus one recommendation to perform an echocardiography before anthracycline, and for patients who are at moderate risk, like theoretically our patient, there is a class 2A indication to perform to assess cardiac troponins and NT-proBNP. So in our patient, we perform an echo, and as you can see, left ventricular ejection fraction was 53%, so low normal range of left ventricular ejection fraction. We also detect an increase in global longitudinal strain. The normal value for our institution is -18, and also a mild increase in NT-proBNP. So using this new data, if we go again to the proforma, I'm sorry because not sure why, but it seems that my PowerPoint doesn't work. Yeah, I think that I need to reinitiate the presentation. I'm sorry. So after the result of this echo and after the assessment of an increase in NT-proBNP, data are completely different because this information changes completely the risk of cardiovascular toxicity and brings our patient to a new category. So now our patient is at high risk of developing cardiovascular toxicity. So we decided with the oncology team to use a different strategy. The patient was referred to our cardio-oncology clinic for close follow-up as per ESC guidelines recommendation, and we also started cardioprotective strategies. Because she is going to receive anthracycline, we decided to change standard anthracycline by liposomal anthracycline, and we also introduced ACE inhibitors and a statin to improve the control of blood pressure and also to improve the control of dyslipidemia. And of course, we need to use anthracycline, but we need to adapt the treatment scheme to this high-risk condition, and we need to organize a close follow-up of these patients. Regarding the second case, the question was if it is necessary or not to perform additional complementary tests for patients who are going to receive immunotherapy. And this is not a standard practice, but guidelines recommend to perform an echocardiography to patients who are going to receive immunotherapy and meet one of these high-risk categories that you have here on the bottom of the slide. So patients who are going to receive dual immunotherapy or a combination of immunotherapy with cardiotoxic therapies, like our patient, or patients who have suffered previous cardiovascular toxicity. And on top of this new indication for baseline transthoracic echo, the guidelines also recommend the assessment of natriuretic peptide and troponin in all patients before immunotherapy, because sometimes these baseline levels of troponin or NT-proBNP are not normal, and to assess this baseline value help us to interpret data if the patient develop myocarditis or we suspect that they develop some problems during cancer therapy. So in this case, we wasn't aware that the patient has an asymptomatic mild left ventricular dysfunction that is probably in relation with an uncontrolled diabetes mellitus, and there is also a mild increase in NT-proBNP. So what does it mean? It doesn't mean that the patient cannot receive immunotherapy, but we need to evaluate what is the reason of this left ventricular dysfunction, and in fact we perform a coronary angiogram and we rule out a significant coronary artery disease, and we started heart failure therapy, and the patient was able to receive immunochemotherapy without any significant problem. So cardiac imaging is very, very important at baseline to reassess the clinical risk that we can get for cardiovascular toxicity. I'm so sorry because I think that again I have some problems with the videos. I really apologize of that delay. But yeah, the first part of my talk, I want to focus your attention really on the need of a cardiovascular toxicity risk assessment before cancer therapy to be sure what are the baseline cardiovascular conditions that can make our decision different. And of course, it's also very important to explain or to communicate this risk to the patients, because it's the only way that we have to improve the adherence to cardiovascular treatment and the adherence to oncologic treatment. So once we have this cardiovascular toxicity risk assessed, guidelines present different protocols, different surveillance protocols. So according to the type of treatment that the patient is going to receive and according to the risk that we have calculated, as you can see, for example, in patients with anthracycline, there is a strong recommendation to perform echo every 2 cycles for high-risk patients, but this recommendation is weak for patients at low or moderate risk. If we focus on immunotherapy, there is a strong recommendation to perform a baseline prospective echo, but during treatment it's most important to perform biomarkers, because biomarkers are going to be more sensitive to detect problems in relation with the immunotherapy. As I commented you before, the patient's involvement in their own cardiovascular care is also very, very important, and that's why the ESC created specific cardio-oncology guidelines for patients to increase their awareness on how to improve their cardiovascular health during cancer treatment. Other important aspect considered in the guidelines refers to the adjudication of cardiovascular events, to the management of cardiovascular toxicity, including the concept of pervasive cardiovascular toxicity. As you know, we have a new definition of this descriptive term, cancer therapy-related cardiac dysfunction, that embraces the different spectrum of a heart failure problem, and we use this new classification to establish the recommendation for the management of this CTRCD. There is also a new definition for IC myocarditis that focuses not only on endomyocardial biopsy but also on the role of CMR and the role of clinical criteria, and it's particularly important to remind that patients who develop immune-related adverse event, non-cardiovascular immune-related adverse event, have a higher risk of developing myocarditis, and that's why we need always to consider to assess cardiac troponin, for example, in patients who develop hepatitis or pneumonitis or myositis or myasthenia. This is the type of flow chart that you can find in the guidelines that refer to the management of different cardiovascular toxicities. In this case, this is the scheme for the management of CTRCD related to HER2 targeted therapies, and more or less all these schemes follow the same structure according to the diagnosis that we made, asymptomatic or symptomatic CTRCD. We established a proposal for oncology strategy and a proposal for cardiovascular strategy. And we include in the guideline different schemes for the management of the most common cardiovascular toxicity. It's also important to bear in mind that we just focus on what is different in patients with cancer when compared with general population. So you are not going to find in the guidelines the treatment, for example, on how to treat heart failure. We just specify what is different in this cancer population. And another important point of the guidelines, and I mentioned at the beginning of my talk, is the need to reassess the risk of cardiovascular toxicity at the end of cancer treatment to identify patients who are at long-term cardiovascular toxicity risk. So that's why it's very, very important, for example, in patients who receive anthracycline to perform an echo at the end of cancer treatment during the first 12 months after the cancer treatment in order to detect high-risk cancer survivors. And this new risk stratification strategy helped us to create again 3 different categories: low risk, moderate risk, and high risk, and you have different tables that summarizes the criteria for the different risk level, and according to this risk level there are specific recommendations for echo monitoring or for stress tests performing in cancer survivors. But the most important for cancer survivors is to be sure that we have an annual cardiovascular risk assessment, that we collaborate with our primary physician in order to organize a quick referral to our cardio-oncology or cardiology areas for patient survivors, for cancer survivors who have abnormal new finding during the follow-up. And it's also very, very important to reassess this long-term risk of cardiovascular toxicity every 5 years, particularly for young cancer survivors, because probably at 10 or 15 years after cancer treatment, if everything is normal, we can decrease the intensity of the So these are the 5 big messages of the guideline. I think that the first one is that it's needed to assess the baseline cardiovascular toxicity risk. If not, it's very, very difficult to interpret data during and after cancer treatment. According to this baseline risk, we need to personalize prevention and monitoring. It's also very important to try to harmonize in our clinical practice cardiovascular toxicity definitions and to use the one included in the guidelines. We think that guarantees a uniformity in the criteria, so that is going to help us not just during our clinical practice but also for research proposal. We need to be sure that we do not recommend to stop cancer treatment for patients who develop only minor forms of cardiovascular toxicity, and that's why permissive cardiotoxicity is also very important. And probably we need to work with not just at the hospital level but with our primary physician in long-term survivorship program. So thank you very much for your attention. I apologize again for the inconvenience. I'm happy to take your questions. Thank you.
Thank you, Dr. Teresa Lopez Fernandez. This was a great lecture, and thank you for the contribution, for the guidelines, both to you and the team, and Sonia with you. So maybe we have some time for a few questions, maybe for the, or from the audience. Is there any question now, or you can save it for the later time? May I ask you about the prevention and how do you do? I see in this patient that there is the statins and ACE inhibitors and beta blockers, and that is the first thing. And the second thing is, how do you organize practically in your clinical center these consultations about cardio-oncology patients? And this is, I think, one of the steps that we need to undertake in our hospital. So this is the new area. There is more and more patients will be with oncological diseases, maybe more or less with cardiology. So we are getting the patients from the oncology field probably.
Yeah, thank you for your question. So regarding the preventive strategies, is it true that patients who have previous cardiovascular risk factors or previous cardiovascular toxicity, what we really need is to be sure that they are under the best cardiovascular therapy? And is it true that, for example, for patients who have previous hypertension, sometimes they are under diuretic, and diuretic cannot prevent anything? So what we do in our clinical practice is to assess the standard cardiovascular risk and to check what are the medication or the cardiovascular medication that the patients are taking, and we try to promote the use of ACE inhibitors or beta blockers for blood pressure management, and also to be sure that patients are under statins if they have a high cholesterol level. For patients if we move to primary prevention scenarios, that refers to patients without cardiovascular disease, probably the evidence is not so strong. In fact, it's a class 2A recommendation with a level of evidence B. And the problem is that most of the trials or registry that have been published since now include patients with low cardiovascular toxicity risk. So it's very complex to demonstrate an important advantage of any medication if we just focus on low-risk population. But in the sub-studies of this population, patients with a high risk of developing cardiovascular toxicity, for example, patients with lymphoma who need high doses of anthracyclines, or patients with breast cancer that have been previously treated with anthracyclines and now need a big challenge because of a progression of the cancer. Is it true that particularly statin ACE inhibitors and beta blockers prevent the decrease in left ventricular ejection fraction? It is not clear if these medications prevent clinical events, but at least they prevent the decrease in left ventricular ejection fraction, which makes for us easier to keep the patient on treatment and minimize cancer treatment interruptions. So regarding how we organize our clinical practice, we agree with the oncology and the hematology team on local protocols. So only patients at high risk are referred to our cardio-oncology clinic, and patients with low or moderate risk are controlled by the oncologist or hematologist, and only if they develop an increase in cardiac biomarkers or some problems at echo or new symptoms, in that case they are quickly referred to our clinic, and we try to be very, very flexible with these patients, and in general it took for us 2 or 3 days to have the patient in our clinic. So we try to minimize the delays, to minimize also the delay in cancer treatment.
Okay, thank you very much. So I think we can move to the next lecture. Prelazimo znači na drugo predavanje koje će dati profesorka Sonja Šalinger. Vidjeli ste da je ona bila jedna od autora ovoga teksta, preporuka, i tu ćemo govoriti o specifičnoj jednoj situaciji, o kanceru, o plućnim embolijama koji su povezani sa karcinomima.
Samo ako možemo da promenimo za moje predavanje. Ili ste vi? Aha, ja sam, dobro. Hvala puno svima. Prvo, čast mi je da pričam na ovom sastanku i zahvaljujem se profesoru Beleslinu i profesorki Sečan što sam ovdje s njima i što smo mogli da čujemo i Terezu, koja je jedan od 2 prvih autora preporuka gde sam ja u stvari s ponosom učestvovala u njihovoj izradi. Ja ću se baviti plućnom embolijom, odnosno probati da nešto pričam o tome, zato što je plućna embolija nešto što značajno utiče na letalni ishod bolesnika sa malignitetom i prosto je drugi uzrok letalnog ishoda i u odnosu na ukupnu populaciju 47 puta povećava rizik od letalnog ishoda, što će reći da je to povećanje hazard ratio za 31,2%, možda, da, tu je bolje ovako da pokažem. Znači, jako, jako važan entitet. Ne treba da pričam, mislim da je svima poznato da je sam malignitet u stvari jedno protrombotično, prokoagulantno stanje, počevši od ćelija samokarcinoma, preko aktivacije faktora koagulacije, preko endotela, preko aktivacije trombocita, skupljanja neutrofila u mreže i sve u svemu to dovodi do jedne tromboze koja može biti i venska, i arterijska i u konačnom voditi i ka dubotkoj venskoj trombozi, ka plućnom embolizmu, ka cerebrovaskularnim insultima i akutnom koronarnom sindromu. Dakle, faktori rizika koji dovode do nastanka venskog tromboembolizma kod ovih, nažalost, najtežih bolesnika jesu u stvari vezani za samog pacijenta, za sam malignitet, za terapiju koju pacijent dobija i naravno ne manje važni su i biomarkeri. Samo kratko podsjećanje, nemaju svi tumori, odnosno karcinomi, jednak rizik kod venskog tromboembolizma. Najveći su u stvari stomaka, odnosno abdomena, odnosno luminalni maligniteti, želuca, pankrasa, mozga, potom nešto manjeg rizika, ali takođe visokorizični, karcinom pluća, hematološki, ginekološki, karcinomi bubrega, mokraćne bešike, jako je važan histološki stadijum maligniteta, stadijum same bolesti, dakle uznapredovali karcinom ili metastatska bolest dodatno povećavaju rizik od venske tromboze i naravno vreme od dijagnoze samog maligniteta, gde je ključan period taj unutar prvih 3 meseca. Dakle, na početku je povećan rizik, dodatno terapija može povećati rizik, sve se stišava u remisiji, ali ako krene progresija bolesti, metastatska bolest, prosto se rizik dodatno povećava. Dakle, incidenca je 5,8 na 100 pacijent godina i, nažalost, ta prva 3 meseca su u stvari ključna, odnosno prvi godinu dana, tokom kog perioda se u stvari odvija i dijagnostika, i terapija, i prosto profesorka je pozvanija da priča o tome, ali zaista to je taj jedan najkritičniji i najvulnerabilniji period za ove bolesnike. Dakle, ja sam u stvari jedan od učesnika i reper registra, to je regionalni registar za plućnu emboliju, koji je u stvari počeo na Vojnomedicinskoj akademiji, gde je tvorac registra u stvari profesor Obradović, Slobodan Obradović. Nakon toga veliki broj institucija je uključen i u Srbiji, proširen i na Republiku Srpsku, i na Crnu Goru, na Makedoniju, i počela i Hrvatska i Slovenija, tako da to širimo. I u stvari na taj način smo došli do izvesnog broja pacijenata koji imaju i maligne bolesti. Kada smo ih stratifikovali u odnosu na to kada se desila venska tromboembolija, odnosno plućna embolija, prosto bolesnici kod kojih je plućna embolija prva manifestacija maligne bolesti su imali najveći rizik, odnosno imali i najkraće preživljavanje i to statistički značajno, što je jako važno da kada plućna embolija u stvari nas negde navede na to da postavimo dijagnozu maligne bolesti. Takođe, u prvih 6 meseci se događa i najveći broj ponovljenih epizoda venskog tromboembolizma i korana risk score, koji je dosta već dugo poznat, nam prosto negde može pomoći da predvidimo potencijalni rizik za ponavljane epizode venskog tromboembolizma kod pacijenata koji su na hemioterapiji. Kumulativni rizik od rekurence tokom hemioterapije je najveći kod maligniteta pankreasa, želuca, pluća i potom idu niže kategorije. I sada, kada napravimo paralelu sa akutnim koronarnim sindromom, gde smo se jako bojali krvarećih komplikacija, ovde postoji rizik od krvarenja, ali nažalost, ovi bolesnici i dalje su većma ugroženi od tih ponovljenih trombotičnih događaja. To je prosto pokazano i u Rijete registru, da je bio povećan rizik i od fatalnih plućnih embolija, nešto manji od krvarenja, ali svakako veći kod bolesnika koji su imali malignu bolest. S druge pak strane, nastupa taj izazov terapije. 63% bolesnika ne nastavlja sa terapijom niskomolekularnim heparinom tokom 6 meseci. A još teži, mislim, onako opasni podatak je da manje od 50% tokom godinu dana bude na antikoagulantnoj terapiji, a kod visoko i veoma visoko rizičnih maligniteta je potrebno upravo zbog rizika od rekurentnih tromboembolizama. Otava skor može biti korisno oruđe za stratifikaciju eventualno 6-mesečnog rizika od venskog tromboembolizma kod bolesnika koji već dobijaju antikoagulantnu terapiju. I svakako, kada pogledamo guidelinese za terapiju plućne embolije, de facto maligniteti predstavljaju permanentni, odnosno perzistentni, veliki faktor rizika koji nam u stvari nameće obavezu za produženo lečenje, zato što je 5-godišnja kumulativna incidenca 43%. Dakle, šta s terapijom? Prosto svi smo negde već friendly sa niskomolekularnim heparinom i definitivno da je efikasni od vitamin K antagonista. Negde su se terapiji niskomolekularnim heparinom približili noaci, odnosno doaci, međutim tu još uvek je potrebno napraviti balans i personalizovati pristup, kao što je prosto i navela profesorka Fernandez. Dakle, CLOT, CATCH studija, prosto stare studije, nama već poznate, gde su definitivno niskomolekularni heparini prosto negde zauzeli primat u odnosu na vitamin K antagoniste. Brojne studije sada sa već nama poznatim doacima ili noacima, rivaroksabanom, apiksabanom, tu je, znači, se pojavljuje doksaba na našem tržištu, su negde omogućile da nam i ovi lekovi pomažu u lečenju ovih bolesnika. Dakle, pokazano je da su efikasni i da ne prave mnogo veći rizik od krvarenja, odnosno da nema mnogo više po život opasnih krvarenja. U stvari, to i jeste bila suština njihovog uvođenja u tretman pacijenata koji imaju atrijalnu fibrilaciju. Dakle, kod bolesnika koji imaju simptomatsku ili incidentalnu vensku tromboemboliju, znači važno je prvo istaći da je incidentalna venska tromboembolija, odnosno plućna embolija, takođe entitet koji treba lečiti, ranije je to bilo još uvek triki, a takođe je važno da je dokazano da noaci jesu i bezbedni i efikasni i ponavljam da venski tromboembolizam značajno može doprineti letalnom ishodu i to mnogo više nego krvarenje, mada i krvarenje ne smemo zaboraviti i uvek imati na umu pristup svakom pacijentu per se. Meta-analiza poznatih studija rivaroksabanom, sa apiksabanom, edoksabanom je de facto pokazala da su ovi lekovi i efikasni i bezbedni. Ali recimo evo jedan praktičan algoritam, kanadski, za onkološku upotrebu. Dakle, jako je važno proceniti rizik od krvarenja. Važno je proceniti broj trombocita, kao što je važno i kod pacijenata sa atrijalnom fibrilacijom, proceniti funkciju bubrega, znači prosto, jednostavno, imamo kalkulatore, proceniti već postojeće krvarenje, rizik od krvarenja svakog pojedinačnog pacijenta i na osnovu toga odlučiti kako ćemo ići s tim dalje. Ne manje važna je i terapija, adjuvantna terapija i na osnovu toga donosimo zaključak. Ukoliko je broj trombocita manji od 25.000 i ukoliko procenimo da će tromboza definitivno ugroziti pacijenta, možemo čak pribegavati i transfuziji trombocita, ali je svakako jako važno ponovo pratiti mogućnost povećanja broja trombocita, proceniti faktore koji se mogu modifikovati, koji doprinose riziku od krvarenja i shodno tome svakom bolesniku prilagoditi terapiju. Može se čak koristiti i Has-Bled score. Ne manje važna, ponavljam, jeste interakcija doaka sa ostalim lekovima, kao i interakcija sa adjuvantnom terapijom koja nije specifična za malignitet. Moramo poznavati metabolizam, pogotovo noaka, a postoji čak i mogućnost da ukucavanjem 2 leka koje želimo da damo, da na sajtu drag interakcije prosto procenimo da li će biti pojačanog dejstva noaka ili njegovog smanjenog dejstva, da li se lekovi metabolišu preko citohroma Petrija 4, da li zavise od glikoproteinskih transportera ili prosto ne zavise. Jako je važno napraviti razliku aktivnih maligniteta, a to je dijagnoza unutar 6 meseci, hemio, radioterapija, hormonska terapija, hirurgija u prethodnih 6 meseci, jer u konačnom sama hirurgija bez drugih faktora rizika predstavlja rizik od plućne embolije, odnosno venskog tromboembolizma, aktivna metastatska bolest, aktivna rekurenca i svakako plućna embolija zahteva duže lečenje, ne 3, nego 6 meseci, nekada i do kraja života. Ovo je u stvari jedna dobra šema i akronim TBIP kod bolesnika koji imaju malignu bolest. Dakle, proceniti rizik od tromboze, proceniti rizik od krvarenja, proceniti interakciju i proceniti preferencu pacijenta. Ovo je samo potvrda terapije rivaroksabanom u realnom životu, gde je taj, da kažem, jedan registar sproveden u Sjedinjenim Američkim Državama, Velikoj Britaniji, Švedskoj i pokazao, ne samo što se tiče rivaroksabana, već i svih doaka, da mogu biti efikasni i bezbedni ako se primenjuju bazirano na riziku od krvarenja. Dokazano je da čak i manje doze, recimo apiksabana, mogu izazvati više krvarenja kod maligniteta koji su skloni krvarenju, što se odnosi i na rivaroksaban, što je u stvari jako važno za luminalne malignitete. gastrointestinalnog i genitourinarnog trakta. Recimo, čak je rađena jedna pilot studija sa rivaroksabanom kod gastrointestinalnih maligniteta, odnosno nakon laparoskopske hirurgije kolorektalnog karcinoma, gde je zaista bio efikasan i gde je tokom tog kratkoročnog praćenja nije bilo mnogo neželjenih efekata, ali prosto to zaista zahteva jedno duže praćenje. Kao što je dokazano i u Kazini studiji, takođe znači da može da se koristi i za prevenciju, ali takođe uz oprez i prilagođeno svakom pacijentu. Dakle, visokorizični pacijenti mogu dobiti i u tromboprofilaksiji rivaroksaban i apiksaban. Niskomolekularni se preporučuju, naravno, ukoliko se bojimo uopšte bilo kakve tromboprofilakse, ako su visokorizični za razvoj trombotičnih događaja, treba ga primeniti. I naravno da se treba voditi u stvari poslednjim konsenzusom, a ovo je u stvari grupni konsenzus Internacionalnog udruženja za trombozu i hemostazu. Važno je da se noaci mogu uključiti. Kod pacijenata je doksaban posle 5 dana od niskomolekularnog heparina, ukoliko pacijent nema visok rizik od gastrointestinalnog ili genitourinarnog krvarenja. Važno je produžiti terapiju na minimum 6 meseci. Važno je da ako se desi rekurentni događaj, treba zameniti antikoagulans, treba tretirati i trombozu katetera. Važno da pacijenti koji imaju tumore mozga, a kojima nije rađena neurohiruška intervencija, ne zahtevaju primarnu tromboprofilaksu. Važno je da su u Averti Kazini studiji čak i pacijenti sa 50.000 trombocita dobijali tromboprofilaksu ako su bili na visokom riziku. I za mene užasno, ali takođe jako važno, da čak i deca koja imaju propisanu hemioterapiju zbog akutne limfoblastne leukemije, trebalo bi da dobiju tromboprofilaksu niskomolekularnim heparinom. Dakle, treba proceniti da li su lečeni, da li su izlečeni, neki se ljudi smatruju izlečenim ili aktivni maligniteti, dakle taj period 6 meseci. Za pacijente koji su kod kuće, naravno da je nekako komforniji doak, ali ako nema rizika od krvarenja, odnosno ako primarna lokalizacija maligniteta to dozvoljava, niskomolekularni zahtevaju staf, s druge pak strane u našoj zemlji nuaci, odnosno doaci, nisu na listi, potrebna je velika saradnja i velika ponekad finansijska pomoć, što znači da su važni ti socijalni aspekti. Važno je proširiti delovanje i na primarnu praksu, na sekundarne bolnice, tercijarne centre, jer naravno da instituti, profesorka će o tome pričati, svakako rade to perfektno na najvišem nivou. Važno je proceniti malignitete i važno je da ovoj priči pristupimo timski. Dakle, i onkolog, i hematolog, važni su i klinički farmakolozi, kardiolozi, radiolozi i hvala vam na pažnji. Jer kardionkologija jeste u stvari da lečenjem maligniteta čuvamo srce.
Hvala profesorka Šalinger na odličnom predavanju. Da li ima nekih pitanja? Mislim da možemo odmah. Dobro, ako nema, možda možemo i posle da ostavimo za kraj za diskusiju. Sada bih zamolio profesorku Sečen da održi predavanje na temu kardiovaskularnih neželjenih događaja povezano sa lekovima protiv karcinoma.
Poštovane kolege, pre svega bih želela da se zahvalim profesoru Beleslinu što je organizovao ovu sesiju, što je imao feelinga i da o ovoj problematici je potrebno da porazgovaramo. Kao dugogodišnji onkolog, ja sam u Institutu za plućne bolesti Vojvodine u Sremskoj Kamenici, dugi niz godina načelnik odeljenja za dijagnostiku i terapiju karcinoma bronha, pa bih vam sada i u većem delu govorila i kao kliničar, praktičar, jer uvek sa mojim mlađim kolegama razgovaram da je efikasnost onkološke terapije zavisna od našeg razmišljanja o nuspojavama. Mnogo se pažnje obraća na hematotoksičnost svih antikancerskih oblika lečenja i u poslednje vreme o kardiotoksičnosti, s obzirom da i naše kolege u Evropskoj uniji, naročito profesorka Silvija Novello iz Torina, daju tome veliki značaj. Iz naše kliničke prakse mi imamo izvanrednu saradnju sa kolegama sa Instituta za kardiovaskularne bolesti u Sremskoj Kamenici, možda što smo i pod jednim krovom, možda što smo mi u Vojvodini svi nekako povezani i rođački, i komšijski, i prijateljski, tako da ta saradnja zaista je izvanredna i Branko zna naše i kolege iz Instituta za kardiovaskularne bolesti, mnogima je žao što nisu prisutni ovde. Tako da je poruka i pozdrav da bi oni želeli sledeće godine da učestvuju na ovim sastancima, ali naš algoritam je kada bolesnik dobije dijagnozu maligne bolesti, da se mora pripremiti za dalje neoplastično lečenje. Ukoliko je hirurgija u pitanju, onda je to vrlo kompleksno kardiološko ispitivanje, a ukoliko je terapija, isto tako mi uvek prvo uradimo kardiološki status i nijedan naš pacijent ne može da ode na terapiju ukoliko nema bazični kardiološki pregled koji uključuje EKG, ehoekcionu frakciju i mišljenje kardiologa. Tako da od tog baseline statusa mi počinjemo sa terapijom. Rekla sam vam da mi mnogo vodimo računa o nuspojavama, ovde normalno da se usredsredimo na kardiotoksičnost koja je dosta sada isto proširena zahvaljujući brojnim novim terapeuticima. Dosta po literaturi se spominju antrациklini koji su zaista bili vrlo kardiotoksični, međutim oni se u novim protokolima ne koriste tako mnogo, znatno više se koriste sada drugi oblici iz drugih grupa koji su čak i manje kardiotoksični, ali na što sve treba da mislimo kako bismo prepoznali kardiotoksičnost kod naših pacijenata, koje sve nuspojave mogu hemioterapeutici, imunoterapija da uzrokuju. Mogu da dovedu do ono što je za nas najjednostavnije hipertenzivne krize. Vrlo često u dnevnoj bolnici imamo hipertenzivne krize jer ovi pacijenti kao premedikaciju dobijaju dosta kortikosteroida, tako da samim time možemo da izazovemo, zatim srčana insuficijencija, poremećaj ritma, zatim može da se razvije miokarditis, može da se razvije infarkt miokarda, čuli ste od profesorke o tromboemboliji pluća, pa čak i valvularne bolesti. Rekla sam da su nekako iz našeg iskustva antrациklini najviše kardiotoksični i tu su bili oni protokoli koji su imali u svom sastavu doksorubicin, epirubicin, kao što vidite iz ove tabele. Ovi novi preparati imaju znatno manju incidencu u pogledu kardiotoksičnih efekata. Čak normalno kao i svugde doze utiču na nuspojave, pojave, tako da i doze bi onaj čuveni AKO protokol koji smo mi koristili u torakalnoj onkologiji, adriamicin, ciklofosfamid i onkovin, i tu smo imali zbog adriamicina veliki procenat kardiotoksičnih efekata i onda smo smanjivali dozu adriamicina do 25%. Kad razmišljamo o kardiotoksičnosti, moramo da imamo pred sobom pacijenta u celini, ne samo njegovu bolest, nego i pacijenta kao čoveka, kao nosioca prvogenetskih osobina, da li je i u njegovoj porodici značajan procenat obolelih od kardiovaskularnih bolesti, da li je on sam imao ranije kardiovaskularne tegobe, da li je bio ranije na nekim tretmanima koji su imali isto kardiotoksični efekat. Zatim moramo da posmatramo i faktore rizika, jer u našoj zemlji je veliki broj pušača i mnogo je bolesnika koji koriste i alkohol i čiji je body mass index znatno viši nego što se očekuje. Koji su znaci, jer i sa studentima kad razgovaramo uvek kažemo prvo nam recite simptome i znake bolesti. Kako prepoznati kardiotoksičnost? Ako je kardiotoksičnost, što se mi delimo levo i desno srce, kao desno srce je naše pulmološko, levo srce je kardiološko, i prvo kad vidimo da nam pacijent koji prima ili koji je primio antikancersku terapiju dispnoičan, moramo se odmah zamisliti zašto je on dispnoičan, da li je ta dispneja akutna, da li je u vezi sa osnovnim oboljenjem, da li je u vezi sa terapijom koju prima. Zatim, ako primetimo da je više cijanotičan nego što je bio prilikom ulaska na terapiju, i tu moramo odmah da vidimo zašto se taj parcijalni pritisak kiseonika snižava i da li je to toksičan efekat terapije. Zatim, fizikalni pregled je uvek neophodan da vidimo da li je došlo do nekih znaka popuštanja srčane funkcije i da vidimo kako je stanje jetre, da li ima astit, da li ima edeme, da li ima povećan pritisak u jugularnim venama. Sama definicija kardiotoksičnosti je kada imamo ekcijnu frakciju koja se smanjuje više od 10% i da je ispod 50% od one koja je uobičajena, iako imamo znake hronične srčane insuficijencije. Ovo je malo podsjećanje na patohistološke procese i biohemijske koji se javljaju kod kardiotoksičnosti. Opet vraćam se da su većina ispitivanja rađena kod toksičnih efekata antrациklina i da tu dolazi do miocitne fibroze koja opet uslovljava nekrozu i tako dolazi do tih toksičnih efekata. Kojim dijagnostičkim sredstvima se služimo da bismo potvrdili da se radi o kardiotoksičnosti? Pa to je klasično EKG, ehokardiografija, zatim radionukleidno ispitivanje i gde postoji mogućnost za kardijalnu magnetnu rezonancu, a uvek u svakoj instituciji i drugoj i sekundarnoj i tercijarnoj postoji mogućnost da vidimo kakav je biomarkerski status, kakav su probio-MP i troponin. I kod poremeća kardijalne disfunkcije proBNP može da bude i normalan, može da bude lako povišen i izuzetno povišen, a troponin isto tako može da u početku je normalan, zato ga treba i pratiti da vidimo, da uhvatimo onaj moment kada se on povišava. kod bolesnika koji su na antikarcerskom tretmanu. Znači, moramo da uradimo ove bazične preglede da bi imali jedan, što mi u našem srpskom jeziku kažemo baseline file, i da onda pratimo razvoj posle te kancerske dijagnoze i same terapije i da se stalno detektuju promene. Mi možemo na početku terapije da imamo pacijenta koji je vrlo stabilan, ali da u toku terapije dolazi do kardiotoksičnog efekta. Mi smo recimo imali na paklitaksel dosta burnih reakcija, tako da smo nekada morali čak i da prekidamo terapiju i da prelazimo na druge protokole. U kliničkoj praksi, u našoj torakalnoj onkologiji, paklitaksel, odnosno taksel, je pravio najviše problema. Uvek se potpomažemo prilikom donošenja definitivne odluke o promeni protokola sa analizom biomarkera i naravno da se uradi ehokardiografija koja je sada dostupna svugde, a magnetna rezonanca ako je moguće da se uradi, ako ne, ovo bi onda bio jedan kompleks koji bi mogao da dovede do zaključka. Kako se rešavaju ovi kardiotoksični problemi? Pa uvek se preporučuju AC inhibitori, preporučuju se beta blokatori i naravno saveti pacijentima kako moraju da vode svoj život uz ograničenja različita i uz upotrebu drugih sredstava, a vrlo često i mi moramo da prelazimo na druge protokole. Pacijenti koji su primali AC inhibitore i beta blokatore imali su mnogo veću efikasnost i od same hemioterapije, što pokazuju i ove tabele. Isto tako, pacijenti koji su koristili, bili na VEGF inhibitorima, vaskularnim inhibitorima, što je sad vrlo popularna terapija i u karcinomu bronha i u lečenju karcinoma bubrega, imali su kardiotoksične efekte na koje je trebalo da se misli i vrlo često imaju i tromboembolizam. Ovo se ponavljamo i prvi i drugi predavač su imali ovaj ESMO algoritam za lečenje kardiotoksičnih efekata, tako da mislim da to treba da stoji u svakoj dnevnoj bolnici i da je dostupno svakom onkologu kako bi se moglo pre svega na vreme sprečiti da dođe do kardiotoksičnih efekata. Danas se uopšte u onkologiji dosta koristi imunoterapija. Imunoterapija je konkretno kod karcinoma bronha napravila veliki bum u lečenju, ali kao i sve terapije ima i svoje izuzetno dobre efekte, ali ima i nuspojave. Nuspojave su zaista retke, ali se na njih mora misliti. Najčešća nuspojava imunoterapije je pneumonitis i to dosta često viđamo u kliničkoj praksi. Vrlo malo smo videli kod imunoterapije kardiotoksičnih efekata, ali opet kažem moramo uvek biti oprezni, misliti na miokarditis koji može da se javi kod terapije sa imunoterapijskim checkpointsima i tu kako ćemo prepoznati? Pa prepoznat ćemo zahvaljujući analizi biomarkera, zatim EKG, vidjet ćemo kakva je ekciona frakcija, koliko pada i onda ili uključujemo kortikosteroide ili ako je blažeg stepena uključujemo, samo ih pratimo. Ovde imamo jednu metaanalizu gde se vidi koliko se često miokarditisi razvijaju kod kojih lekova, pa vidite da kod bolesnika koji su bili na imunoterapiji je procenat vrlo mali u odnosu na bolesnike koji su bili na hemioterapiji. Ovi immunocheckpoints dovode često do promene u sprovođenju, tako da tu može da dođe do produženja QRS kompleksa i vrlo je bitno da se redovno prati kod ovih bolesnika EKG kako bismo mogli da odmah vidimo kada se počinju razvijati promene. Perikarditis je isto znatno češći kod bolesnika koji su na hemioterapiji nego kod bolesnika koji su na imunoterapiji, ali i kod perikarditisa treba biti vrlo oprezan jer on može biti i posledica diseminacije onkološke bolesti, tako da uvek mi imamo mogućnost u institutu da se uradi i punkcija i da se ta tečnost evakuiše i citopatološki izanalizira. Kod pacijenata koji su na imunoterapiji je vrlo mala, bila je znatno veća kod bolesnika koji su na hemioterapiji. Zatim, kod bolesnika koji su na svim oblicima antikancerskog lečenja može da se razvije i koronarna bolest, ovo smo već spomenuli, produženje QT kompleksa, i moramo uvek da mislimo na one rizikofaktore koji se javljaju u toku terapije. Naprimer, pacijenti koji su na platinskim dubletima imaju često u 94% nauzeju jer sama platina uzrokuje mučninu i kroz tu mučninu oni mogu da uđu u elektrolitski disbalans koji opet povlači tegobe kardiološke i da se kroz to razvije kardiološka disfunkcija. Hipertenzija, rekla sam da je vrlo česta i mi je vrlo lako rešavamo u dnevnoj bolnici. Zatim trombocitopenija se često javlja, vrlo često se i završava da pacijentima dajemo dodatne trombocite, a o tromboemboliji ne bih govorila s obzirom da je profesorka izvanredno predavanje održala, pa da vam ne oduzimam vreme. Kardiotoksičnost se javlja i kod radioterapije. Opet kod radioterapije, bar kod ovih naših bolesnika sa karcinomom bronha, najčešće su fibroze, odnosno postiradijacioni pneumonitisi. Kardiološke smetnje mogu da se jave, ali su ređe u odnosu na pulmološke i tu je jedan moment gde moramo pacijente dugo da pratimo jer ova kardiotoksičnost nakon radioterapije može da se javi protrahirano, može da se javi čak i nakon 5 godina po aplikaciji. To je ono što se mi sa hirurzima raspravljamo. Hirurzi kažu ja sam vas izlečio i vi ste zdravi. Ovi bolesnici moraju biti stalno pod onkološkim okom. U početku, u prve 2 godine na 3 meseca, u 3. godini na 6, u 4. isto na 6 i onda u 5. nadalje jednom godišnje. I što bi naš Đole Balašević rekao, mi smo slovenske duše, pa uvek na to 3-6 napišemo, a prema potrebi ranije, što pacijentima daje sigurnost i zaista ne zloupotrebljavaju. Dok u nekim drugim ustanova van ovog regiona su striktni, samo primaju na određeni termin. U zaključku bih ponovo rekla da je potrebno da se na sve nuspojave misli mnogo i da ishod lečenja zavisi od razmišljanja o nuspojavama jer time se omogućuje regularan tok aplikacije terapije i da u tumor bordu bi bilo dobro da imamo i kardiologa da se sve brže i lakše rešava. Hvala na pažnji.
Izvanredno i na kraju, ali ne i najmanje važno, a to je u stvari kardiotoksičnost izazvana hemioterapijom. Drago mi je da je tu s nama primarijus doktorka Marijana Malović-Kovačević vrlo izazovna tema, vrlo izazovno dijagnostikovati, ali i lečiti. Izvolite.
Drago mi je da sam danas s vama i zaista mi je velika čast što sam među profesorom Beleslinom, Šalinger i Sečen, zaista je divno slušati vaše predavanja. Moje predavanje će biti prilično slično i profesorki Sečen, zato što zapravo je tema prilično slična, ali ja ću negde pričati iz ugla onkologa koji se bavi karcinomom dojke i karcinomom ginekologije i negde ću možda tokom predavanja neke stvari ponoviti što je rekla profesorka Sečen, jer je tema veoma slična, ali bih ipak poentirala ono gde mene dotiče u kliničkoj praksi, nešto o čemu ja negde najviše znam i šta je to što možemo eventualno menjati i popravljati, pa bih sa vama naravno posle i prodiskutovala. Znači, naravno, kardio-onkologija je veoma važna tema i mi znamo da su pomaci u lečenju naših bolesnika sa onkološkim bolestima značajno se poboljšali i naše pacijentkinje i pacijenti značajno duže žive. Ti novi molekularni lekovi koji targetiraju određene signalne puteve i određene targete definitivno su u svim tumorskim tipovima, pre svega solidnih tumora, ispitivani i oni su prilično toga promenili, ali definitivno doneli i doveli neke nove toksičnosti, između ostalog i određene oblike kardiotoksičnosti sa kojima se mi negde upoznajemo i prilično smo i mi mladi u tim iskustvima i nije nam lako da uvek dobro procenimo i što najgore nije nam lako da uvek na vreme procenimo. A vreme je ključni moment kada govorimo o kardiologiji. Naravno, kardiovaskularni neželjeni efekti raznih kancerskih tretmana su različiti. Čuli smo da to može biti različita disfunkcija miokarda, koronarne bolesti, zatim akutne prolongacije, aritmija, infarkt miokarda, valvularne bolesti i da zapravo različiti lekovi, s jedne strane hemioterapija, s druge strane VEGF antitela, s treće strane HER2 blokatori, znači monoklonalna antitela i danas antitelo drag konjugati koji su zaista izuzetni lekovi, izuzetni po svojoj efikasnosti, ali nažalost mi smo tu da se upoznamo sa ne tako lakom toksičnošću koju ovi lekovi izazivaju. I znamo da antraciklini sa kojim imamo vekovna iskustva moraju se i tekako dobro dozirati i ovde ćelije miocida pamte. Znači, ukoliko ste dali antracikline, recimo, i do 20 godina unazad, ne znači da možete ići opušteno sa dozom 20 godina kasnije kada dođe do relapsa bolesti, već zaista moramo poštovati ove kumulativne doze koji svaki antraciklin ima ponaosob, jer ukoliko vidite pređemo kumulativnu dozu kod antraciklina, procenat incidenca verovatnoće za srčanu insuficijenciju raste za više od 5% ukoliko premašimo ovu dozu. Tako da to zaista jako retko radimo, samo u slučaju da je zaista od vitalnog značaja. Znamo da postoje različiti rizikofaktori, to smo čuli od profesorke Sečen i sve zajedno sa našim onkološkim lekovima, to dalje potencira mogućnost da se dođe do veće verovatnoće za kardiotoksičnost. Naravno, to su prethodne kardiovaskularne bolesti, prethodni kardiotoksični režimi, recimo radioterapija toraksa, demografske karakteristike i naravno životni stil. Nikad ne smemo da zaboravimo da moramo pacijentu objasniti da je jako važno da ne puši, da ne pije i da vodi računa o svojoj telesnoj težini, jer to zaista nije samo predmet estetike i primerenosti biti ne debeo, nego je zaista izuzetno važno, jer je to jedan elementaran znak da ste nezdravi ukoliko dozvolite gojaznost. I naravno znamo da postoji levostrana i desnostrana srčana slabost i znamo da je prepoznajemo, mnogi od nas smo završili internu medicinu i specijalizirali kardiologiju, ne bih ovo ponavljala, a definicija kardiotoksičnosti je važna. Još jednom da ponovim da je ekcijna frakcija ukoliko padne za više od 10% i ukoliko se deci da je ekcijna frakcija leve komore ispod 50% sa ili bez simptoma srčane insuficijencije smatra se kardiotoksičnošću. I zapravo jedan miocid zdrav svakodnevno ima jedan balans između proteinske degradacije i proteinske sinteze, ali ako deluje antraciklin kao stresor i izaziva oksidativni stres i osloboda reaktivne slobodne radikale i dođe do porasta kalcijuma u citosolu, to dovodi do velike aktivnosti proteaza, do jednog disbalansa, do izuzetno jake proteinske degradacije i druge strane nedovoljne proteinske sinteze i miociti dolaze do neke gubitka homeostazi i organizacije, a sledstveno dalje se kaspaze aktiviraju u smislu da budu još funkcionalnije, još aktivnije, dolazi do miocidne apoptoze i na kraju irreverzibilno do miocidne nekroze, odnosno do irreverzibilnog gubitka dela srčanog mišića. Vidimo da postoje osnovna dva tipa kardiotoksičnosti. Antraciklini izazivaju tip 1. To je irreverzibilni tip kardiotoksičnosti koji je uzrokovan mehanizmom oksidativnog stresa, kiseoničnim slobodnim radikalima, oštećenje dovodi do miofibrilane nekroze i definitivno imamo ovde kumulativnu toksičnost. Tip 2 je trastuzumab koji je tipičan za tip 2 kardiotoksičnosti, to je monoklonalno antitelo koji izaziva HER2 blokadu i mehanizam delovanja upravo preko HER2 signalne blokade, ne izaziva ultrastrukturne promene, nije kumulativnog karaktera, generalno je reverzibilno i ta disfunkcija je privremena. I to je jako važno znati za kliničara koji će dalje odlučiti da li određene terapije može ponovo startovati nakon oporavka erekcione frakcije, a koje su to terapije koje zauvek moraju da se obustave. Isto tako, jako je važno i dugo godina smo razmišljali kako je moguće i da li je moguće primeniti antracikline zajedno sa trastuzumabom, odnosno herceptinom, koji je HER2 blokator, da bismo što bolje i što efikasnije eventualno lečili karcinom dojke i kao što vidimo ove plavi pravogaonici definitivno govore da nikako, ukoliko to zaista nije neophodno, ne treba dati istovremeno antraciklin i trastuzumab, odnosno HER2 blokator, zato što je verovatnoća kardijalne disfunkcije i verovatnoća NIH 3-4 apsolutno veća ukoliko istovremeno primenimo antracikline i trastuzumab, što znači jedino danas je dozvoljeno da se navedena terapija primenjuje sekvencijalno, a nikako konkomitantno. Takođe, čuli smo različite dijagnostičke metode, mi najčešće ehokardiografiju koristimo, ona nema i radijaciju, ali negde imamo limitacije što je malo ipak subjektivna i negde limitirana kod nekih promjena na toraksu, muga ima veći reproducibilitet, ali ipak ima i radijaciju, tako da u suštini mi danas najčešće koristimo ultrazvuk, ehokardiografiju, magnetna rezonanca je često teško sprovodljiva zbog ekstremnih troškova i klaustrofobije, a definitivno je jako precizna. I naravno u dijagnostici moramo koristiti kardijalne biomarkere, gde generalno ukoliko imamo kardijalnu disfunkciju, ovde imamo uglavnom BNP koji je normalan ili je eleviran, ali troponin T ili I, on je uvek normalan. A ako imamo nekrozu, eleviran je i BNP i troponin i to je važno prilikom neke naše diferencijacije o kom tipu miokardnog problema se radi. Isto tako, htela sam da kažem da je ova HERA studija jedna od najvažnijih studija za nas kliničare od izuzetnog značaja, jer je zaista herceptin, odnosno trastuzumab kao HER2 blokator doveo do neverovatno velike redukcije rizika za smrtni ishod kod naših pacijentkinja i tu jezivu prognostičku grupu pacijentkinja sa HER2 overekspresijom potpuno transformisao, gotovo da mi kliničari volimo da vidimo HER2 3+ ili CIŠ pozitivnu pacijentku, jer ćemo je imati mogućnosti lečiti targetnim lekom. A onda se postavilo pitanje nakon dugog niza godina HERA studija gde je standard dugi niz trastuzumab godinu dana u adjuvantnom lečenju, da li možda ukoliko primenimo 2 godine adjuvantnog trastuzumaba ćemo imati bolju efikasnost, da li će naše pacijentke još duže živeti. Nažalost, rezultati ovog dela studije su pokazali da 2 godine ne donosi prednost u pogledu efikasnosti, ali kao što vidimo donosi veći nivo toksičnosti, značajno veći procenat signifikantnog pada erekcione frakcije. U tom smislu 2 godine definitivno nije standard za adjuvantnu primjenu herceptina. Takođe vidimo da bi trastuzumab dao svoje neželjene efekte, neophodno je da bude udružen sa drugim faktorima, s jedne strane sa prethodno primljenim antraciklinima, s druge strane minimum 2 faktora moraju da budu prisutni da bi zaista došlo do značajne verovatnoće kardijalnih događaja i to su uglavnom hipertenzije, body mass index veliki, godine starosti i sve to zajedno dovodi do veće verovatnoće da će sam trastuzumab dovesti do kardiotoksičnosti. Osim što sam pričala da se razmatralo da li može herceptin da se primenjuje 2 godine umesto godinu dana, danas sve i više idemo u pravcu deeskalacionih studija, da li možda možemo primeniti herceptin, odnosno trastuzumab, to je isti lek, samo je ovo zaštićeno, ima ovo genetičko, da li možemo da primenimo kraće, a da imamo isti efekat. I tu je mnogo studija sprovedeno, jedna od najznačajnijih koju bih danas pomenula je short hair studija, sam se ja nedavno vratila iz Čikaga, NASCO 2023. Čuli smo rezultate ove studije gde je 9 nedelja, samo 9 nedelja herceptina versus godinu dana herceptina je pokazalo da su kod svih pacijenata je dostignut taj stepen neinferiornosti, znači statistički je analiziran non-inferiority, da zapravo je 9 nedelja dovoljno, osim kod pacijentkinja koji imaju 4 žlezde, koji imaju stadijum 3, koji imaju izrazito visok rizik za relaps. Ali kod ovih pacijentkinja koje su HER2 pozitivne, a imaju umereni i nizak rizik za relaps, možemo i uštediti državi, jer 9 nedelja u odnosu na godinu dana herceptin je izrazito skup, a s druge strane zaista vidimo da kardijalna toksičnost je znatno veća kod duže primene trastuzumaba. Ono što mi je posebno važno da vam kažem da kod pacijenata koji imaju visok rizik za relaps, koji imaju nodus pozitivnu bolest, razmatra se i dualna blokada. Affinity studija je najviše u tom pravcu razmišljala, Alto studija je prva, Affinity je druga. Affinity je studija kombinacije pertuzumaba i herceptina, gde je jasna redukcija rizika za relaps 4%, dovoljno velika da generalno se razmišlja u pravcu da se nodus pozitivne pacijentke treba lečiti dualnom blokadom, a nemamo veći stepen kardijalne toksičnosti. I naravno procena srčane funkcije neophodna je pre antriciklina, nakon antriciklina, a tokom anti-HER2 blokade koje traje godinu dana, najčešće još uvek kao standard, mora se na svakih 3 meseca analizirati ejekciona frakcija i naravno tretirati ukoliko dođe do značajnog pada. Naravno, ACE inhibitori, blokatori, angiotenzi receptori i beta blokatori su osnovni lekovi koji se preporučuju za simptomatsku i asimptomatsku srčanu slabost. Takođe, u slučaju HER2 blokade treba da znamo da ukoliko ejekciona frakcija padne, a nakon toga, ukoliko je korigujemo adekvatnom kardioprotektivnom terapijom, možemo ponovo započeti HER2 blokadu. To nije slučaj kod antriciklina, jer kao što se sećate, antriciklini izazivaju irreverzibilnu kardiotoksičnost. Takođe je veoma važno znati da na vreme moramo prepoznati i da li pacijent ima visok rizik za kardijalnu toksičnost i apsolutno učiniti sve da promeni životni stil koji ima do tada ukoliko on nije adekvatan i naravno ukoliko je moguće određenoj grupi pacijenata koji imaju visok rizik moramo dati ipak lekove koji nisu kardiotoksičnosti. Takođe, čuli smo od profesorke Sečen da profilaktički možemo razmišljati o ACE inhibitorima. Karvedilo, lizinopril su pokazali značajnu redukciju preživljavanja bez kardiotoksičnosti, odnosno kardiotoksični free, što znači da negde prevencija ACE inhibitorima i beta blokatorima može da se razmatra kod pacijenata koji će dobiti terapiju kardiotoksičnu i koji imaju visok rizik sami po sebi zbog drugih faktora. Ovde imamo algoritam gde ja samo bih rekla 2 reči, a to je ako imate ejekcionu frakciju iznad 50 i pacijenta koji je u fit stanju, naravno idete sa kancerskim tretmanom koji njemu pripada, bez obzira što nosi određeni kardijalni rizik i redovno radite ultrazvuk srca. U slučaju ejekcione frakcije koja pada, vi ćete naravno kardioprotektivnom terapijom učiniti sve da oporavite pacijenta, za to vreme on mora da stopira svoju kardiotoksičnu onkološku terapiju i ukoliko oporavi na adekvatnu ejekcionu frakciju nastavlja, ukoliko ne oporavi, tada definitivno moramo razmatrati takozvane alternativne režime koji nisu kardiotoksični. Čuli smo za checkpoint inhibitore, o njima znamo nedovoljno jer iskreno mi u Srbiji lečimo imunim checkpoint inhibitorima ipak nedovoljno dugo da bismo sada mi osetili i iskusili kasnu kardiotoksičnost. Negde rano da i istina je da su miokarditisi izrazito retki, vidimo do 1% se javljaju, ja sam ukupno videla do sada 1 pacijenta, ali to stvarno nije ni malo lako i ni malo prijatno jer je jako teško pre svega razmišljati o tome, teško je negde i ne posumnjate toliko da zbog ovako male incidence da može doći do toga, ali verujte, jako je bitno da promptno taj pacijent sa onkologije ode na urgentni centar i da hitno krene terapija. Isto tako, kardiolozi nisu spremni za checkpoint inhibitore i mi smo morali da odemo lično kao doktori sa svojim pacijentom da objasnimo da je ovde ključna terapija kortikosteroidi. Znači, ne smemo da lečimo ovaj miokarditis kao sve druge miokarditise, moramo posebno da mu pristupimo, nije lako ni dokazati da je to baš uslovljeno checkpoint inhibitorima, ali sve vreme moramo ozbiljno da sumnjamo, ozbiljno tako da lečimo dok ne dokažemo suprotno, a inače naravno da tu idu i beta blokatori i ostali jako važni kardiološki lekovi i pristupa se miokarditisu generalno kao svakom drugom, ali ogromne doze kortikosteroidi. Ako negde nakon 3 dana, nakon ovih velikih doza dođe do responsa, mi ćemo polako redukovati kortikosteroidi, to je taper ili taper, već kako god, a ako nema responsa moramo koristiti infleksimab ili druge jake imunosupresivne lekove, možemo izgubiti lako pacijenta. Znači, koliko god volimo checkpoint inhibitore koji daju dobre response, duge response, toliko ih se i plašimo, jer verujte, negde imamo neku vrstu još uvek nedovoljnog iskustva i nedovoljne sigurnosti i pomalo straha. Naravno, neophodno je da mi, onkolozi, sa kardiolozima imamo jednu usku saradnju, da osim što ćemo uraditi EKG, kardijalne enzime, proceniti simptome naših pacijenata, mora kardiolog da sve to lepo interpretira, da nam da jednu dodatnu sigurnost da li se zaista radi, recimo, o miokarditisu kod checkpoint inhibitor uzrokovanog srčanog problema, da li da zaustavimo tretman, da li da damo kortikosteroide, da zajedno odlučujemo u ovim teškim situacijama i koje tačno, naravno, kardioprotektivne lekove da damo, a onda ta odluka kada sve rešimo, a daj Bože da rešimo, da zajedno odlučimo smemo li da nastavimo checkpoint inhibitore kada oporavimo ovaj problem sa srcem, jer to nisu lake odluke i nemamo dovoljno uporište, ne samo u našoj kliničkoj praksi, nego možda čak nemamo dovoljno ni u tim ESPO preporukama, ni u ASCO preporukama, sve je to tu, ali verujte, još uvek, ja opet poentiram, nedovoljno dugo iskustvo i nedovoljno mnogo tih, hvala Bogu, neželjenih efekata, samim tim nedovoljno dokaza šta tačno smemo da uradimo, a dokle da budemo obazrivi. S druge strane, koronarna arterijska bolest je izuzetno važna, izazivaju brojne terapeutici i fluoropiramidini, i platinum soli, VEGF inhibitori i sama radioterapija, i kako oštećenjem endotela, tako protrombinskim nekim izazivanjem, čuli smo od profesorke Šalinger da generalno protrombotično deluju mnogi lekovi, sama maligna bolest, koliko je opsežnija, toliko više deluje protrombotično i toliko više izaziva u stvari sklonost da se stvaraju pre svega venske tromboze, a i arterijske. Naravno, kada govorimo o koronarnoj bolesti, važno je naravno da se što pre prepozna, nema toliko limitirane su opcije da možemo odmah intervenisati, pacijenti koji imaju konkomitantno neurotoksične lekovi ili radioterapiju mogu da budu takozvani nemih koronarnih sindroma i ovde rechallenge lekom kardiotoksičnim, odnosno našim hemioterapeutikom definitivno se ne preporučuje. Za akutno prolongiranje čuli smo definitivno da može biti opasno, da može biti uzrokovano osim antikancerskim lekom, istovremeno se javljaju brojne elektrolitne promene, različiti predispozirajući faktori mogu da utiču, konkomitantna medikacija, sve to može dovesti do life-threatening aritmija, do ventrikulnih fibrilacija, a te aritmije mogu da budu i tokom i nakon tretmana, tako da ribociklib, recimo, koji je lek, sada su ciklibi jako moderni, jako dobri lekovi, oralni lekovi koji su dali ne samo jednaku efikasnost, nego već pokazuju superiornost u odnosu na hemioterapiju, tako da ja brojne svoje metastatske dojke, jer dominantno su luminal oblika, hormon receptor pozitivni, HER2 negativne, negde 70% je baš takvih dojki, lečimo ciklibima, gde nažalost ribociklib, iako je peroralni lek i sjajno se podnosi, moramo da vodimo računa jer dovodi do akutne prolongiranja, može da dovede u velikom procentu, ako to da uradi u prva 2 do 3 ciklusa. Zato u prva 2 do 3 ciklusa moramo na svakih 14 dana analizirati EKG i ukoliko dođe do prolongiranja, postoji šema po kojoj moramo postupati, privremeno obustavimo lek, dajemo terapiju, proverimo elektrolite, proverimo tiroidnu funkciju i nikako ribociklib ne smemo da kombinujemo sa klaritromicinom, naravno ni sa tamoksifenom i sve ono što dodatno prolongira akute interval. I naravno o trombozama smo čuli, ja o ovome prosto ne bi ni smela da pričam s obzirom da je profesorka toliko bila jasna i precizna, ali još jednom samo da kažem da je arterijskih bitno manje od tromboza venskih. Venske tromboze se dešavaju u 20%, posebno kod onih pacijenata koji su hospitalizovani, imaju duge hospitalizacije, mogu biti znači kancer related, patient related i treatment related, a suštinski sam samo htjela da nas podsjetim na jednu najvažniju stvar, da mi kardiolozi i mi onkolozi moramo apsolutno stalno da sarađujemo i nekako češće da se viđamo i malo više mi da znamo o važnim lekovima, a vi možda malo više o našim, jer negde mi se čini da je ta kolaboracija jako važna i meni prosto nedostaje u svakodnevnoj kliničkoj praksi. Hvala.
Hvala vam. Možete da, evo možemo malo, imamo još nekoliko minuta, sledeća sesija kreće za 10 minuta ili nešto manje, pa evo, ove su vama za zahvalnost onako predavanju. Vidim da svi praktično govorimo isti jezik, a saradnja je stvarno komplementarna. Nas malo plaše lekovi koji dolaze iz onkologije, a vaš naravno potencijalne komplikacije koje stvarno mogu da budu vrlo ozbiljne i kao fatalne. Tu ima puno, vidim, mesta i tu je moj drug još iz osnovne škole, profesor Zoran Todorović, mislim da ovdje ima puno mesta i za ove kliničke farmakologe, znači koji mogu da povežu te dve oblasti, kao kardiologiju, ovu i puno sad bolnica ima na svojim mestima kliničke farmakologe i to je stvarno jako važna njihova uloga. Evo, ako ima neke pitanja, ja samo da, evo ja mogu dva ono kao pitanja što sam ovako malo kao prošao, to je za profesorku Šalinger, su doze koje se koriste, da li su one manje ili su iste ili su veće, primarne prevencije i posle ova i rizik od krvarenja isto je sigurno veći kod ovih pacijenata nego kod populacije koji nemaju. I za doktorku samo ste nešto, nisam najbolje shvatio da postoji neke kontraindikacije što se tiče dvojne antitrombocitne terapije. Nisam baš shvatio najbolje engleski deo. Da. Da li nema? Znači nema nikakvih... Da, dobro.
Ovako, što se tiče primarne prevencije, prosto je potrebna zaista ispravna procena rizika od potencijalne tromboembolije. Dakle, videli smo, postoje rizik skorovi i konačno pojedinačni maligniteti nose taj rizik. Sad, tu je mnogo važna i trikije stvar, u stvari same doze lekova. Negde, iako su rađene i Kazini i Avert, nijedan od NOAK-a još uvek nema u SMPC-u svoju dozu koja bi bila adekvatna za primarnu prevenciju. Recimo, ovo je poslednji rad koji je objavljen za kolorektalne karcinome tretirane laparoskopski, gde su ljudi nakon toga dobijali rivaroksaban, ali u dozi od 10 mg. Prosto u dozi koja je adekvatna onoj preventivnoj dozi u ortopedskoj hirurgiji. Međutim, oni su ih pratili tokom 3 meseca. I smatra se da je to bilo bezbedno zato što su to bili laparoskopski izlečeni luminalni karcinomi. Međutim, takođe svi imamo saznanje da negde malignitet per se jeste sistemska bolest. I zato se, i što se tiče plućnih embolija, smatra perzistentnim velikim faktorom rizika. Tako da prosto mislim da je tu veoma još uvek triki i da ako su jako rizični pacijenti, ako zahtevaju prolongiranu hospitalizaciju, a to još uvek spada u primarnu prevenciju jer u konačnom nisu imali trombotični događaj, negde bismo možda pribegli niskomolekularnom heparinu ili obazrivo manjim dozama NOAK-a. Međutim, i apiksaban u dozi od 2 puta 2,5 mg u randomizovanim studijama ili real world data, negde on bio udružen sa manjim procentom krvarenja, ali kako god. Ako se radi o luminalnom malignitetu, krvaranje je svakako tu. U konačnom, bilo je mnogo diskusija sa gastroenterolozima vezano za krvarenje na dvojnoj antitrombocitnoj terapiji koja je bila na kraju nama must have, pa na kraju su svi stentovi dobili C-mark za skraćenu dvojnu antitrombocitnu terapiju upravo zbog rizika od krvarenja. Ja bih samo dodala, ako je to okej, što se tiče terapije onkološke. Nama je mnogo teško da pratimo vašu terapiju. Imate jako puno studija, jako puno novih molekula, jako puno pacijenata kojima je to poslednja šansa i ljudi i tekako budu dobro. Ja sam imala i lečila pacijentkinje još dok je bila studija sa herceptinom, gde smo negde iskustveno davali ACE inhibitore, AT blokatore, beta blokatore tim pacijentkinjama i verujte, onkolozi su pre bili za odluku da obustave i ne nastavljaju terapiju inhibitorima HER2 receptora, iako je posle dokazano da daju reverzibilno smanjenje, nego da produže nakon oporavka. S druge pak strane, kada pogledate, profesorka Lopez je odlično pokazala, bez obzira što kardiolozi nisu baš mnogo friendly sa strain rate-om, nije ni on jednostavan, zahteva poseban softver, međutim GLS bi trebalo da bude jednostavan zato što nije prosto onako tako kompleksan kao short i tako dalje. Međutim, šta je poenta? Poenta recimo da iz vašeg ugla, recimo GLS desne komore još ranije predviđa potencijalno pogoršanje funkcije ne samo desne nego i leve komore, je li tako? I s druge strane, ranije to najavljuje. Mislim, ja bih sada, znači otišli smo sad baš onako u sitne detalje, za početak. Ja bih ovako, kada bi šira javnost prosto postala svesna ovog velikog problema, zato što sve više ima maligniteta i to ne samo kod nas, i u čitavom svetu, ili tako, mnogo puno genetski modifikovane hrane, mnogo puno lekova, jako puno stresova i tako dalje, u konačnom živimo u vreme ratova, jel da? To je prva stvar. Druga stvar, potrebna je mnogo veća briga, a trebalo bi da imamo i dalje na umu da su ti ljudi, se smatraju čak i izlečenim, ali zahtevaju lečenje, kao i remisija prosto sistemskih bolesti vezivnog tkiva, jel da? Znači, trebalo bi prosto to proširiti i praviti na jednom širem nivou Ministarstva zdravlja i da nas poveže onkologe, kardiologe, radiologe, hematologe, kliničke farmakologe, jako važni. Prosto mi ih sada koristimo većma za antibiotike, ali su mnogo važni za interakcije i da nama pomognu. Ja sam uzela ovaj mikrofon i izvinjavam se, ali mislim da je jako važno. Profesorka, izvolite ako biste dodali nešto.
Ja bih samo još dodala da se malo razmišlja i o paraneoplastičnom sindromu, gde imamo kod mladih bolesnika tromboflebitis. I zašto kod jednog mladog čoveka od 20-25 godina da se javi tromboflebitis? I ne treba se izlečenjem tromboflebitisa staviti tačka, nego treba gledati koji organ je ugrožen, ili biomarkerima, ili osnovnim dijagnostičkim procedurama, snimak pluća, skener, snimak pluća više ne znači ništa nego skener CT grudnog koša, abdomena ili ultrazvuk abdomena, male karlice. Vidim tu mlade kolege do sada, pa bih to poentirala, jer dosta se kasno takvi pacijenti jave, leče se tromboflebitis, prođe 5-6 meseci i onda se uradi snimak pluća ili neki drugi dijagnostički moment i otkrije se već uznapredovala maligna bolest. To bih ja poentirala. I ako se slažete, ova sesija je bila vrlo interesantna, bar nama predavačima, i mi bismo vrlo rado da se ovo nastavi. U vidu nekih drugih konferencija, kongresa, ali mislim da ima mnogo prostora za ovo. Hvala.
Hvala vam najlepše i još jednom hvala najlepše.
Drago mi je što smo se ponovno sreli. Hvala puno. Imaš pozdrav od Zagreba, pođe ova dobro.
Ne vidim dobro.
Ajde, vidjet ću, imam mnogo ispita u tom periodu.
Jelena, molim te, evo ti Daninac od klime, pusti ovu klimu. Tu ti to izvrljam. Da li radi? Radile su obe. Jel hoće? Ne, to je malo, prijemno radiš. Poštovane koleginice i kolege, dobar dan i hvala vam što ste u ovakvom broju i sa velikim interesovanjem došli na sesiju kojom se faktički zatvara ovaj veliki skup gde je tokom ova 2 dana bilo preko više od 600 učesnika uživo, a juče preko 1500 pregleda na YouTube kanalu gde je emitovano. Ovo je jedinstven skup gde se čija je intencija da se okupe kolege iz Srbije koje su školovane u Srbiji i ostale tu da rade i kolege koje su svoje znanje kad su stekle otišli u inostranstvo, ali nisu zaboravili svoju otadžbinu i vole uvek da se vrate i zato je nekako simboličan datum ovog našeg okupljanja uvek u junu, kada su između ostalog i proslave mature i tako dalje, ali ono što je suština je da je ovo jedan naučni i profesionalni koncept koji donosi up to date, znači najvrednije i najmodernije zaključivanja iz svih oblasti, a ova sesija je upravo posvećena intenzivnoj medicini i za mene je velika čast da budem deo ove sesije koju sam predložila na sastanku Kraljevskog medicinskog odbora i ona je ušla u, da kažem, uži izbor. Posebno se zahvaljujem profesoru Todoroviću koji je ovde s nama i koji me je podržao da ova sesija bude u užem izboru. Znači, veliki broj sesija nije imao prilike da bude prikazan na ovom kongresu, a ja sam o intenzivnoj medicini počela mnogo da brinem kada sam postala direktor i onda sam shvatila koliko je za funkcionisanje jedne bolnice, da bi sve službe mogle da funkcionišu, bitna ta intenzivna nega, bilo da se radi o hiruškoj ili internističkoj ili kardiološkoj. Rezultat toga je da smo mi mnogo radili na povećanju broja lekara, sestara, na edukaciji lekara i sestara i zbog toga mi je drago da ste ovde danas, na nabavljanju opreme, a u tome su nam mnogo pomagali kolege iz drugih centara, upravo oni koji su i danas sa nama, profesor Lađević, profesor Dejan Marković i profesor Radmilo Janković. Profesor Dejan Marković je docent, ali je za mene profesor i ja koristim slobodu da prekršim sada pravilo i da kažem hvala vam još jednom u ime Bežanijske kose, svih nas koji smo prošli to. Hvala vam što ste vi to vodili, što smo imali koga da pozovemo, što smo imali da zamolimo za savet, pomoć, podršku na bilo koji način. Vi ste bili veliki i za nas ste postali veliki prijatelji, ne samo veliki doktori. Ja sad dajem reč profesoru Lađeviću da otvori ovaj skup.
Hvala puno, profesorka. Ja se zaista zahvaljujem u svoje ime i mojih kolega anesteziologa, kako ste rekli, profesora Markovića i profesora Jankovića. Zaista nam je bilo zadovoljstvo da možemo da pomognemo, tako su bile i vremena i trebalo je pomoći. A eto, iz toga su se izrodila i divna prijateljstva i dalja saradnja, tako da smo i naučili nešto novo i ono što nismo znali, a evo došli smo do toga da sada vrlo često držimo zajedničke sesije, ko predsedavamo, predajemo zajedno i samo nastavljamo dalje. Tako da, evo, ja ne bih mnogo dužio, mislim da možemo i da pređemo na samu sesiju. Mislim da je moje prvo predavanje, tako, evo, izvolim.
Zadovoljstvo nam je da slušamo i ovu sesiju počnemo s tvojim predavanjem.
Hvala.
Izvolim.
Sad ćemo da vidimo kako ovo na daljinu izgleda, pošto su naočare za blizinu. Ali dobro, ja ću se samo podsjećati. Pa sad ovako, kada govorimo o modalitetima lečenja postoperativnog bola i uopšte kako je da utvrdimo koja je jačina postoperativnog bola, dolazimo zaista do jedne velike prepreke u jedinici intenzivnog lečenja, s obzirom da dosta pacijenata imamo i na mehaničkoj ventilaciji, da dosta pacijenata je sedirano i da nisu baš u stanju da lako razgovaraju sa nama i da uzmemo jednu dobru anamnezu kako bismo to uradili, da su oni van jedinice intenzivnog lečenja. Pa evo, ja ću vam čisto ovako predstaviti one osnovne stvari, a dati posle jednu mogućnost kako će to možda biti u budućnosti. Inače, kao što znate, izvori bola u jedinici intenzivnog lečenja su različiti, pa evo ja sam ovde pobrojao neke od njih, svakako da ima još i više, to su iskorišćena naravno hiruška intervencija, to su ranija obolenja, prisustvo drenova, centralnih venskih katetera, arterijske linije, neka dugotrajno stajanje, kanile ili čak vrlo i brzo nekada kanila izazove i spazam same vene, pa to boli, dođe do crvenila, zatim sve manipulacije koje se dešavaju oko pacijenta. Vi imate u jedinici intenzivnog lečenja manipulacije svaki dan, morate da previjete pacijenta, okrenete, promenite posteljinu, da uradite negu samoga bolesnika, ali isto tako tu se nalaze i određene procedure koje su bolne i takozvani proceduralni bol postoji. Nekada morate da uradite lavažu respiratornog trakta, morate da uradite bronhoskopiju, bronhoaspiraciju, sve to zna da bude bolno. Posledice postojanja bola u jedinici intenzivnog lečenja svakako su različite, ali najviše utiče na poremećaj sna, na agitaciju, rekli smo već da dovodi do bola, zatim za stres odgovor. Stres odgovor razvija jedan pojačani katabolizam kod pacijenta, usporava njegov oporavak, produžava boravak u jedinici intenzivnog lečenja. Sve to ima neke druge implikacije, pre svega na produženi ostanak u jedinici intenzivnog lečenja i naravno i veće troškove samog lečenja kod pacijenta. Ono što je izuzetno značajno da sam bol najviše utiče na pokretljivost bolesnika, da kasnije ustane iz kreveta, ali isto tako ukoliko su intervencije u torakalnom delu, abdominalnom delu, da i pliće diše, da ne može duboko da udahne, stvaranje atelektaza i pneumonija. Sad ono što je bitno da nemogućnost da pacijent komunicira sa vama verbalno ne znači da ga ne boli, je li tako? I da on ne osjeća bol i da mu nije potrebna takozvana antidolorozna terapija. Mi moramo na neki način da procenimo koliko pacijenta boli. Pa sad skale za bol koje mi poznajemo mogu biti subjektivne i objektivne, s tim da ove objektivne nisu u pravom smislu objektivne, da on 100% kaže koliko ga boli, nego mi preko ovih objektivnih skala u suštini procenjujemo skorovanjem. Subjektivne su numeric rating scale, visual analog scale i imamo verbal rating score. Na osnovu tih mi jednostavno bodujemo koliko od 0 do 10 boli pacijenta, a što se tiče objektivnih, vidjet ćete, to su Behavioral Pain Scale, Adult Non-Verbal Scale i imamo Critical Care Pain Observation Tool. Ovo verovatno ste videli do sada u svome radu, gdje mi ponudimo pacijentu da on se izjasni od 0 do 10 koliko ga boli, ili postoji mogućnost da jednoj skali od 10 cm stavi crticu i da nam pokaže, pa mi izmerimo koliko je to centimetara. Obično kažemo da su to skale koje on može u dobroj komunikaciji da nam objasni, i da 0 je nema bola, 10 je onaj najjači bol koji nikad doživljeni, toliko jaki bol, 1, 2 i 3, to je bol koji je umereni, 4, 5 i 6 to je bol koji je, odnosno blagi, 4, 5 i 6 je umereni, 7, 8, 9 i 10 to je jaki bol. Nekada možemo i na osnovu ekspresije lica da vidimo koliko pacijenta boli, mi to ne koristimo toliko često zbog toga što najčešće se to koristi kod dece, ali nije toliko sigurno zbog toga što deca znaju da plaču iz nekih drugih razloga, ne samo zato što ih boli, ali negde se koristi i ove skale. Vidjet ćete sada ove skale koje zovemo objektivnim, one nisu toliko objektivne, međutim skorovanjem dolazimo do objektivizacije bola i vidjet ćete prva je Behavioral Pain Scale, sad ću vam pokazati Adult Non-Verbal Scale, ali ona koja sublimira ove dve, ona se zove Critical Care Pain Observation Tool. Ono što mi vidimo u svemu tome i što bodujemo jeste ekspresija lica samoga pacijenta, zatim njegovi pokreti, da li se on u suštini sudara sa mehaničkim ventilatorom ili ga dobro toleriše, zatim kakva je mišićna tenzija, zatim imamo mogućnost vokalizacije kod pacijenta koji nije intubiran, da li postoji vokalizacija i mi sve to skorujemo i vidimo da li pacijenta boli ili ne boli, znači posredno odredimo preko ove skale. Ona je trenutno najkompleksnija i najviše se upotrebljava i najviše se i preporučuje u jedinici intenzivnog lečenja kod pacijenta koji ne može sopstvenim rečima da vam opiše jačinu bola. Što se tiče izbora analgetika, naravno da ga izabiramo pre svega prema jačini leka, da vidimo da li će to biti nesteroidni antiinflamatorni lekovi, da li će to biti opioidi, njihova kombinacija, ali zavisi naravno i od farmakokinetike samoga leka, zatim specifičnih faktora kao što je da li je pacijent u stanju neke vrste šoka, da li je to sada septični, kardiogeni, kakav je hemodinamika samoga pacijenta. Zatim gledamo funkciju bubrega, jetre, da li postoji telesna temperatura, da li postoji gojaznost kod tog pacijenta. Mnogo faktora možemo da gledamo i da vidimo koji bismo analgetik najčešće i najlakše izabrali. Opioidi su generalno lekovi koji se najčešće koriste u jedinici intenzivnog lečenja za bolove. Pretpostavljam uvek da su to jaki bolovi, za ove slabije gotovo i da to nisu toliko značajni bolovi zbog toga što primenimo onda nesteroidne antiinflamatorne lekove, ali od opioida, kao što vidite ovde, tu su fentanil, hidromorfon, metadon, morfin i remifentanil. Kod nas najviše koristimo morfin. Morfin nekako imamo najviše iskustva sa njim, a sa druge strane ovi ostali lekovi kao što su remifentanil, fentanil mogu da se koriste i u single dozama, mogu se koristiti u infuzionim pumpama, međutim šta je značajno da mora da bude izuzetno dobar nadzor nad pacijentom. Vrlo lako se izazove bradikardija, respiratorna depresija, što znači da ipak je nekako možda najbolje koristiti i u našim uslovima morfin. Sve zavisi od broja osoblja i intenziteta nege kod pacijenata. Ovo su isti ti lekovi, samo da vidite kakav je put njihovog metabolizma. Pored opioida mi koristimo i neopioide. To bi bili, već sam spomenuo, nesteroidni antiinflamatorni lekovi, tu se nalazi metamizol ili, kao što mi znamo, novalgetol, zatim nalazi se paracetamol, nalaze se različiti drugi koanalgetici, međutim te koanalgetike ne dajemo u neposrednom postoperativnom toku, već sa njima pokušavamo da sprečimo nastanak, odnosno da smanjimo intenzitet postoperativnog bola, da manju količinu takozvanih rescue lekova uzimaju kao što su opioidi i oni su izuzetno značajni za prevenciju nastanka hroničnog postoperativnog bola. To su pre svega gabapentinoidi, magnezijum, lidokain, gde možemo i njih primeniti. Pored toga što mi ordiniramo lekove i mi ih i dajemo pacijentu, postoji mogućnost da napravimo takozvanu PCA primenu lekova, gde oni patient control analgezija, gde uz pomoć pumpi mi napunimo jedan rezervoar sa lekom, sa koncentracijom koju mi želimo, zadamo na samome aparatu, samoj pumpi, koliko on može sam sebi da da na jedan stisak dugmeta, koliko je ta bolus doza, zadamo lockout intervale, u kom periodu on može da pritiska jednostavno to dugmence, ali se neće bolus isporučiti i na taj način mi predvidimo koliko će on maksimalno mogući da dobije leka, na primjer u sat vremena, i na taj način mi jednostavno dozvolimo pacijentu da on i sam sebi ponekad doda taj lek. Sad, to isto je interesantno, imamo recimo jednog mlađeg pacijenta koji je, gde mi možemo, samo da se vratim korak unazad, gde mi možemo da vidimo koliko su oni sami dodali, ali isto tako možemo da vidimo koliko je zahteva bilo koji su neostvareni, znači u tim lockout intervalima. I sad imali smo mlađeg pacijenta koga smo pratili i videli smo da taj mlađi pacijent je vrlo često sebi dodavao opioid. Kada smo ujutru ga pitali, pa zar vas je toliko bolelo i kako je to bilo, ma kaže, ne, meni uopšte nije bolelo. Pa zašto ste sami davali? Ma ja kako sebi dodam tih par miligrama morfina, kaže, ja zaspim, uopšte ne gledam oko sebe, prespavam 4 sata, dodam ponovo. Sad vidite kako to radovi, mnogi radovi su rađeni upravo tako da vi imate jedan protokol i da u tom protokolu imate određenu vrstu terapije, pa se 2 protokola porede koliko je neko primao ovih rescue lekova. Znači, postoji mogućnost da je neko primio i zbog nečeg drugog, a ne zato što ga je samo bolelo. Tako da, imaju opet i 2 pristupa za PCA. Jedni kažu, vi ste dozvolili pacijentu da sam sebi daje, na taj način ste uštedili i osoblje koje ga leči, obilazi, ima velike uštede u radu, a s druge strane napravili smo ipak neku vrstu dehumanizacije, nikoga i ne obiđe, samo namesti lockout intervali i onda ga sutradan tek vidi ovako nekako ima i žive reči. Imamo znači pro et kontra za tako nešto. Svakako znate da postoji mogućnosti primjene epiduralne analgezije, da ona može biti u bolusima, da može biti kontinuirana jedna infuzija, ali isto tako postoji pacijent kontrolisana epiduralna analgezija, gde uz pomoć istih ovih pumpica, samo potreban je malo nešto veći pritisak, pumpe posebne za tako nešto da savladaju tanki epiduralni kateter, mogu dodavati sebi određene količine leka u epiduralni prostor. Lekovi koji se koriste kod epiduralne analgezije su različiti, spadaju u različite grupe, pa vidimo najčešće su to lokalni anestetici i opioidi, to je nešto najčešće što se koristi. Postoji mogućnost da se doda čak i NMDA antagonista kao što je ketamin, alfa-adrenergički agonista klonidin, čak se može dodati i neostigmin, a mnogi ovi lokalni anestetici mogu sadržati i epinefrin, ali u razblaženju 1:400.000 umesto 1:200.000. Znači, ove doze se mogu koristiti. Najčešća kombinacija je kombinacija između lokalnog anestetika i opioida. Mi konkretno na našoj klinici koristimo najčešće kombinaciju levobupivakaina i fentanila, ali vidimo da fentanil je 2 do 4 mikrograma po mililitru se koristi najčešće. I evo, ukoliko bismo uzeli, na primjer, jedan špric od 50 mililitara, to je špric koji ide na špric pumpu, dodamo 12 mililitara 0,5% levobupivakaina, 2 mililitra fentanila i 36 mililitra fiziološkog rastvora, dobit ćemo rastvor koji je 0,125% rastvor levobupivakaina, U njemu će biti 2 mikrograma po mililitru fentanila i ovih 36 mililitara će biti fiziološkog rastvora. Takav jedan rastvor stavimo 4 do 6 mililitara na sat otprilike da ide u epiduralni prostor. Znači, to doziranje smeše može biti različito, može biti taj jedan background koji ide stalno 4 do 6 mililitara, ali mogu biti i bolus doze gde pacijent obično može da odavati sebi 2 do 4 miligrama sa lockout intervalima od 10 do 30 minuta i na taj način poboljšavati sopstvenu epiduralnu analgeziju. Ono što takođe možemo primeniti, to su različite pumpe. O infuzionim pumpama manje više znamo i ovi špricevi se stavljaju infuzione pumpe, odnosno špric pumpe, može biti infuziona pumpa, u nekom rastvor se može napraviti, ali isto tako postoji i elastomerne pumpe. Elastomerne pumpe, kada se napune, one su to tako napravljene da kada se pusti rastvor da ističe iz tih elastomernih pumpi, one se zbog svog elasticiteta smanjuju određenom brzinom i tako da imamo elastomerne pumpe koje su za 5 ml na sat, 10 ml na sat i takve različite pumpe možemo koristiti. Čak možemo i otpustiti pacijenta kući, a da koristi ovakvu jednu elastomernu pumpu i u njoj da bude rastvor. Ono što je u poslednje vreme interesantno i što sam ja isprobao i pričao na par nekih sastanaka jeste kako mi možemo zaista da objektiviziramo analgosedaciju kod samoga pacijenta i da ne prevedemo nekako u neku brojku. To je izuzetno teško, mislim da još uvek to niko nije uspeo, posebno kod budnog pacijenta. Ali imamo jednu mogućnost, to smo videli, evo isprobali u poslednje vreme na jednom aparatu, gde pacijenti koji su u anesteziji ili u sedaciji mogu da budu priključeni na ovaj aparat i preko elektroda koje se nalaze na frontalnom delu, znači na čelu glave, preko EEG-a da dobijemo određene signale i te signale tumači aparat i prevodi u jednu brojku bez mernih vrednosti, znači nešto isto kao što je BIS monitoring. Jedna vrednost je Q-con, ona nam govori o dubini anestezije, odnosno dubini sedacije, a druga vrednost je Q-nox, odnosno nociceptivni indeks, koji nam govori o analgeziji kod pacijenta. Kao što imamo na BIS-u, znate svi kada je na BIS monitoringu, range je negde raspon između 40 i 60, tu je za anesteziju, 40 do 60 je i za analgeziju, idealna neka vrednost samoga Q-nox indeksa i tada se smatra da smo dobro pokrili pacijenta sa analgeticima. Sad, na ovome samome aparatu postoji različiti neki parametri, kada je to u anesteziji, onda mi možemo govoriti naravno o Q-konu gde ga držimo između 40 i 60 da bi pacijent bio u anesteziji, gledamo kakva je mišićna relaksacija, kakav je signal, gledamo je burst suppression ratio gde on mora da bude na nuli, znači tada je sve dobro u anesteziji, ali ono što je interesantno da u analgeziji kod pacijenta koji je jedinici intenzivnog lečenja, on mora biti sediran da bismo uopšte Q-nox dobili. Taj Q-nox dobijamo najčešće kod pacijenata znači, koji su na mehaničkoj ventilaciji i koji su sedirani i tada možemo pratiti analgeziju. Iskreno da vam kažem, mi smo u fazi da ispitamo ovaj aparat i da vidimo kako će on reagovati. Bila je interesantna jedna sesija i ovde sada u Glasgowu na SAIC-u, gde sam ja baš postavio par pitanja kako recimo taj aparat deluje ukoliko bismo mi imali sediranog pacijenta, usput uradili, na primjer, neku regionalnu blokadu, na primjer, ne znam, blokadu pleksusa brachialisa, asedirali pacijenta, da li bi i u tom trenutku Q-nox trebao da padne u odnosu na te vrednosti od 100 da padne naniže, jer oni su ga standardizovali prema primjeni remifentanila, zatim inhalacionih anestetika. Dobio sam odgovore od samoga čoveka koji je izmislio takvu jednu formulu tumačenja EEG talasa, da sve ono što u suštini smanji intenzitet bola će se pokazati, bilo da je to paracetamol, epiduralna anestezija, blokada, ali da je uslov da sam taj Q-con, odnosno ne bude 100, da pacijent ne bude budan. I možda je to nešto što možemo primeniti kod kritičnih pacijenata, da ne bude da oni ne mogu to da nam kažu, a da ih bole. Možda je to jedan od aparata koji ćemo koristiti u budućnosti, ali evo ostavljamo to da vidimo i ispitaćemo u svakom slučaju u našim klinikama. Hvala vam na pažnji.
Želim da se zahvalim profesoru Lađeviću na jednom izvanrednom predavanju koji je samo nastavak jedne kontinuirane edukacije koju on vrlo temeljno čini na polju intenzivne medicine. Svima nama pomaže da što više i bolje naučimo kako da lečimo pacijente. Ja bih pitala da li neko iz publike ima neko pitanje za profesora Lađevića ili želite da ostavimo na kraju za diskusiju. Ukoliko nema, ja bih najavila docenta Dejana Markovića, koji će nam govoriti o nečemu što je izuzetno bitno za veliki broj intenzivnih jedinica, ne samo za anestezijologije, nego za sve nas, jer upravo ova tema koja je kod nas uvek za psihijatra, delirium, teško nađete vi psihijatra raspoloživog u trenutku kada pacijent se sprema da uđe u delirium ili već jeste. I zbog toga hvala na ovom divnom predlogu teme. Izvoli, Dejane.
Hvala, profesorka Marija. Poštovane koleginice i kolege, čast mi je zadovoljstvo da budem u ovom zdanju i čast mi je zadovoljstvo da govorim pred vama. Hvala organizatorima što su me udostojili da održim predavanje danas. Delirium je problem koji viđamo svakodnevno u jedinicama intenzivnog lečenja i najčešće mi koji radimo u jedinicama intenzivnog lečenja, u hiruškim jedinicama uglavnom rade ili apsolutno rade anestezijolozi. To viđamo svaki dan i s tim moramo da se borimo. Pozovemo, ok, i psihijatra u konsultaciji, ali, ko što reče i profesorka Zdravković, vrlo često psihijatar nije dostupan, naročito u noćnim satima, vikendom i tako dalje, a pacijenti nisu samo delirantni preko dana u radno vreme, nisu samo delirantni radnim danima, nego i vikendom. Po definiciji, delirium je sindrom. Ima nekoliko stvari koje treba da budu ispunjene da bi se nešto okarakterisalo kao delirium. Prvo, iznenadni početak, akutna promena u stanju svesti bolesnika. Druga stvar je promena u nivou svesnosti. Treća stvar, promena u nivou pažnje i četvrta stvar, na nivou mišljenja, dezorganizovano mišljenje. Da bismo nešto krstili kao delirium, dakle, moraju da budu ispunjena prva dva uslova, dakle, da je akutni početak, da imamo promenu nivoa stanja svesti, znači, ova dva moraju obavezno da budu ispunjena i jedan od druga dva, poremećaj pažnje ili poremećaj mišljenja. Ukoliko smo to ustanovili da se desilo kod našeg bolesnika, moramo nešto da uradimo. Obično kod delirantnih bolesnika viđa se fluktuacija. Bolesnici imaju periode kad budu relativno ili potpuno bez ikakvih simptoma, a opet periode kad budu izuzetno delirantni, a sam delirium može da bude hiperaktivni i on se lakše uočava, bode oči, što bi se reklo, vidi se iz aviona kad je pacijent hiperaktivan i delirantan. Međutim, podjednako često, ako ne i češće, se javlja hipoaktivni delirium i ta stanja mogu da budu zanemarena. Pacijent koji nam ne pravi problem, vizuelno ne skače, nije agresivan, nije agitiran, obično bude ostavljen, ok, on ide svojim putem, a mi se bavimo nekim drugim pacijentima, međutim i ovi bolesnici zahtevaju tretman, zahtevaju lečenje, zahtevaju našu pomoć i pomoć psihijatra, a najčešće, vrlo često delirium može da bude mešovit, da ide iz faze hiperaktivnog u fazu hipoaktivnog deliriuma. Ovo je jedna studija iz koje sam izvukao ovu jednu rečenicu u kojoj se kaže da u jedinicama intenzivnog lečenja, što se tiče delirijuma, uglavnom se bavimo tretmanom, mnogo se ređe bavimo samom prevencijom delirijuma, što bi trebao da bude naš prvi korak. Incidenca je različita, u zavisnosti od toga o kakvoj jedinici intenzivnog lečenja se radi, ali da se razumemo, delirijum se javlja i van jedinice intenzivnog lečenja i najčešće kad je bolesnik hospitalizovan, može i na običnom odeljenju jedinice poluintenzivnog ili najčešće intenzivnog lečenja. I zavisnosti od toga da li se radi o hiruškom pacijentu, da li se radi o internističkom bolesniku, razlikuje se incidenca, ali neka prosječna je oko 20%. Kod kardiohiruških bolesnika, neurohiruških bolesnika, traumatizovanih, kod bolesnika u neurološkim jedinicama intenzivnog lečenja incidenca je nešto veća. Kod bolesnika koji je delirantan, sledstveno se produžava ostanak u jedinicu intenzivnog lečenja, produžava se lečenje i naravno cena lečenja samog bolesnika. Neće svaki bolesnik koji uđe u bolnicu da postane delirantan. Da li će neko postati ili neće, zavisi od nekoliko stvari. Postoje predisponirajući faktori, ono s čime bolesnik dolazi u bolnicu, kakva je njegova ličnost i tako dalje, koliko ima godina. Pol, muški pol je skloni nastanku delirijuma u odnosu na ženski, godine starosti, što stari bolesnik, češće delirantan nego neko ko je mlađi, ali ono što je, i to ne možemo skoro nikako da promenimo, ali ono što možemo da menjamo, to su precipitirajući faktori. Ono što će pacijenta da sačeka kad dođe u bolnicu i šta mi možemo da uradimo kako bismo incidencu delirijuma smanjili na najmanju moguću meru. Ovo postoje i među precipitirajućim faktorima neke stvari koje ne mogu da se modifikuju, ali ovde vidimo i stvari koje mogu da budu modifikovane, kao što je izbor sedativa, izbor opijata, korišćenje antiholinergika, neatropin, pošto prolazi hematoencefalnu barijeru, koliko god je moguće zaobići kortikosteroide, zatim samo okruženje u kome je smešten bolesnik, buka, ritam spavanja, trebalo bi da se obezbedi bolesnicima, a samim povezano s tim i nivo osvetljenja u prostoriji gde borave bolesnici. Bolesnici koji imaju veliku dioptriju, ukoliko smo im uklonili sočiva, naočare, oni su pod povećanim rizikom da postanu delirantni. Isto tako bolesnici koji imaju problema sa slušnim aparatom, ukoliko smo skinuli pomoćne stvari, slušni aparat, ukoliko nismo vratili postoperativno, ti bolesnici zbog nemogućnosti ili otežane komunikacije postaju češće delirantni i o tome mora da se vodi računa. Bolesnici koji su duže vremena imobilisani, kod kojih se ne sprovodi rana fizikalna rehabilitacija, ne budu pokrenuti i rehabilitovani u toku dana, takođe su pod povećanim rizikom za nastanak delirijuma. Profesor Lađević govorio o značaju bola kod hiruškog bolesnika, apsolutno jedan od najčešćih razloga postoperativnog delirijuma može da bude i jeste neadekvatno tretiran bol. Produžena mehanička ventilacija, što više dana na mehaničkoj ventilaciji, veća verovatnoća nastanka delirijuma, metabolički poremećaj. Dakle, ovo su modifikujući faktori na koje mi možemo da utičemo kako bismo smanjili incidencu delirijuma. Kako ćemo da procenimo, otprilike sad znamo stari bolesnik muški pol, ali da li ima još nešto što može da nam ukaže na to, da li će baš taj bolesnik koji nam je došao legu u bolnicu, da će eventualno da ima veći rizik za nastanak delirijuma. 2012. godina Van den Bogarde i saradnici su napravili jedan model, skalu, predelirik model, na osnovu nekoliko parametara bolesnici mogu da budu gradirani što se tiče rizika u bolesnike niskog, srednjeg, visokog ili veoma visokog rizika za nastanak delirijuma. Izuzetno je teško izračunati, pošto je eksponencijalna jednačina i tako dalje, ali ukoliko unesemo parametre koji su nam potrebni, a to su ovih 10 godine starosti bolesnika, Apache score, da li je prisutna koma ili ne, o kakvom bolesniku se radi, hiruški trauma ili drugi bolesnik, da li je prisutna infekcija, metabolička acidoza, da li se koristi morfin kao analgetik, da li se koriste sedativi u smislu benzodiazepina, koliki je nivo ure i da li je u pitanju hitan prijem. Kad se unesu svi ovi parametri u kalkulator, izaći će nam finalna vrednost, ukoliko je 0 do 20%, nizak je rizik, ukoliko je vrednost predelirik modela preko 60%, taj bolesnik, kad je ušao u bolnicu, ima veoma visok rizik da nastane delirijum i kod svih bolesnika bi trebalo činiti sve što je u našoj moći da se prevenira nastanak delirijuma, ali kod ovih kod kojih smo procenili da su pod veoma visokim rizikom, to i tekako ima smisla. Postoje raznorazni kako se to kaže, snopovi mera, šta sve treba uraditi da bi se prevenirao delirijum. Ovde sam naveo samo jedan od, pošto se lako pamti, A, B, C, D, E, F, snop mera koje treba sprovoditi. Prvo je proceniti adekvatno, kupirati bol, drugo je svakodnevno insistirati na spontaneous awakening trial, to znači ukoliko je bolesnik sediran, svaki dan moramo da stopiramo sedaciju, smanjimo sedaciju kako bi obezbedili delove dana kad je bolesnik komunikativan i kad može da komunicira sa nama. Isto to važi za bolesnike na mehaničkoj ventilaciji, kad svakodnevno treba omogućiti test spontanog disanja za vreme mehaničke ventilacije. Iza toga izbor sedativa i analgetika. Pod broj 1, u jedinicama intenzivnog lečenja nema mesta za benzodiazepine, izuzev 2 slučaja, a to je alkoholni delirijum, kad se koriste benzodiazepini, i druga stvar, bolesnici koji su preoperativno, odnosno pre prijema u bolnicu na visokim dozama benzodiazepina, te bi obustavljanje daljeg primene benzodiazepina dovelo do nastanka neželjenog efekta. Dakle, samo u ta 2 slučaja benzodiazepini su indikovani, a za izbor sedacije ne ostaje nam nešto mnogo, može inhalaciona sedacija ukoliko bolesnik intubiran, dexmetomidin ili propofol, to su otprilike ta 3 leka. Pod D je delirijum sam po sebi, treba ga prepoznati, prevenirati i tretirati na adekvatan način. E je rana mobilizacija i vežbanje, i F, ono što nismo mogli da obezbedimo praktično u prethodne 2,5-3 godine, to je uključivanje članova porodice u lečenje bolesnika zbog COVID infekcije. Kod nekih bolesnika u mnogim svetskim velikim bolnicama gde ima mogućnosti, prisustvo porodice je obezbeđeno 24 sata dnevno, samo da ne remete rad osoblja i tretman drugih bolesnika, ali pričamo o Americi, o Zapadu, gde su velike intenzivne nege, gde svaki bolesnik ili 2 bolesnika leže u odvojenom boksu od drugih, i upravo ukoliko ima takvih mogućnosti, dozvoljava se porodici da bude i u toku dana i u toku noći s bolesnikom, naročito s bolesnikom koji postaje delirantan. Ovo su sve bili snopovi mera. Još jednom da pobrojimo šta to možemo nefarmakološki da uradimo da bi prevenirali delirijum. Potrebno je s pacijentima razgovarati, naročito sa starijim bolesnicima, reorijentisati ih u toku dana, više puta dnevno, da mu se kaže koji je danas dan, da je operacija bila juče, prekjuče, jutros, da je sad, 5 sati, 6 popodne, da je veče, jutro, jer budu dezorijentisani, i ukoliko ih reorijentišemo, incidenca delirijuma bi trebala da bude manja. Promocija kognitivnih aktivnosti, kad god je moguće, bolesniku treba omogućiti da čita, ako ne mora novine, da čita knjigu, da gleda televiziju. Opet pričamo o modernim jedinicama intenzivnog lečenja, gde je internet i TV dostupan svim bolesnicima i bolesnici mogu jedan deo 24-časovne aktivnosti da fokusiraju na nešto drugo, a ne na mišljenje sami sa sobom i o svojoj bolesti, i na taj način da vežbaju kognitivne funkcije. Omogućiti adekvatan unos tečnosti, nutritivnu potporu, apsolutno mandatorno. Već smo pomenuli nivo osvetljenja i buke tamo gde leži bolesnik, naročito u noćnim satima. Ako se radi o jedinici intenzivnog lečenja, zna da bude reanimacija, prijemi, ali opet da ne bude previše ni glasan razgovor, niti lupanje, niti upaljena sva svetla, kako bi bolesnicima bio omogućen san. Rana mobilizacija, već sam rekao, izuzetno značajna. Što pre ukloniti katetere i drenove. Kad god je moguće, urinarni kateter i centralni venski kateter, drenovi, što pre ukloniti, jer je to sve povezano s povećanom incidencom delirijuma. Vraćanje naočara, vraćanje slušnih aparata, čim se pacijent probudi, kako bi bila olakšana komunikacija. Čak korišćenje ogledala u jedinicama intenzivnog lečenja, svakodnevno da bolesnik može da pogleda svoje lice, takođe može da smanji incidencu nastanka delirijuma. Ovo je jedan rad koji govori o tome koliko su značajne nefarmakološke mere van jedinice intenzivnog lečenja, gde incidenca delirijuma, ukoliko se koriste nefarmakološke mere van intenzivne nege, da smanjuju incidencu delirijuma za 43%. Dakle, delirijum nije samo isključivo vezan za intenzivnu, ima ga i van intenzivnih, i tamo treba raditi na prevenciji delirijuma. Šta kaže vodič za sedaciju, analgeziju i delirijum kod bolesnika 2018. godina. Za prevenciju delirijuma kaže da se ne sugeriše upotreba ni haloperidola, ni drugih atipičnih antipsihotika, niti deksmedetomidina, niti statina, niti ketamina u prevenciji delirijuma kod kritično obolelih odraslih osoba. Ovo je sistematski prikaz koji kaže 10.800 bolesnika iz 19 studija, koji kaže da trenutni dokazi ne preporučuju upotrebu antipsihotika u prevenciji delirijuma i da je potrebno standardizovati metodologiju i procenu mogućnosti upotrebe ovih lekova u prevenciji. Jedan od lekova koji se eventualno pokazao da može da smanji incidencu delirijuma, to je deksmedetomidin, mada ga osporavaju stručnjaci, naročito sa zapada, zato što kažu, iako su ovo meta-analize, 25 randomizovanih studija, skoro 5000 bolesnika iz 2018. godine, gde su u zaključku kaže da je pronađeno da deksmedetomidin smanjuje incidencu i trajanje delirijuma, čak šta više, deksmedetomidin može da bude korišćen u tretmanu delirijuma. Ljudi protivnici primjeni deksmedetomidina kažu da su ove studije uglavnom bazirane na studijama iz Kine, gde se postavlja veliki znak pitanja kako su i koliko adekvatni ti rezultati tih studija bili, te same meta-analize mogu da daju rezultate koje možda mogu da nas odvedu u pogrešnom smeru. Međutim, kad pogledamo zaista ovako, a iz svakodnevnog našeg rada, čini se da ipak deksmedetomidin može da bude značajan prijatelj u borbi protiv delirijuma. Još jedan lek koji obećava, to je melatonin ili njegov analog. Pokazalo se da smanjuje incidencu delirijuma kod hiruških bolesnika, bez obzira koja je hirurgija u pitanju, na osnovu 14 randomizovanih studija. Intraoperativna upotreba ketamina, pokazalo se da u ovom trenutku nema značajnog uticaja na delirijum, ali može da smanji incidencu postoperativnih kognitivnih deficita. Ovo je još jedna studija iz 2021. godine koja kaže da, opet sistematski pregled randomizovanih studija, da deksmedetomidin možda može da se koristi u prevenciji delirijuma i ono što je apsolutno sigurno, to je da smanjenje izlaganju benzodiazepinima takođe smanjuje incidencu delirijuma. U zaključku šta možemo da kažemo? Delirijum je prisutan svakodnevno. Kad primimo bolesnika u jedinicu intenzivnog lečenja ili uopšte u bolnicu, ne bi bilo loše da uradimo procenu, da uradimo ovaj predelirik kalkulator i ukoliko vidimo da je visok ili veoma visok rizik za nastanak delirijuma, da uradimo nešto i više nego što obično radimo s bolesnicima kako bismo prevenirali nastanak delirijuma. Druga stvar, potrebno je svakodnevna procena bolesnika, najmanje 2 puta dnevno, jednom u jutarnjim časovima, drugi put u večernjim časovima. Zato se najčešće koristi ICU CAM skala, mogu i druge skale da se koriste, ne bi trebalo da oduzima mnogo vremena osoblju koje je zaposleno u jedinici intenzivnog lečenja, treba bukvalno minut ili 2 za svakog bolesnika kako bi se procenili u toku dana. Imamo nefarmakološke mere o kojima trebamo da razmišljamo. Što se tiče farmakološke strategije, mi volimo kad nam pacijent dođe da mu pre svega damo neki lek da mu bude bolji ili da mu damo lek da preveniramo nastanak komplikacija. Nemamo neki veliki izbor, eventualno deksmedetomidin i melatonin, a svakako izbjegavanje benzodiazepina sem u ona 2 slučaja. Imamo ABCDEF snopove mera u prevenciji i svakodnevno moramo ne samo za bolesnike za koje smo procenili da su pod visokim rizikom za nastanak delirijuma, već i za sve druge bolesnike da optimalizujemo njihov boravak u bolnici u jedinici intenzivnog lečenja kako bi incidenca delirijuma bila manja. Hvala vam na pažnji.
Zahvaljujem se docentu Markoviću, izuzetno predavanje. Mislim da se lepo nastavilo i na prethodno predavanje, jer je bol zaista jedan od glavnih faktora delirijuma. Docent Marković je zaista organizuje ove godine jedan jako lep skup o delirijumu izuzetna posjećenost tog skupa, čak nas dvojicu, zajedno smo to radili, ali ideja je bila njegova. Neverovatno koliko se ljudi odazvalo na takav skup, nije bilo mesta u sali, svi su ostali do kasne. Znači, ova tema je izuzetno interesantna svima. Da li možda ima neko pitanje iz publike? Evo, izvolite.
Samo pitanje, da li postoji neki preparat melatonina za parenteralnu primjenu?
Ne da ja znam. Ne znam zaista, ali evo imamo čoveka koji zna.
Profesore.
Profesore. Aha.
Kako da ne izvolite?
Koje doze melatonina? Vidim da je spomenuto.
Ja jesam pročitao rad, ali stvarno nisam se udubljivao. Znam da je melatonin dosta korišćen u nekim bolnicama za vreme COVID-a. Neki su ga hvalili na sva zvona, drugi osporavali, ali nevezano za davanje u vreme COVID-a. Ovo su rezultati studija bez COVID bolesnika koji kažu da ima pomoći u smanjenju incidencije primjena melatonina, ali zaista ne znam koje su doze.
Neki kolege se šale pa kažu dajemo ga, sigurno neće delovati,
Da, neće da škodi.
Pa delirium zaista je multifaktorijalni, ima jako mnogo kofaktora koji utiče na sve to. I onda tamo mislite da je to bol ili je melatonin ili nešto drugo, ono ispadne da je samo jako mnogo iskrvario, na primjer, za vreme i operacije, da je hematokrit izuzetno nizak. Ja mogu da vam, eto, možda ispričam samo jedan događaj da je sve najbolje prošlo u najboljem redu, operativno, to je bio naš kolega jedan, evo, Radmilo iz Niša, pa ću kažem, kolega je bio iz Niša, jedan stariji profesor u penziji, gde smo mi obećali da čim se završi operativni zahvat, da mogu da dođu supruga, sutradan i dvoje dece, i svi su oni lekari, naši kolege, ja sam bio dežuran i da ćemo pustiti da vide tog našeg kolegu u jedinici intenzivnog lečenja. I oni su zaista ljudi došli, i kada su došli ispred jedinice intenzivnog lečenja, prolazila je naša jedna sestra i pitala šta vi čekate, pa mi smo hteli da zvonimo, da pitamo, znate, ima neka, zabranjen ulazak u jedinicu intenzivnog lečenja. I ona sad dolazi i kaže, evo ovi neki čekaju sada tu, ja kažem, ja, pa to je od naše kolege sada, mi smo sve to, dajte pozovite, i ona kreće za njima, i viče, ja, pa oni su otišli, su bili ljubazni, kulturni ljudi, nisu bili nametljivi da uđu, oni su se okrenuli i otišli, i ovaj čovjek je počeo da ih doziva i u tom trenutku je nastupio delirium. Znači, apsolutno ništa od ovoga što smo spomenuli, osim, eto, tog trenutka kad je on samo počeo da zove njih i nastupio je delirium. Mi nismo mogli ga vratimo 2 nedelje posle toga, tako da zaista ima jako mnogo uzroka i zato je delirium interesantan.
Samo da komentiram, dok smo čekali da uđemo na sesiju, dok su bili studentski radovi. Kolega iz Niša je imao sa biohemije 2-3 godina baš ispitivanje melatonina kod sepsa. I mi smo baš pitali na koji način su davali, kaže, intraabdominalno injekcije. Što ne znam da li je dovoljno prečišćen za upotrebu u ljudsku ili je samo u eksperimentalne svrhe, ali očigledno da ima neki preparat.
Ja iskreno nemam nikakvog iskustva s melatoninom, ne znam da li koristio.
Pitaćemo ga. Dosta, da. Dobro, zahvaljujem se prezidentu Markoviću. Idemo na sledeće predavanje. Profesor Radmilo Janković, on će nam govoriti o novim antibioticima za multi-drug resistance bakterije, tako da vidimo šta je to novo. Izvoli, Radmilo.
Hvala najbolje na ljubaznoj najavi i Marija, hvala na pozivu koji mi lično i profesionalno puno znači, a vama kolegi hvala što ste došli, mi smo bili prilično skeptični da ćemo biti malte ne sami u sali i nadam se da ova predavanja ispunjavaju neke vaše kriterijume i da su vam interesantna. Ovo neće biti klasična tema o novim antibioticima, samo ćemo na kraju par slajdova proći kroz minimalnu neku osnovnu farmakologiju nekih novih antibiotika. Moja ideja je bila da se više priča o osnovi čitavog problema, kako smo došli u situaciju da imamo visoko rezistentne sojeve bakterija, koji najveći problem u stvari i prave u jedinicama intenzivne nege i kako smo na kraju sada tragamo za novim antibioticima, a ono što nam je bilo dostupno smo svojom nekom traljavošću ili bahatošću praktično zloupotrebili pre svega jednom neracionalnom primjenom, pa vidjet ćete i kako je došlo do toga i šta sve treba uzimati u obzir kada se tretiraju multirezistentne bakterije. Ja dolazim iz Niša, dolazim iz bolnice koja je sigurno bila heroj bolnice tokom COVID-a, kao na kraju krajeva i Bežanijska Kosa. Dakle, Marija, mi smo dugo bili bolnica koja je primila ubedljivo najveći broj pacijenata, sigurno prve 2 godine COVID-a i više od 7000 prijema u jedinicu intenzivne nege, nažalost veliki broj smrtnih slučajeva, jer smo bili centralna intenzivna nega za čitav središnji, južni, istočni pa i jugozapadni deo Srbije i tu je takođe tema, ovo što je tema današnjeg predavanja imalo svog uticaja. Vidjet ćete na kraju da mi čak taj neki mikrobiološki nadzor, epidemiološki nadzor nismo zapostavljali u to neko teško vreme kada smo imali zaista jako teške pacijente u jedinicama intenzivne nege. Ja inače vodim kliniku za anesteziju i intenzivnu terapiju, što znači da anestezijolozi ekskluzivno, odnosno samostalno vode jedinicu intenzivne nege, naravno uz saradnju sa lekarima drugih specijalnosti, naročito sa kliničkim farmakolozima, odnosno jednim kliničkim farmakologom koji je praktično pridodat našem timu i nikada ne donosimo odluke bez ozbiljnog uzimanja u obzir našeg mikrobiološkog okruženja, epidemiološkog okruženja. Vidjet ćete da to pratimo stalno i da se ne stidimo toga da šaljemo ubedljivo najveći broj uzoraka na mikrobiološku dijagnostiku i bez obzira što nas to izdvaja kao kliniku koja ima ubedljivo najveći broj pozitivnih nalaza, ali nama je to svakako korisno. Mi smo do pre COVID-a imali gotovo 3000 prijema u jedinicu intenzivne nege, mi smo mešovita jedinica intenzivne nege, ogroman broj kreveta, 86 kreveta u jedinici intenzivne nege, od kojih i uglavnom su to posthiruški pacijenti, ali vrlo i često i pacijenti koji stradaju u saobraćajnom traumatizmu, politraumatizovani pacijenti, često pacijenti od kojih, nažalost, svi ostali dignu ruke i veliki broj pacijenata sa teškim infekcijama i sa sepsom. 2022. godinu smo završili sa gotovo 6000 prijema zaista najtežih pacijenata. Poslednjih godina, naročito posle COVID-a, se nastavio trend da se svi najteži pacijenti, pa i oni internistički, uglavnom šalju u jedinicu intenzivne nege i da internisti uglavnom dižu ruke od teških pacijenata, recimo. To se naročito odnosi, nažalost, na naše kolege neurologe, nefrologe, nešto manje na kardiologe, ali zaista to jeste trend. Bakterijska rezistencija jeste ozbiljni problem u jedinicama intenzivne nege, nije nastao skoro, postojala je naravno tendencija već i poslednjih decenija, ali je u svojoj magnitudi ovaj problem se iskazao poslednjih godina ili poslednje decenije. Imate jedno skretanje praktično sa desna u levo, odnosno da ranije kada se pričalo o multirezistentnim bakterijama, uglavnom se mislilo na gram pozitivne bakterije, već 2000. godina postoji snažan trend da gram negativne enterobakterije praktično preuzimaju dominaciju stanovnika u jedinicama intenzivne nege. I nije sramota reći da oni jesu praktično prisutni u našem radnom prostoru, njih je gotovo nemoguće iskoreniti, naravno određenim merama i navikama se njihov broj može smanjiti ili smanjiti njihov rast, ali svakako se antibioticima taj problem ne može rešiti. Šta kažu epidemiološka istraživanja? Ovo otprilike možete vidjeti u svim nekim prezentacijama. 2007. godine je već Evropski centar za kontrolu bolesti rekao da je primjena, odnosno prisustvo multirezistentnih bakterija, naročito sada već klebsijele pneumonije i tada već karbapenem rezistentnog pseudomonasa ozbiljan zdravstveni problem, ali možete vidjeti da nije samo zdravstveni problem. Naravno, gotovo 2000 novih slučajeva takvih infekcija izazvanih ovih bakterijama godišnje, ogroman višak smrtnosti, višak morbiditeta, direktni ekonomski posledice koje se ogledaju u većem, naravno, broju bolničkih troškova i naravno veliki broj dana odsustva s posla, što zbog mortaliteta, što zbog same bolesti. Šta u stvari, kako se definišu pojmovi multirezistentnosti? I multirezistentnost nije jedini pojam koji se uzima u obzir kada govorimo o teškim infekcijama izazvanim tim opasnim bakterijama koje su rezistentne na različite antibiotike. Prvi put je pojam multirezistentna bakterija je definisan praktično time da je jedna bakterija istovremeno rezistentna na 3 grupe najčešće prepisivanih antibiotika, a to su cefalosporini, čak i njihovi kombinaciji sa njihovim inhibitorima, fluorohinoloni i aminoglikozidi. Kada imate multirezistentnu bakteriju, onda imate naravno još uvek terapijske opcije. Po samoj definiciji MDR bakterije nisu rezistentne na karbapeneme ili ne bi trebalo da budu. Tako da je 2000. godina kada su se karbapenemi pojavili, naročito u hirurgiji u jedinicama intenzivne nege bili jako popularni antibiotici i bili su zaista jako efikasni. Ali vidjet ćete šta govore podaci epidemiološki, čak i Srbije, kako smo jedne jako dobre antibiotike uspeli na neki način da oslabimo njihovu efikasnost. Ali svakako karbapenemi i jedan drugi antibiotik, a to je polimiksine, koji je poznat gotovo 50 godina, je postao sada najčešće prepisivan antibiotik u jedinicama intenzivne nege, naročito sa predominacijom sojeva acinetobaktera, naročito acinetobaktera baumani. Ekstenzivno rezistentna bakterija je gora od multirezistentne bakterije jer je još rezistentnija. Sem toga što je rezistentna na ove 3 grupe najčešće prepisivanih antibiotika, ona je rezistentna i na karbapeneme. Evoluciono, znate i sami, neću se puno zadržavati oko toga, kako je selekcioni pritisak na bakterije veći, što ih tučete jačim sredstvima, one postaju pametnije, odnosno nemaju drugog izbora nego da stvore neki način kako će zaobići to moćno oružje. I naravno, rekombinacijom genetskog materijala stvaraju se forme za sintezu pojedinih supstanci koje su najčešće enzimi koji uništavaju praktično antibiotike. I tako su bakterije najčešće, uglavnom gram-negativne enterobakterije, smislile da produkuju određene enzime koji se zovu karbapenenaze i potpuno su karbapeneme učinile neefikasnim. Mi sada govorimo o ekstenzivno rezistentnim bakterijama, a one su još uvek osetljive, recimo, na kolistin, odnosno na polimiksine i na još neke antibiotike, recimo poput tigacila. Noćna mora u jedinicama intenzivne nege, pa i na infektološkim odelenjima, jeste panrezistentna bakterija. Panrezistentna bakterija je super bakterija budućnosti koja će biti rezistentna na sve antibiotike i na karbapeneme i, gle čuda, i na kolistin. To bi praktično trebao da predstavlja jedan multirezistentan acinetobakter baumani i zbog toga se rezistentnost na acinetobaktera na polimiksin u svetu prati, jer bi ti slučajevi zaista bili prilično upozoravajući. Postoje faktori kojima možete kontrolisati ono što sam rekao, da taj broj multirezistentnih bakterija nekako ne poraste. Pre svega koristići taj antimikrobni stewardship, odnosno načine na kojima vi ordinirate, da imate jednu politiku kuće koju se svi lekari pridržavaju i kojem zaista se koristite primjerima dobre kliničke prakse u racionalnoj primjeni antibiotika. Ona u sebi podrazumeva da imate potpunu kontrolu nad epidemiološkim nadzorom, da u svakom trenutku znate šta potencijalno raste u vašim respiratorima, šta raste na vašim površinama, na vašim kompjuterima. Nije stvar stideti se toga, već to znati. Kada eskalirate antibiotsku terapiju kod sumnje na ozbiljne infekcije, onda ne dajete uvek longacev, zato što je to, jel da tako, naučeno, iako znate da imate bakterije u vašoj jedinici intenzivne nege koje su apsolutno rezistentne na taj antibiotik, nego upravo eskalirate i pravite kombinaciju antibiotika u odnosu na ono što predviđate da će biti. Da li će to biti pseudomonas ili će biti acinetobakter i tako dalje. Nama se dešava da nekad budemo prilično sigurni da neki VAP bude prouzrokovan acinetobakterijom i nemamo problem da eskaliramo terapiju čak i polimiksinom. Tu su naravno neke druge, pre svega mere iz domena higijene koje se mogu preduzimati. Što se tiče faktora koji promovišu rezistenciju, to su naravno nepotrebno dugo davanje antibiotika, nepotrebno prethodno dugo davanja antibiotika za neku drugu infekciju kod istog pacijenta, neke hiruške procedure, plasiranje invazivnih linija, centralnog venskog, dijaliznog katetera, arterijske linije i tako dalje, mehanička ventilacija, imunokompromitovane pacijenti, ali to već sigurno znate. Ovo skretanje sa desno u levo je prvi put dokazano kada je Epikova studija koja je imala gotovo 13.000 pacijenata iz čitavog sveta, dosta jedinica intenzivne nege je učestvovalo, neke iz Kliničkog centra Srbije i jedinice intenzivne nege koju sam u to vreme i ja vodio, i ona otprilike govorila o prevalenciji najčešćih prouzrokovača infekcija u jedinicama intenzivne nege i tada je definitivno dokazano da su gram negativne enterobakterije najčešći prouzrokovači tih infekcija i kada podelite te gram negativne infekcije možete vidjeti da je pseudomonas tada 2007. godine bio najčešći prouzrokovač, pa zatim Escherichia coli, a tek onda Klebsiella, ali vidjet ćete kako se ti podaci menjaju. Zašto je problem toliko izražen i da li je on svuda podjednako izražen? Na ovim kartama i sličnim kartama, da kažem, epidemiološki možete vidjeti otprilike ovakvu jednu situaciju gde u levo ka istoku, pre svega istočnoevropskim, centralnoazijskim zemljama, u zemljama Azije imate crvenilo ili ružičasto, otprilike da je procenat rezistentnosti određenih sojeva jako visok, da je značajno manji na zapadu, naročito evo možete vidjeti u skandinavskim zemljama koje se odlikuju prilično strogom i restriktivnom, pre svega politikom davanja antibiotika i ovo je situacija gde multirezistentni sojevi Klebsielle, pneumonije, pre svega koji su lučili karbapemenaze su bili prisutni širom Evrope još pre 7 do 8 godina. Otprilike ovako brzo ću proći kroz ove slajdove da vidite kakva je zaista situacija u svetu što se tiče rezistencije na antibiotike. Acinetobacter baumani je trenutno najrezistentnija bakterija, ali ono što je problem je trenutno najveći, odnosno najčešći prevalent u jedinici intenzivne nege. Najviše je prisutan i vidjet ćete podatke iz moje jedinice intenzivne nege gde smo mi to naravno dokumentovali. Ono što je problem da gotovo nema antibiotika koji deluju na acinetobakter. Ako pogledate fluorohinolone, ovi podaci naravno za Afriku nisu verodostojni jer nemate izveštaje, ali što se tiče Severne Amerike i Evrope možete vidjeti da fluorohinoloni ne utiču. Malo pre sam pričao da to je recimo acinetobakter, multirezistentan acinetobakter koji je rezistentan na polimiksin E, može biti problematičan jer je to najgora, da kažem, opasnost za budućnost. Neki sojevi su se pojavljivali u Sjedinjenim Američkim Državama i Indiji, ali trenutno je dobra situacija što se tiče polimiksina E. Acinetobacter baumani je rezistentan uglavnom na karbapeneme i u istočnoj, i u južnoj, i u zapadnoj Evropi. Sledeća multirezistentna bakterija koja takođe pravi problem u jedinicama intenzivne nege je Klebsiella pneumonije, koje, kada su se karbapenemi pojavili u kliničkoj praksi, naročito u jedinicama intenzivne nege, pokazivala dobar profil osetljivosti. Sada već to nije takva situacija, jer je uglavnom Klebsiella stvorila načine produkujući beta-metaloproteaze i karbapemenaze koje čine njih neosetljivim. Fluorohinoloni takođe velika upotreba, veliki selekcioni pritisak dovode da su neefikasni protiv Klebsielle, piperacin, tazobaktam takođe ne. Što se tiče pseudomonaca, on je recimo treća ta bakterija, on nije toliko invazivan, nije toliko odgovoran za veliki broj smrtnih slučajeva, ali jeste svakako neko ko stoji u jedinicama intenzivne nege, velika rezistencija na piperacin, tazobaktam, fluorohinolone svakako i ono što ćete videti to su i karbapenemi. Priča o antibioticima u Srbiji je priča uglavnom o našim lošim navikama i nekim socijalnim i životnim, nažalost, koji se nekako prožimaju i kroz zdravstvo. Antibiotici su najomiljeniji lekovi srpskih i lekara i pacijenata. Vidjet ćete zašto lekara, vidjet ćete na grafikonima, ali i pacijenata. Sećate se sigurno, ja se makar sećam da me baka svojevremeno vraćala kad god sam otišao zbog upale grla ili upale uva i kada lekar koji je bio na prijemu nije hteo da mi da antibiotike i onda onako ja sam sećam što najzad neću dobiti penicilin ponovo. Ona je rekla ne, taj doktor nije dobar, sutra ponovo, dok se injekcije ne daju, znači taj lekar nije dobar. I generalno se smatra da lekari nisu dobri ukoliko ne propisuju antibiotike. Podaci o tome koliko se zaista troše antibiotici u Srbiji i podaci o rezistenciji su dugo nedostajali, jer sada već otprilike postoji nešto što se zove Cezar mreža koja prati kontrolu potrošnje, konzumcije antibiotika i njihove rezistencije širom Evrope. Dugo Srbija nije bila, ovo je prvi izveštaj iz 2013. godine kada se Srbija pojavila u ovim stubićima. Svi smo očekivali da će to biti devastirajući neki podaci koji će Srbiju staviti na, da kažem, vodeće mesto po potrošnji rezistenciji. Nije bilo toliko strašno, ali smo svakako bili u vrhu. Ono što možete vidjeti da za čitav ovaj, da kažem, mentalni neki socijalni prostor, to su ovi crveni stubići koji u stvari pokazuju kakva je situacija kada podelite potrošnju između različitih antibiotika, naravno beta-laktamski antibiotici su svuda najpopularniji, ali pogledajte ovaj crveni stubić koji je jako širok, da kažem, što se tiče Srbije, to je potrošnja makrolida, koja je, nažalost, ogromna, pre svega zbog propisivanja trenutno najpopularnijeg srpskog antibiotika, to je hemomicin od strane pedijatara i lekara opšte prakse, koje baš nema direktan uticaj na jedinične intenzivne nege, ali to jeste to. Šta Srbija šalje u Cezar mrežu iz 2020. Ja sam prošle godine video podatke iz 2021. Otprilike ćete videti, ako se samo gleda, rezistencija Klebsielle pneumonije, vidjet ćete da vrlo malo, ovo je procenat rezistencije, jako slabo efikasni, uglavnom većina nekih starih antibiotika, sem jednog starog, aminoglikozida, to je amikacin, imipenem pokazuje određenu efikasnost. Kada pogledate acinetobakter, to je ono o čemu sam vam pričao, da su svi antibiotici apsolutno neefikasni, sem polimiksina je protiv acinetobaktera, i kada pogledate sledeću stvar, to je pseudomonas aeruginosa, koji je zaista jako rezistentna bakterija, i vidjet ćete da većina antibiotika koje mi primenjujemo ima aktivnost koja je manja od 50%. Kako smo došli do toga? Malo pre ste videli, samo sam hteo da se osvrnem na jednu studiju koju su naši klinički farmakolozi, koji su početkom 2000. godina stavili pod kontrolu potrošnju antibiotika u našoj bolnici, u kliničkom centru Niš, i to su publikovali u jednom radu, tako da antibiotike širokog spektra više nisu mogli da propisuju lekari kako su hteli, pre svega hirurzi, i da bez kliničkog farmakologa u toj jednoj komisiji lekara nije bilo moguće prepisati antibiotike, i to je dovelo do značajnog smanjenja potrošnje antibiotika u kliničkom centru Niš, ali možete vidjeti šta radi selekcioni pritisak. Potrošnja, recimo, ciprocinala ili ciprofloksacina je bila zaista ogromna i rasla je od 2003. do 2007. godine. Postoji snažna korelacija antibiotske potrošnje sa antibiotskom rezistencijom, i ona je potpuno jasna. Možete vidjeti prve godine, neke 2007. godine, Klebsiella koja već pokazuje rezistenciju, znači bez rezistencije 2003. godine, i već određeni procenat Klebsielle pneumonije pokazuje rezistenciju na karbapeneme već 2007. godine. Sada je situacija dramatična. Ali pogledajte ove brojke. Potrošnja amikacina je u te 4 godine gotovo prepolovljena u kliničkom centru Niš, i ona je vratila efikasnost jednog nekada davno zaboravljenog antibiotika kao što je amikacin. Intrahospitalna epidemija Klebsielle pneumonije, nažalost u odelenju gde sam ja radio, čiji sam bio šef, sigurno nije naravno bila zasluga lekara koji su radili to, ali je u potpunosti blokirala operativni program par dana, i Klebsiella pneumonija je bila odgovorna za to. Gledajte kakvi su nama dolazili antibiogrami pacijenata iz te njih 8 koji su bili uključeni u tu infekciju, gotovo potpuna rezistencija na sve antibiotike, Bogu hvala nije bila na amikacin, smrtnost kod te, da kažem, intrabolničke epidemije nije bila toliko draga. Šta danas raste u kliničkom centru Niš? U najvećem procentu acinetobakteri, pretpostavljam da su sve jedinice intenzivne nege. Rezistencija na acinetobakter kod nas što se tiče karbapenema je ogromna, 100%. Klebsiella pneumonija, pogledajte ove stubiće, šta se kao? 81, znači od 948 pozitivnih izolata Klebsielle pneumonije u kliničkom centru Niš, 81% njih, znači 8 od 10 uzoraka su bili Klebsielle pneumonije koje su multirezistentne, znači neefikasne i protiv cefalosporina, i na cefalosporine treće generacije, i na fluoroquinolone, i na aminoglikozine. I još 10% njih je bilo rezistentno na karbapeneme. To otprilike izgleda tako, ovo je po različitim klinikama osetljivost na karbapeneme. Kada pogledate pseudomonas aeruginosa koji koji je još rezistentniji, 53% su bili multirezistentni, ali čak 12% je bilo ekstenzivno rezistentno. Ovo su načini na koji, odnosno genetski screening bakterija koji se radi kod nas u institutu na mikrobiologiju i možete vidjeti koji su praktično geni odgovorni za razvitak tih rezistencije. Antimikrobna osetljivost onih bakterija koje praktično produkuju karbapemenaze je zaista visoka što se tiče svih antibiotika. Eventualno na njih i dalje mogu delovati kolistin i amikacin. Kući u kojoj ja radim, u kojem ja rukovodim, mi radimo zaista ozbiljan mikrobiološki nadzor, ne dajemo nikada sem eskalacije, vrlo brzo tražimo i preliminarne rezultate mikrobiologije i gledamo da deeskaliramo antibiotsku terapiju uvek prema onome što dobijemo i pratimo šta raste kod nas u jedinici intenzivne nege i šta, nažalost, pacijenti najčešće imaju kao infekcije. Ubedljivo najveći broj uzoraka, još tada, 2018. kad smo krenuli, je bio acinetobakter. Acinetobakter kod nas, kada nije multirezistentan, je, da kažem, ne postoji takva bakterija, još uvek kod nas jedino je osetljiv na kolistin. Kada pogledate pseudomonas aeruginoza, najveći broj je multirezistentan. Kada on nije multirezistentan, što je ređe, to je samo 1 od 5 slučajeva, imate da možete različitim antibioticima delovati, ali kada je pseudomonas multirezistentan, uglavnom samo kolistin, izuzev ovih novih antibiotika. Ovo su enterobakterije generalno i njihova rezistencija, najveći broj njih je multirezistentan, proći će malo brže. Što se tiče klepsijele, kada nije multirezistentna, pogledajte, plavo dominira ovim ekranom, znači antibiotici su efikasni, ali one su u ređem broju slučajeva, znači tek 1 od 5 pozitivnih uzoraka nije rezistentan. Ovo je klepsijela koja raste kod nas i na nju uglavnom sem tigacila relativno dobra projekcija što se tiče karbapenema. Stafilokok nije toliki problem, ali nemamo toliku rezistenciju što se tiče na tigaciklin, na linezolid, pa i na vankomicin. Što se tiče enterokoka, kada imamo multirezistentan enterokok, na svu sreću kod nas još uvek nemamo rezistenciju enterokoka na linezolid. Slična je bila situacija i 2019. godine. Šta mi sem prisustva mikrobakterija još radimo? Radimo da gledamo potrošnju antibiotika i nismo naravno zadovoljni. Ovo je otprilike dominacija naših bakterija, ono što raste. 2018-19. trend acinetobaktera je jako visok, malo manje pseudomonasa, klepsijela takođe, da kažem, jedan trend povećanja, ali takođe i merimo šta dajemo od antibiotika i ono čime nisam ja bio zadovoljan i čime mi nikad nismo zadovoljni jeste da često nastavljamo antibiotsku terapiju, pogotovo kada nam pacijenti dolaze iz drugih centara i da je, nažalost, evo vidjet ćete, još uvek otprilike se ovde vidi. Znači, ceftriakson još uvek najčešće prepisivani antibiotik. Kod nas postoji tendencija, da kažem, malo većeg propisivanja sad amikacina i kolistina, uglavnom zbog acinetobaktera koji je prisutan. Što se tiče COVID-a, i tad smo se trudili da pratimo šta raste kod nas u jedinicama intenzivne nege, računajući da su bakterijski superinfekcije jedan od faktora koji je odnosio naše pacijente. Najčešće je to bio acinetobakter, vidjet ćete i na svu sreću i ovde, da kažem, osetljiv na kolistin. Imali smo malo manje pseudomonasa, malo manje klepsijele, ali sećate se, nas dvoje, profesor Lađević i ja, smo bili u komisiji državnoj koja je donosila protokole za lečenje COVID-19, između ostalog bilo je tu i kliničkih farmakologa. Sećate se šta je bilo na početku COVID-a, jeste da su se antibiotici davali u ogromnom broju, čak su neke studije, malo pre smo pomenuli kineske studije, ukazivale da čak i neki antibiotici poput hemomicina mogu delovati povoljno na ishod infekcije, što naravno nije tačno. Kada smo do kraja se da kažem, sumiranje davanja antibiotika nije desilo u Srbiji, bez obzira što su preporuke već od neke 7. ili 8. verzije bile, Bez obzira što su preporuke bile da se daje samo kad imate znake za infekciju, a ono što se moglo vidjeti jeste potrošnja antibiotika, recimo kod nas, i vidjet ćete ogromnu potrošnju pre svega respiratornih inolona i kolistina koji je još uvek bio kod nas. Šta je na kraju krajeva rezultat toga? Bio je rezultat uvek davanja antibiotika jeste Clostridium difficile infekcije koje zaista predstavljaju ozbiljan problem i što se tiče ekonomskih nekih dela i što se tiče smrtnosti, i naravno i kod nas je u COVID-u upravo u toj crvenoj jedinici intenzivne nege bila najveća incidenca, nažalost, Clostridium difficile infekcija. Kako bakterije stvaraju, nemam dovoljno vremena, a pretpostavljam da to znate, postoje različiti mehanizmi kojima one evoluciono usled selekcionog pritiska stvaraju rezistenciju, različite bakterije produkuju, imaju različite enzime, širok spektar beta-laktamaza, karbopemenaza, beta-proteaze, oksa 48, i možete vidjeti neke nove lekove o kojima vrlo kratko, znači ceftalozam, tazobaktam, znači novi lekovi praktično nisu novi molekuli, sem cefdirekola, svi ostali su kombinacije poznatih antibiotika, najčešće cefalosporina treće i četvrte generacije ili nekih specifičnih antipseudomonasnih cefalosporina i inhibitora različitih enzimskih varijanti koje praktično dovode do rezistencije. Kada pogledate Acinetobacter baumani, vidjet ćete da on posjeduje sve mehanizme koji izazivaju rezistenciju. Uglavnom, čak i ovi novi preparati ne mogu delovati na bakterije koje produkuju karbapemenaze širokog spektra ili beta-laktamaze. Ovo su par novih antibiotika koji su zaista specifični i nekakav zaključak ovog predavanja bi bilo da ih zaista treba koristiti i čuvati za slučajeve kada ste sigurni da su prouzrokovači osetljivi. Ovo je ceftalozam, tazobaktam, znači kombinacija inhibitora beta-laktamaza i antipseudomonasnog antibiotika. Možete vidjeti spektar dejstva, uglavnom su komplikovane intraabdominalne, komplikovane, znači teške infekcije urinarnog trakta i bakterije prouzrokovane mehaničkom ventilacijom indikacije. Druga je ceftazidim avibaktam, slična varijanta inhibitora i poznatog cefalosporina, gde uglavnom deluje pozitivno na klepsijelu pneumonije, ali takođe ne na sve varijante koje produkuju karbapemenazi. Onda imate imipenem, cilastatin i relabaktam, znači kombinaciju karbapenema i inhibitora beta-laktamaza koji imaju prošireni, da kažem, antibakterijski spektar i uglavnom su u sličnim indikacijama rezervisane samo kada znate prouzrokovača i kada se radi o komplikovanim, teškim, urinarnim, bakterijskim pneumonijima i intraabdominalnim infekcijama, i kombinacija meropenema i veborbaktama. To su antibiotici koji su nam već dostupni i koji će biti dostupni, ali svakako ih treba sačuvati za neke specijalne slučajeve. Hvala vam na pažnji, to je otprilike sve, nadam se da sam spremio to.
Zahvaljujem se profesoru Jankoviću. Da li imamo pitanje iz publike za njega? Toliko bakterija, toliko rezistencija, bar jedno pitanje. Sve je jasno. Profesor je sve rezistencije bakterije. Pa šta?
Hvala profesor, to mi puno znači.
Mi ćemo jedno predavanje preskočiti s obzirom da profesor Kovačević iz Banja Luke nije došao. Meni je zadovoljstvo da najavim profesorku Zdravković i da se zahvalim još jednom i u svoje ime i ostalih kolega na pozivu da učestvujemo u ovoj sesiji, s obzirom da je njena zasluga, što smo mi danas ovde, i kao izuzetnog stručnjaka i dobrog prijatelja da najavim profesorku i njeno predavanje Kardiogeni šok. Izvolite, profesor.
Hvala puno na ovim divnim rečima i moram da kažem da mi je drago da sam baš na ovoj sesiji sa vama, a ja ću danas kratko govoriti, nadam se kratko, pošto je poslednja sesija pa možemo da diskutujemo. Posebno mi je drago da su moje kolege sa kojima radim meni došle da daju podršku i svima nama. Mislim da je Zaista ova sesija je izašla iz našeg grada i ako postoji bilo šta pozitivno u tom teškom vremenu korone, to je to jačanje naših profesionalnih veza, posebno među ljudima koji se bave intenzivnom medicinom, jer intenzivna medicina je multidisciplinarna, ali naravno uvek najveću težinu posla tu iznesu anesteziolozi i ono što ne smemo zaboraviti, edukovane medicinske sestre i tehničari iz intenzivnih nega. I zbog toga hvala vam što ste danas ovde. Šok ili šokno stanje je put prema onom definitivnom završetku života i smatra se jednim zastojem u aktu umiranja koji je krenuo. Da li će taj zastoj biti dovoljno dugačak da se pacijent vrati ponovo u život ili će ići u onom pravcu u kome nažalost krenuo, zavisi isključivo od tima koji leči tog pacijenta. Pre svega zavisi od prepoznavanja stanja i adekvatnog reagovanja. Kardiogeni šok je vodeći uzrok kod pacijenata i dalje umiranja, vodeći uzrok umiranja i dalje kod pacijenata u intrahospitalnom mortalitetu ukoliko pacijent ima akutni infarkt miokarda. Ne treba da zaboravimo da je pre uvođenja koronarnih jedinica, pošto sam ja do skoro bila predsjednica Udruženja koronarnih jedinica Srbije, i u Srbiji ima 56 koronarnih jedinica koje su dijametralno različite. Znači, mi imamo koronarne jedinice koje nisu zadovoljavale ni standarde po principima intenzivne nege. A mi smo se dosta trudili da to lečenje ujednačimo, ali nije dovoljno kupiti monitore, obezbediti sredstva. Jako je bitno da osoblje koje tamo radi zna kada se to koristi, kako se koristi, koliko dugo je i na koji način. Incidenta kardiogenog šoka u današnje vreme kod pacijenta sa akutnim infarktom miokarda koji se leče primarnom PCI, odnosno adekvatno brzim prepoznavanjem i razvijenom STEMI mrežom po Srbiji, a posebno razvijenom u Beogradu, je značajno smanjena i obuhvata 3 do 10% pacijenata. Međutim, kardiogeni šok je povećan sa vrlo visokim povezanim morbiditetom i ukoliko imate pacijenta koji u akutnom infarktu miokarda razvio kardiogeni šok, verovatnoća je 1:1, znači 50-50, između 40 i 60, jedan će preživjeti, jedan neće, bez obzira koliko se trudite, čak i onda kad uradite sve što je trebalo. Šta je problem sa kardiogenom šokom? Kardiogenom šoku osnovni okidač je ishemija, i to je nesporno, međutim ono što dovodi do progresije stanja pacijenta, to je inflamacija, generalizovan sistemski odgovor kao u svakom šoknom stanju, vazokonstrikcija koja je u početku protektivna, ali postaje patogena i opterećenje volumena. Vi vidite ovde jedno srce, to je jedan pacijent koji je imao akutni infarkt, počinje ishemija, počinje nekroza, inflamacija, dolazi do smanjenja perfuzije svih organa, jer nemojmo zaboraviti, prve arterije koje izlaze iz aorte su koronarne arterije i one hrane srce da bi ono moglo da hrani celo telo. To često pitam studente na 3. godini medicine i verujte mi da se zbune. Kad ih pitam koje su prve grane aorte, naši studenti se zbune pa počnu da nabrajaju, a u stvari jako je bitno za život da znaju da prve grane su koronarke koje ishranjuju srce i da bi sve ostale grane mogle funkcionišu, srce mora dobro da se ishranjuje. Dakle, početak je u ishemiji i lošem snabdjevanju samog srčnog mišića koje vodi dalje do smanjene perfuzije svih drugih organa, opterećenja volumenom, pojačanom simpatičkom stimulacijom, aktivacijom RAS sistema, regigangliotenzin i do poremećenog tubuloglomerulnog odgovora, odnosno venokonstrikcije. Ono što mi jako dobro znamo, prvo merilo pogoršanja pacijenta je smanjenje satne diureze. Jako smo se trudili da uvedemo u našem hiruškom šoku sistem satne diureze, pa da to proširimo, nekako najbolje nam ide u hiruškom šoku. tu, zato što su nam tu bez laskanja anestezijolozi. Mi se dogovorimo lako sa anestezijolozima i anesteziološkim timovima, mislim, ja se dogovorim lako s njima, a jako to teško ide sa kardiolozima, sa internistima u opštoj intenzivnoj nezi. Teško se prihvataju neki standardi, ali bubreg je organ koji je najbolji marker da nešto nije u redu sa cirkulacijom. Kako pada satna diureza? I zbog toga svi koji me znaju da prvo što pitam, satna diureza raste, pada, kolika je. To je jako bitno. I još nešto ću da vam pokažem posle, to su te čuvene gasne analize. Kad neko mlađi doktora krene da čita kiseonik, krene da čita ugljen dioksid, sve moguće krene da pita, ja pitam koliki je laktat, jer mi je taj laktat najvažniji kod pacijenta u šoku. Naravno, sve to vodi padu pritiska, ono staro kad nemate ništa, nikakav monitor, onda koliko pacijent ima pritisak, koliko ima puls i da li je pacijent u šoknom stanju, do patološke vazokonstrikcije, a ono što mi možemo da vidimo to je pad kardijak indeksa ispod 2,2 litra u minuti po metru kvadratnom, ako imamo invazivni monitoring. Veliki broj ustanova nema invazivni monitoring ni u velikim gradovima, a kamoli u manjim gradovima i međutim, te gasne analize bi morale da se urade svakom pacijentu koji je u jedinici intenzivne nege. Zašto nastaje kardiogeni šok? Mi i dalje koronarne jedinice zovemo koronarne jedinice, ali sve manje je pacijenata koji u njih ulaze zbog koronarnog dešavanja, na koronarkama, akutnog infarkta miokarda, sve je veći broj pacijenata koji imaju akutno srčano popuštanje, koji dolaze zapravo u edemu pluća ili u jednoj teškoj kongestivnoj srčanoj insuficijenciji. Naravno, mi imamo pacijente koji imaju miokarditis. Da bi miokarditis napravio stanje kardiogenog šoka, to mora biti fulminantni, masivni miokarditis i to su pacijenti koji imaju lošu prognozu u startu, naravno, i pacijenti koji zahtevaju mehaničku potporu, što ćemo da vidimo. Poseban problem su pacijenti koje zadesi naprasna srčana smrt, nepoznatog razloga, jer po definiciji to je stanje koje nastupa u roku 24 sata smrtni ishod, a bez prethodnog vidnog razloga pogoršanja srčane funkcije. I upravo ti pacijenti koji ulaze kao akutni, a neki od njih mogu biti i pacijenti sa hroničnim kardiomiopatima, bilo da se radi o genski kodiranim ili nekodiranim, veliki broj pacijenata u naše koronarne jedinice ulazi kao septični pacijenti koji se ne prepoznaju da su septični. Mnogi od njih se razmatraju u deliroznom stadijumu, pa onda se ne prepozna sepsa, tako da često kada pacijent ima mentalnu konfuziju, i drago mi što su ovde kolegi hitnog prijema, ja uvek pitam kao prilično star lekar, je li ima sepsu, prvo pitanje, iako ga nisam pregledala, pošto je to za mene prvo da isključimo, lako ćemo mi da lečimo delirium. Naravno, postoje valvularni razlozi, postoje električni razlozi, određene aritmije kao što su ventrikularne oluje i tako dalje, mogu da dovedu do kardiogenog šoka, ali to je mnogo, mnogo ređe. Postoje određeni parametri koji su nam vrlo bitni kad procenujemo prirodu šoka. Zapravo, pacijent koji ulazi kao kardiogeni šok vrlo retko je čisto izolovani kardiogeni uzrok tog šoka, a vrlo često može biti i pomešan sa različitim hipovolemičnim dešavanjima, distributivni šok tipa sepse, anafilaksa ređe, neurogeni šok i malo ređe opstruktivni i disocijativni. Klinička definicija kardiogenog šoka je smanjen, kardiok output sa evidentnim dokazima tkivne hipoksije u prisustvu adekvatnog intravaskularnog volumena. To je prava definicija kardiogenog šoka. Ali kad pogledate, vidite koliko pacijenata ima izolovano kardiogeni šok, a koliko njih ima i određena preklapanja sa drugim uzrocima šoka. Ono što smo rekli, to nam je opšte, ako smo u seoskoj ambulanti, sistolni pritisak, diastolni pritisak, frekvenca, mentalni status i tu se orijentišemo, ali mi ne radimo u seoskim ambulantama, mi radimo u renomiranim institucijama i zbog toga je bitno da pacijentu, posebno u prvom kontaktu kada ulazi u akutni prijem, kod nas su hiruški prijem i internistički prijem odvojeni. Svi znamo da pacijent ulazi u hiruški prijem ukoliko nema, pacijent koji ima bol u trbuhu, koji ne mora biti hiruške prirode, vrlo brzo se on observira u hiruškom prijemu i najteži pacijenti završavaju u internističkom prijemu. Ono što je uvek bitno, na čemu ja insistiram, prijem ne služi za lečenje pacijenta, ne služi za dijagnostiku pacijenta. Pacijent mora da dobije brzu trijažu. Znači, osnovna uloga doktora u prijemu je da prepozna hitno stanje i napravi trijažu da li je doktor za prijem, hospitalizaciju ili da ide kući. Mi imamo čak i jedan nalog direktora moj, moram da kažem, koliko god je smešan, on glasi ukoliko pacijent zahteva dijagnostiku dužu od 2 sata u hitnom prijemu, primiti pacijenta u bolnicu. Zato što smo svedoci velikog zadržavanja pacijenata kod različitog multidisciplinarnog pristupa pacijentu, ali pri tome pacijent kada dođe na odeljenje, on je već izgubio mnogo vremena, a mnogi od njih su i dehidrirani. Naravno, laktat iznad 2 milimola po litru u gasnim analizama je jasni prediktor da imamo pacijenta koji je u šoku, ne treba da pričamo o stanju ekstremiteta i tako dalje, i manje, znači satna diureza koja je manja od 30 ml na čas. Kao što vidite, pacijent koji ulazi u šoknom stanju mora da dobije 3 stvari. Kao što mora da dobije farmakološku podršku, znači mora da dobije hitno lek ako je edem pluća ili neko drugo stanje, on mora da dobije ventilatornu podršku. To je jako bitno, uvek tome treba da mislimo. Ventilatorna podrška se prepisuje, ona se ne daje odokativno, ona se dozira, bira, prepisuje u skladu sa stanjem pacijenta i ono što kod nas još uvek nije razvijeno, a nadamo se da ćemo zajedno uspeti, mehaničku cirkulatornu podršku. Mehanička cirkulatorna podrška je pre svega, imamo pumpe kao što su impela, a imamo i ECMO sistem. Mi smo srećni, još jednom želim da vam se zahvalim svima što ste nam pomogli da uspemo da realizujemo prvog pacijenta, a volela bih da uspemo i više pacijenta, jer mi u ovom trenutku nismo reprezentativni centar i to ne možemo da radimo sami. Mi moramo da imamo dovoljnu propusnu moć pacijenata za godinu dana da bi bili referentni centar. Mi možemo da radimo uz podršku velikih stručnjaka kao što je profesor Dejan Marković, profesor Lađević, profesor Radmilo nam je daleko i međutim ono što je bitno da se taj problem prepozna, identifikuje i postavi na nivou države. Zašto je bitno da se napravi mreža ECMO centara, da se napravi saradnja i da se odvoje timovi za edukaciju i timovi koji će da rade i ono što je jako bitno, timovi koji će biti vrednovani od strane države, jer ako se sećate kad je počinjao STEMI program, svi koji su u njemu učestvovali imali su 4 puta veće vrednovanje rada, pa smo za ista dežurstva dobili različite plate i ja to podržavam, iako je moja plata bila 4 puta manja od mojih kolega koje su radile STEM i infarkt, imale manje pacijenta, ali mi smo došli u situaciju da STEM i mreža funkcioniše besprekorno u Srbiji. Mi moramo doći u situaciju da obučimo kadrove, da nama ECMO mreža funkcioniše dobro u Srbiji, jer smo dostigli visok nivo srpske medicine i to je nešto što je jako bitno da bi se dalje razvijeli, naši pacijenti lečili, imali šansu da prežive i ono što je bitno, nešto čime se mnogi od nas bave teorijski, a profesor Lađević jako uključen u to, a to je transplantacija od koje očekujemo puno da stane na noge u Srbiji, jer mi mnogo kasnimo za ostatkom sveta koji je oko nas i to je jedan deo s kojim najviše kasnimo, ja mislim, u srpskoj medicini. Šta je bitno? Kada sve ovo uradimo i kada pacijenta stavimo na ono što mu treba, onda radimo dijagnostiku. Najveća greška je raditi dijagnostiku, pacijenta pustiti da tone i tone dalje i onda imate neku dijagnostiku i pacijenta koga više ne možete da izvučete, jer on ima možda akutni koronarni sindrom, možda ima hipertenzivnu krizu, mehanički uzrok, pulmonarni embolizam, izvinjam se, možda ima sepsu, pa nismo odmah videli, ušao u koronarnu, u sepsi pravi ishemiju miokardal, ona je samo posledica, ona nije osnovno stanje i naravno tamponadu. Kao što imamo, klasifikacija akutne srčane slabosti je stadijum A, B, C i D, a pri tome vidite kako se daje, mi kardiolozi imamo NIHA klasifikaciju, a NIHA klasifikacija nije klasifikacija za akutnu srčanu slabost. I ja to često pričam mojim mlađim kolegama, NIHA klasifikacija u stabilnom stanju za hroničnu srčanu insuficijenciju. I ne može da izađe pacijent sa odeljenja kardiologije iz Bežanjske kose, jer ima jedna kućica koja je obeležena dok ne napiše koja je NIHA. To je nama jako bitno. Zašto nam je bitna NIHA? Nama je NIHA bitna kao ekciona frakcija. A verujte mi, još nam je važnije od ekcione frakcije, jer ta NIHA prognostički mnogo više znači od ekcione frakcije, posebno sada kada mi imamo pacijente sa HF-refom, jer misle se, a imamo pacijente i sa HF-pefom koji su vrlo teški i u teškoj srčanoj insuficijenciji, a imaju ekcionu frakciju 52. I ja pre 15 godina, kad sam počinjala da učim eho, 20, ja sam mislila da pacijent koji ima 52 ekcijonu frakciju ne može da bude u srčanoj slabosti. Može da bude i tekako u teškoj srčanoj slabosti i da se destabilizuje. Prema tome, KILIP klasifikacija, to je klasifikacija kod akutnog infarkta miokarda i zbog toga nam je važna. Ovo je slajd koji svi znamo na pamet, ali moramo da ga koristimo i znamo šta je insuficijencija kada pripremimo pacijenta i ruke su hladne i noge su hladne i sada zavisi da li je on suv ili mokar, ali znamo da to ništa ne valja. Klinički kriterijumi, već sam ih pomenula, u 2 različite studije su definisane i zbog toga nam je jako bitno da imamo monitoring koji može biti invazivni ili neinvazivni. Sad danas imamo i neinvazivne monitore koji će dati cardiac index i koji će nam dati orijentaciju. Ono što je bitno da možemo da odredimo laktate, a vidite, druga studija zahteva invazivno određivanje več pritiska, pulmonalnog več pritiska. Ovde je sve dobro dok je svetle boje. C stadijum je prelomna tačka. Počinje malo da bude tamnije, da bi D, vidite, bio problem, jer to su već teško dekompenzovani pacijenti koji zahtevaju ili multiple presore koje dajemo medikamentozne ili dodatak mehaničke cirkulacije da bi se održala perfuzija. Znači, ima od toga i gore. To je E, znači tu nam je veliki problem, laktati su preko 5, pH je ispod 7,2, to su umirući pacijenti i vrlo teško je odatle izaći. Jako je bitno da pacijent ne pređe iz C u D. Prelazak iz C u D znači prelomnu tačku ka nishodnoj liniji, tako da je ovo bitno, ono što kontrolišemo kod naših pacijenata. A gde je prelazak? Pa vidite, urin manji od 30 ml na čas i zbog toga je bitno, to je jedna naravno mera, zato je bitno staviti satnu diurezu kod tog pacijenta. Nemamo invazivni monitoring, ok, radit ćemo satnu diurezu, radit ćemo standardni monitoring, mada moram da kažem, mi imamo invazivni monitoring i to radimo. Znači, cardiac output je jedna varijabla koja zavisi od preloada, afterloada, kontraktilnosti miokarda i srčane frekvencije. Znači, mnoge parametre možemo menjamo. U suštini cardiac outputa je čuveni Frank Sterlingov zakon. Znači, kardiolog ne sme previše, mora da da diuretik, ako je on dekompenzovan. Morate jako da pazite kako dalje ide, nećete ga vi odmah uvesti u problem. Ali ako budete vrlo agresivni s diuretikom, poremetit ćete tu diurezu, taj bubreg ćete skroz raštimovati i napraviti, ako on uđe u depleciju volumena, mi smo ušli u negiranje Frank Sterlingovog zakona. Mi kad nemamo više Frank Sterlingov zakon, mogućnost da razvučemo levu komoru volumenom, mi nemamo mogućnost ni da je kontrakujemo. Zato je caka u akutnom infarktu desne komore prva terapija, dodaj odmah tečnost. Hitno dodaj 2 litra tečnosti, ako hoćeš da ti pacijent ostane živ. A on se guši, on ima i popuštanje leve komore, ne ti dodaj, jer nećeš moći da ga vratiš u cirkulaciju i to je čuvena priča o Frank Sterlingovom zakonu i o tome, zato je bitno znati pacijentu da li dodajemo ili oduzimamo tečnost. Ja kad sam bila mlad kardiolog, uđem u hiruški šok, pacijent mi se guši, normalno ja prvo se uhvatim za lasik, hiruzi su bili očajni. Oni su se stalno plašili pucanja anastomoze, da se ne presuši pacijent. A mnoge studije su pokazale kada se pacijent uđe normalno u kongestivnu srčanu insuficijenciju, anastomoza će i tekako da pukne, jer on ima jako veliki problem sa venskom kongestijom i to ne može da zaraste. Kada imamo akutni infarkt miokarda ili srčanu dekompenzaciju, onda imamo povećan pritisak, end-diastolni pritisak leve komore i dalje idemo u smanjen cardiac output i ono što je novu i ponovo sve jaču i jaču smanjenje koronarne perfuzije. Mi ulazimo zapravo u circulus viciosus, odnosno u ovu jednu spiralu koja će nas dovesti na kraju do progresivne miokardne disfunkcije i multiorganskog otkazivanja kod našeg pacijenta. Zbog toga je jako bitno to prepoznamo i da damo dobre preparate. Nešto o invazivnom monitoringu. Dakle, ne postoji ni jedna randomizovana studija koja je dokazala da je invazivni monitoring pokazao da pacijenti više preživljavaju. Ali činjenica da mi imamo intenzivne nege i da mi pratimo te pacijente i da pacijenti preživljavaju u intenzivnim negama mnogo bolje nego van intenzivnih nega je dovoljna činjenica da znamo da pacijentima to treba i da to treba zdravstvenom sistemu. Ono što ja uvek naglasim i mi smo imali sad skoro u želji da pomognem kolegama sa odeljenja anestezije, hirurgije i drugih internističkih odeljenja da bolje leče pacijente, mi smo doneli obavezu planiranja, ali ona je zakonom regulisana, samo što se nije sprovodila i nigde se ne sprovodi poluintenzivna nega. Dakle, pacijent moraju da se leče na odeljenjima i mislim da je profesor Radmilo rekao za neurologiju, znači neurologija bi morala da ima svoju intenzivnu negu koju bi morali da vode neurolozi. Dolazimo do velikog pitanja. Zašto internisti, zašto neurolozi, zašto psihijatri ne žele da budu intenzivisti? Zato što je to jako teško i zahteva veliko znanje i dodatno znanje, pored onih specijalizacija, onih znanja koje mi lečimo, a zapravo izuzetno je bitno da mi produkujemo takve kadrove i da svako odeljenje ima svoju poluintenzivnu negu i da tek u konsultaciji sa anesteziologom može taj pacijent da se prevede u intenzivnu negu. Tako je kod nas i anesteziolozi naši znaju da dok oni se ne slože, pacijent se neće prevesti u intenzivnu negu, jer ne može niko da im prevodi na njihovo odeljenje, ali isto tako oni imaju obavezu da siđu i da pogledaju pacijenta. O ovome sve znate, ne bih dalje pričala da venski pritisak, saturacija kiseonika, normalno 60 do 70% i u kardiogenom šoku pad u venskoj saturaciji označava u stvari znake kardiogene deterijacije. Arterijska linija je nešto što je izuzetno bitno, anesteziolozima je to blisko, ali internistima koji rade u intenzivnoj nezi to nije blisko. I mnogi se libe, posebno kardiolozi, ne vole anesteziološku liniju i tako dalje. Ja sam, arterijsku liniju, izvinjavam se, ja sam pobornik da je imam uvek i da pacijenta mogu da iskontrolišem i da dobijem ovaj jedan sistem koji mi koristimo. Meni je pomogao da shvatim ovaj sistem jedan anesteziolog, dr. Sava Nenić, koji je otišao i sad je u Orlandu. I ja sam ovaj sistem zavoljela, a verujem i moji anesteziolozi, jer je izuzetno teško odrediti kod kardiološkog pacijenta sa dodatnim elementima šoka, u kom se nalazi, a najčešće u sklopu kardiološkog i septičnog šoka koliko tečnosti treba da mu date. Drugi način da ne koristite ovaj sistem, zlatni standard je Svan-Gansov kateter. Svan-Gansov kateter mora baš da bude ozbiljan, da kažem, doktor. Niz otvaramo put ulaska bacilima, kojih imamo puno i sa kojima se borimo na sve moguće načine. Antibioticima, kad dođemo da se borimo antibioticima, onda smo se loše borili. Onda smo tu stali na poslednju ivicu i baš sam pričala s profesorom Mlađevićem, mi imamo onaj robot rotirajući i upotrebom tog agresivnog robota mi smo smanjili broj intrahospitalnih infekcija, posebno u hiruškim salama i u šoku. Imamo celu proceduru i tu su naše medicinske sestre koje vode šok, glavne sestre, jako uporne i odgovorne i strašno dobro vode i malo smo smanjili taj broj koji smo imali sa klicama, ali opet taj acinetobakter, kao lekar laik, nisam anesteziolog, više puta sam videla i pričala smo o tome s profesorom Todorovićem, on često nije uzrok smrtnog ishoda, ali ta klica odlično prepoznaje pacijente koji tonu. Ona prosto, kad vidite nalaz acinetobaktera, to je za mene prognostički nalaz. Evo, to bih baš voljela da vas pitam, ja se uvek plašim kad vidim acinetobakter, posebno kad kažu u nedovoljnom broju kolonizira, a pacijent ima milion drugih razloga zašto tone. Zašto mi je bitno da imam ove parametre u invazivnom monitoringu? Zato što je potpuno različita terapija. Ako je hipovolemični šok, ako je kardiogeni šok ili distributivni šok, mi najčešće vidimo septični, a postoje i neurogeni, to je vrsta distributivnog šoka. Pogledajte koliko se razlikuje terapija. Ne možemo svima davati isto, većinu stvari i dajemo, ali je bitno šta predominantno dajemo, i zbog toga nam je jako bitno da odredimo šta je preload, šta je afterload. Preload je već pritisak, afterload je sistemska rezistencija i na osnovu toga mi znamo šta je veći problem kod našeg pacijenta. Da li je on u problemu zato što ima nizak preload ili zato što ima veliki afterload. Kateterizacija desnog srca je jako popularna kad čitate radove, međutim, vidite, kateterizacija desnog srca je jedna invazivna procedura i ja kao kardiolog mogu da iznesem svoje mišljenje da ne treba raditi kod svakog pacijenta, treba raditi isključivo kod pacijenata koji su posebno izabrani, imaju razlog zašto se rade. Međutim, ako ne radimo ništa od tih parametara, a to su ovi pacijenti, koji su plavi, pogledajte koliko imaju veliki mortalitet. Što je teži pacijent i ne uzmete mu ništa od parametra da vam pomogne u doziranju vašeg leka i da imate kontinuirani monitoring kako on deluje na doziranje leka koji dajemo, pacijent ima veći mortalitet. Dakle, i oni koji dobiju invazivni monitoring kompletno, sa kompletnom procenom pritisaka i plućne cirkulacije u desnoj komori, neće oni svi preživeti, ali je razlika u preživljavanju ekstremno bolja kod onih koji imaju monitoring. I zato je bitno da imamo monitoring. Što manje agresivan, ok, ali moramo imati neki invazivni monitoring sa cardiac outputom i sa sistemskim otporom. Evo je kateterizacija desnog srca. Da bi ta kateterizacija mogla da se tumači, ona mora da bude takozvano nulovana na nivou desne pretkomore, odnosno ona mora biti urađena po standardima. Šta to znači? Onaj koji radi, interventni kardiolog kod nas, ali može i anesteziolog da je uradi, i internista, znači svi oni koji su prošli obuku, nama je puno pomogao Institut za kardiovaskularne bolesti Sremska Kamenica, on mora da dobije ovu krivu. Ako doktor nema ovu krivu, da ona ovako izgleda sa svim ovim talasima, onda ona nije dobro urađena, odnosno nije izvršeno nulovanje na nivou desne pretkomore, kako mi to kažemo, i možemo da dobijemo pogrešan rezultat. I onda srljamo dalje u propast. Naravno, nije to jednostavno, postoje tu komplikacije, Znači, otvaramo novi put, odmah mesto infekcije, da ne pričamo od ovim, vidite, teškim komplikacijama, prema toraks, pa povreda arterije, pa infekcija, pa stavite jednu vensku kanilu, pa vam je to teško da se stavi, boli pacijenta i pravimo problem, a ne ovakvu proceduru da napravi, ali zbog toga mi se trudimo da napravimo invazivni monitoring i uvek je pitanje što manje invazivno raditi. Sada, ovo je jedan algoritam o šoknom stanju. Mislim, prepoznavanje šoka bi trebalo i lečenje da bude na nivou hitne pomoći. Mi sa kolegama u hitnoj pomoći imamo izvanrednu saradnju u prepoznavanju i lečenju infarkata, ali se često ovi pacijenti koji su u šoknom stanju ne prepoznaju. I pošto je Udruženje kardiologa činilo velike napore da izvrši edukaciju hitnoj pomoći, mislim da bi i adekvatna anesteziološka i intenzivistička udruženja trebala da pozovu hitnu pomoć oko te edukacije, jer ove pacijente mi gubimo. Ovo su preporuke Evropskog udruženja kardiološkog, da ukoliko imamo pacijenta sa akutnim infarktom miokarda, odnosno akutnim koronarnim sindromom i mehaničkim komplikacijama, razmotrimo da li ćemo raditi i primarnu PCI, a onda ukoliko imamo popuštanje leve komore, da razmotrimo da li nam treba klasa 2A, mehanička cirkulatorna potpora, i vidjet ćete da je to klasa 2A, klasa 2B su inotropi i vazopresori. Mi još uvek nismo u klasi 2A, mi smo i dalje u klasi 2B. Mi tako lečimo našeg pacijenta. Znači, ono što se manje savjetuje, mehaničku cirkulatornu potporu mi još uvek ne krećemo da radimo, i to je ono što bih ja voljela da mi svi zajedno kao struka pomognemo našim pacijentima, jer jedino struka može da nametne neke nove standarde da se usvoje, ali tu moramo svi da budemo složni. Ukoliko, veoma smo srećni zbog CRRT, odnosno renal replacement therapy, koja se kod nas provodi, težinu tog posla i dalje vode anestezijolozi, trebalo bi da vode svi doktori koji rade u intenzivnim negama i naravno medicinske sestre i tehničari. Dakle, to je ono što nam predstoji, jedna malo veća edukacija. Mi smo kuća koja nema nefrologiju i moram da kažem da sam vrlo ponosna na svoje koleginice i kolege koji su mnogo života spasili, sigurno i u vašim bolnicama. Mi nemamo nefrologa, mi imamo konsultanta iz Zemunske bolnice, jednog divnog kolegu, Rođu Markovića, koji svaki put dođe i pomogne nam, ali zapravo silni životi su spašeni kod ovih pacijenata zalaganjem naših timova. Ovo je jedan, da kažem, algoritam kako bi trebali u odnosu na odnose između plućnog pritiska i sistemskoj rezistencije da doziramo lekove. O tome ne bih puno pričala, moram da iznesem svoje impresije na Kongresu internista u Vrnjačkoj banji. Koleginica koja je iz tima profesora Radmila Jankovića, Milena Stojanović, održala je izvanredno predavanje i moram da kažem da sam bila iznenađena koliko su internisti voleli da to čuju i kako je sala bila. To je bila jedna od najposećenijih sesija i naše kolege su imali divna predavanja i posle sam čula jako dobre komentare i to mi je posebno drago. Pričali smo o impeli, a ovo je u stvari ECMO i to je ono što nas sve čeka da razvijamo zajedno. Naravno, postoji intraaortna balon pumpa, ona je nekad bila broj 1, sada se koristi samo u akutnom infarktu kao suport. Ono što bežanijsku kosu konkretno čeka, to je ECMO support kod pacijenata rizičnih za infarkt. Ono što bih htela da kažem, vreme u medicini je uvek život. Svaki izgubljeni trenutak ne može da se nadoknadi i zbog toga je za mene najvažnije što smo mi uspeli da pacijenta ako u roku od 2 sata ne možemo da dijagnostikamo primimo, jer smo pokazali i ti pacijenti koji se primaju, to su najčešće bili pacijenti koji su bili u vrlo teškom stanju ili kasnije ulazili u teško stanje. Ali ono što je za nas bitno, da pacijent onog trenutka kad dođe u jedinicu intenzivne nege ne čeka lek, ne čeka ventilaciju i ne čeka mehaničku potporu ako je to neophodno. On sad čeka i moramo, setite se iz klase 2B gde dajemo inotrope, da pređemo u klasu 2A gde preporuke jasno kažu mehanička potpora jer pacijenti bolje preživljavaju. Hvala vam puno.
Hvala profesorki Zdravković na izuzetnom predavanju. Ja bih zamolio publiku da vidim da li ima neko pitanje iz publike za profesorku. Ili je sve bilo izuzetno lepo. Evo, izvolite.
Nemam pitanje, ali bih pohvalila predavanje fantastično. Naravno, i ovo prethodno je bilo dobro, ali ovde nema veće. Toliko je važna tema, toliko je zaista života izgubljeno, samo zbog niskog pritiska ili tako neke stvari, tako da značaj teme je fantastičan. Tako da pohvaljujem i mnogo je važna tema i mnogo je korisno to što ste nam napisali.
Hvala vam.
Zahvaljujem koleginici. Baš mi je drago da vas vidim. Mi se znamo iz viđenja i znam koliko ste često gost i zajedno smo slušale i bili na konferencijama i hvala vam što ste došli. Zahvaljujem vam se na divnom komentaru.
Evo, izvolite.
Predavanje su bilo sjajno. A osim toga, to smo i očekivali, zato smo tu. I nije problem u medicinskom znanju. Mi imamo jedan drugi, jako veliki problem. Danas je organizaciona šema brak. Urgentna je multidisciplinarna. I tako se mora posmatrati. I tako se mora organizovati. Ljudi koji su donosioci odluka su izvan urgentnih stanja. Prema tome, jedan ozbiljan nacionalni tim mora da se bavi ne samo medicinom, nego i organizacijom. To je jedina garancija da svi pacijenti na teritoriji Republike Srbije mogu u dato vreme sa datim kliničkim manifestacijama dobiju pravi tretman. I na taj način se samo isključuje diskriminacija po osnovu dostupnosti zdravstvenog sistema.
Hvala vam, koleginice, na komentaru. Upravo menadžment u zdravstvu je prava stvar, kao i u svakom poslu čiji prava organizacija dovodi do uspeha, a kao što ste rekli, znanje nam ne manjka. Da li imamo još neko pitanje?
Nisam rekla, moram da kažem, ovo što ste rekli 2 sata, pa ne više da se ljudi se u urgentnom centru cimaju ceo dan i na kraju, kad je primi, gotovo nema, kradan u konu. Tako da, to vam je fantastična ideja i to pozdravljam, tako da... Hvala.
Dobro, evo da zaključimo sesiju. Najlepše od svega je što smo se mi ovde skupili, iako je petak. Ovde sede ljudi koji su ceo život posvetili medicini. Kao koleginica koju ja znam od prvih dana kad sam krenula na kardiološke sekcije, jako mi je drago, doktorka, što ste ovde s nama. I ljudi koji su sad na specijalizaciji, koji treba tek da počnu svoje samostalne odluke, da dežuraju, da donose odluke. Ja sam lično najviše naučila o kardiologiji kad sam počela da radim u koronarnoj jedinici. I sve ono što sam učila u knjigama mnogo mi je pomoglo, ali praksa i taj kontakt s pacijentom i učenje od starijih kolega je izuzetno bitno. I učenje kroz multidisciplinarni tim i pravljanje tima i odlični međuljudski odnosi, jer mi najveći deo svog života zapravo ne provodimo sa svojom porodicom. Svi mi najveći deo svog života provodimo na radnom mestu, kad preračunate ono što ne spavamo, jer tada nismo svesni i tako dalje. Upravo ova sesija je i bila tema da struka uvek može da da dodatnu vrednost, da nešto ide. Naravno, znanje i organizacija moraju da idu zajedno i zbog toga ja moram još jednom da se zahvalim ovim divnim ljudima koji su danas u ovoj sesiji predavači, a da kažem da ja njih nisam znala pre korone, znala sam njihova velika imena, kakvi su to veliki profesori, veliki stručnjaci, oni su ispali veliki kolege i veliki ljudi u koroni, jer su u trenutku kad je Bežanijska kosa dobila rok manji od 24 sata, da je iz non-covid bolnice sa 247 pacijenata non-covid pređu u covid bolnicu, oni došli kod mene, iako sam ja bila uplašena, ali smo mi svi zajedno ostali, masa nas je ostalo da se pripremamo, da selimo pacijente i onda sam dobila jednu posetu, potpuno spontanu i veliku podršku svim našim doktorima, sestrama u šoku, u jedinici intenzivne nege i ono što je najvažnije tim pacijentima koji su ušli na Bežanijsku kosu. I upravo ta kolegijalnost je nešto što pored znanja, kolegijalnost i humanost izdvaja dobre od loših lekara i medicinskih sestara. Izuzetno je bitna edukacija i medicinskih sestara i tehničara i taj timski rad i kontinuirano i zbog toga hvala vam još jednom što ste vaše popodne u petak posvetili ovoj divnoj temi. Mnogo vas pozdravljam.
Thank you.